timu ya kuboresha utendakazi. That is quality improvement teams. The structures I've talked about, so that they can bring these ideas to impact, and a number of counties have really improved on that. Thank you very much.
Thank you, Dr. Kandia, for a very informative speech and also very good use of time. Please keep your questions for Dr. Kandia. Please note them down so that we can have them at the end of the session. We have about 6 presenters who we are going to invite to speak to us or to present their work. So, and I'm going to call them to come and sit here, and then each one of them will then come to present. So please, if we can have Walter Kiptrim, Grace Mwangi coming up here, Priscilla Kashero, Moses Karema, Masiatieno, and Caroline Getza. And then we can have Walter Kiptrim, please. When you come in, you have about 8 minutes to present. We will be keeping time very closely, and then I said we will take questions at the end of your presentation. 8 minutes to present. Please come, tell us your name and your institution, and go straight to your presentation. All right? Okay. Walter, take it away.
Thank you. Good morning. At least with extra effort. Good morning. Yes, my name is Walter Kiptrim. I work with USAID Stawisha Pwani as the CKY specialist, supporting all the 4 counties that we work with, from Kilifi, Kwale, Mombasa, and Taita Taveta. In our session today, I'll be presenting on digitally empowered mentorship, where we are transforming the digital documentation of QI for sustainability. And this is in tandem with the theme of sustaining universal health coverage through innovation, research, and best practice. This is the outline of the presentation, and I hope you will enjoy, work with me. You all have attested in this forum that digitization is sweeping all sectors, and health is not spared. And quality is also not left behind. This has been happening. Tools, systems are happening on digitization, and therefore strengthening mentorship towards this is critical. And what is happening is we have the KQMH, as has been alluded earlier, and Kenya is in advanced stages to make sure that this is digitally implemented across counties and facilities, and also partners have been doing so in similar occasion. You can see here we have the KQMH, and we have also one that is implemented by partners. And what's happening is, yes, it's being implemented, but the pace at which it is being implemented is quite slow. So the reason why we have this problem, that Stawisha Bwana has been implementing the same, and so far we have reached 182 facilities across the 4 counties. And what's happening is, as much as we've done really to start with, cutting across the counties, not all of them are there, but the challenge is that improvement is coming up slowly, but in a slow way. So what is the aim? To enhance peer mentorship, to catalyze adoption and documentation. Remember, in quality, whatever is not documented is not done. And therefore, what is the objective? We want to assess how is digitization going to be improved through county-led mentorship and peer support. And this is what it looks like. Let's come closer. Still part of the baseline. Kilifi County has 41 facilities that have documented. You can see across the sub-counties, and in that regard, these are the number of projects, not facilities. The number of facilities, you'll get it when you go deeper to the platform. Now, this is, we gave credentials to utilizing the dashboard. And after that, we did virtual sensitization, navigating the platform as well, and then virtual monthly reviews. Peers were identified across from the sub-county to the facilities, and then now they were given updates every week to see how they are performing, how they are documenting, screenshot of the platform, and they are able to see how they are performing. Best practices. This is the fourth of the 4 counties we've done this year, and it's one of those journeys that we've come this far together, and we celebrate. Therefore, as of September 2025, we got 1,079 CQI projects, and what happened is that we compared now, how are these projects distributed? Is it by chance or because of some effort? Mentorship is the game changer. And out of this is how we performed. Across the counties, Kilifi County is number 2. Second following Taita Taveta, and then we have Mombasa and Kwale. Achieving a target that was set 800 projects by end of the year, we got 1079, and the sprint that took us there is the peer-led mentorship. Now, these are what happened and what we did, and what is important is, as much as this has happened, mentorship structures have been in place, collaboration of sub-county teams, the QI focal persons and the SCASCOs that we are working with, clearly showed this effort. And what's happening is we were able to go beyond HIV program, and we have an almost 50-50 inclusion of CQI projects. And this is particularly because of the collaboration of the teams beyond the HIV program at facility level. Let me conclude by saying, because of the platform, because of the mentors, the structured approach of mentorship has led significant enhancement of documentation. And this is best so because we're able to update the teams, see how they are performing, and give them a target so that a level 2 facility is not given 20 projects, but at least the 2 or 3 is enough. Level 3, 5. Level 4, 10. And in this regard, they were able to achieve. Digital platforms is the way to go because it opens transparency and shared learning. And therefore, these findings affirm the role of mentorship play in improving digitization, not only in QI, but across. 2 recommendations. Counties is encouraged to adopt the peer-led mentorship across, including transition. And number 2, hold annual best practices to reward, recognize, motivate those who are doing a good job. Thank you very much.
One minute saved, so we might donate a minute to the next presenter. Grace Mwangi.
Good morning. My name is Grace Mwangi from the Department of Health, and I'm going to present our work, a study entitled Maternal and Neonatal Outcomes Among Obstetric Referrals at Mali Sub-County Hospital, and I'm a co-author together with Dora Chorogo, Mary Kariuki, and Emily Karisa. So globally, maternal and neonatal mortality still remains high, and particularly in the low and middle income countries. And in 2020, the global maternal mortality was estimated to be 223 deaths per 1,000 live births. And most of it is in the sub-Saharan Africa, that is about 70%. And our current maternal mortality ratio is 355 per 1,000 live births. And in Kilifi County, it's much higher at 532. Emergency obstetric and neonatal care is one of the key strategies to be able to reduce the maternal and neonatal morbidity and mortality. So the Kenya Health Sector Referral Implementation Guidelines define referral as a structured process which involves either transfer of clients, specimens, services, or even information across the various levels of healthcare. And an effective referral system is the one that minimizes delays, at the same time supports quality of care during the emergencies. So Mali Sub-County Hospital receives multiple of referrals. Within the sub-county, within from the neighboring sub-counties and also from the neighboring counties. And despite the many strategies that have been put in place, the mortalities have been high. And as a result of that, we came up with this idea of carrying out this study so that we can be able to know whether the referrals are the cause of the high mortality. So our main objective was to assess and analyze the outcomes of obstetric referrals at Marie Sub-County Hospital, particularly to determine the maternal and neonatal mortality rates, at the same time explore the contributing factors to those outcomes. We employed a retrospective design study, and we reviewed all the obstetric referrals that were admitted in Marie Sub-County Hospital within a period of 6 months, January to June 2025. And we really depended on the data that was available in the hospital records, and therefore any missing or incomplete entries would have introduced bias to this study. Additionally, the 6 months that we conducted the study might not be enough to really show the pattern of the referrals in the sub-county. So we looked at various variables, and one of them is age, and most of the mothers, our study population was 336 mothers, and most of the mothers were between the age of 20 to 29, accounting to 59%. Looking at the marital status, we had a gap of documentation of 18%, but many of them were married, that is 74%. For the occupation, 86% of the occupation was not indicated, but those who are housewives took the lead with 7%. For education level, most of them had primarily for education, though we had a gap of 59% where education was not documented. We also looked at the sub-county of residence for these mothers, and most of them were residing from Magarini sub-county, followed by Malit sub-county, then Kilifi North. For the ANC, 87% of the mothers were able to attend ANC. For the 13% remaining, it was never indicated whether they attended ANC or not. For the number of visits, most of them were able to achieve 4 to 5 visits, accounting to 37%. We also had 1% who were able to attain the 8 contacts according to the WHO. Most of the mothers were admitted during the intrapartum period, accounting to 82%, and most of the weeks accounting to 60%. We also looked at the status of the fetus on admission, and most of the mothers had viable fetus on admission, accounting to 89%. For the parity, most of them were first-time mothers, accounting 42%, followed by low parity of 1 to 3 at 41%. Most of the mothers did not encounter any complications, 80% of them, but for those that had complications, the hemorrhages took lead with the PPH at 12% and APH at 4%. We also looked at what were the recommendations put in place by the service providers, and 29% of them say that they were referring for further management, followed by those that were referred for cesarean section at 25%. Then we also looked at what was the diagnosis that was made on admission, and most of the mothers had a diagnosis of prolonged labor, that is 25%, followed by fetal compromise at 20%. We also looked at the state of the mothers on admission, and 95% of them had, they were stable on admission, while we had 1% who admitted in critical condition. For the time that it was taken to initiate the interventions, we had a gap of 59% where time was not indicated, but those that were indicated, interventions were initiated within 30 minutes, accounting to 26%. Then most of the mothers used ambulance as a mode of transportation, accounting to 85%. Then we also looked at the facilities where those mothers were referred from, and most of the facilities were from Magarini, accounting to 52%, followed by Malit sub-county, 35%, and Kilifi North, 11%. We also looked at the delivery status, and 98% of the mothers delivered, and the highest mode of, the leading mode of delivery was cesarean section at 49%, followed by SVD at 45%. Now for the outcome, the 99 mothers were alive, while 91% of the babies were alive. We also evaluated to know how the babies were, the condition of the babies upon delivery, and 82% of the babies had a good score of above 7, while we had 4% who had severe asphyxia and 14% who had mild asphyxia. And now the causes of the poor outcomes for the mothers, we had 3 mothers who died, and one of the mothers died due to delay in surgery, also developed PPH and also shortage of blood products. This is a mother who was admitted with active bleeding with the APH, and decision for theater was made, for surgery was made. However, the facility has one theater which was occupied by a surgical patient by that time, and they had to wait for the surgical case to be cleared. The other mother died due to anesthetic complication, and the last one died due to hyperomic shock due to PPH. For the outcome of the babies, we had 12 macerated stillbirths, we had 11 fresh stillbirths, then we had 2 babies die immediately after delivery due to severe asphyxia. So maternal outcomes generally was good with a survival rate of 99%, although there were 3 preventable maternal mortalities that occurred. And those deaths were related to the delay in surgery, PPH, and also the anesthetic complication. Neonatal outcomes were slightly low at 91%, and we had stillbirths accounting to 7%, then early neonatal deaths accounting to 4% of the total neonates during that period of study. Then we had 18% of the infants who developed birth asphyxia. And in conclusion, the study shows that although maternal survival among the referrals was high, neonatal outcomes were slightly low, and the leading maternal complications were hemorrhage, hypertensive disorders, and labor complications, reflecting the global trends of maternal morbidity and mortality. So we are recommending strengthening of ANC uptake, improving referral communication for timely and also complete information. We are also recommending strengthening of WIMO capacity with skills, equipment for faster response, improving newborn care through effective resuscitation and monitoring, and lastly, boosting the community to facilitate linkage for timely care seeking and also for seamless referrals. Thank you.
Thank you to our first 2 presenters and the keynote speaker. I'd like to invite Mr. Mwamuye to introduce the next 3 presenters. Thank you.
Okay, thank you very much. My name is Mr. Mwamuye. I will be joining with you to introduce 3 of the coming participants. So we would like to welcome Mr. Moses to take it away. Moses, please stand up, take it away.
Thank you. Good morning. Good morning. Good. My name is Moses Karema, Director ICT, Kilifi County. I'd like to invite you to
Okay, we have some change to make. Priscilla has not yet arrived, so we will push the presentation for Priscilla at the end of the incoming 3. So at this juncture, maybe we call it the presentation for Mr. Karema. I can see it's already presented there. Thank you.
Thank you, Dr. Mine is very simple. It's just to convince this room for some technology here. Okay, this is a research proposal. And it's about blockchain. We're proposing a blockchain framework to control drug theft, case study of Kilifi. We have several cases in Kilifi that we either have drugs, either they're lost or they're not there. And in many cases, either those drugs we're not sure what number of drugs we have or what stock do we have. So what's the background on this? What is blockchain? Decentralized digital ledger transaction that it cannot be altered at any given time. The key features is having transparency, security, and immutable of these transactions or these records of the records. And also, the key thing in the blockchain is a smart contract. When you hear about blockchain, we always think about Bitcoin. Yes. But what are the objectives of this research? The objective of this research is to identify what are the key factors that are influencing or that are leading to loss of not having drugs in our pharmaceutical supply chain. Then what are the suitable protocols that you can use to be able to handle this in the blockchain technology? Then the other objective is to develop a framework that is going to be able to have drug transferability in the pharmaceutical chain. and also to validate that framework. So what's the problem statement? The absence of a decentralized proof or tamper-proof audit trail that could be leading to when you talk about loss. Sometimes, yes, we say loss, but maybe those drugs are there and we are not sure whether they're there. So we are not able to see what we have in our stock. Absence of decentralized tamper-proof from the warehouse, from the on transit, lack of manual. We use manual proof for delivery, and manual update of the drug at the drugstore. So we checked around what is the current practice of how the health product technologies are being the logistic in the county. Yes, the drugs are being delivered at the county at the county main warehouse by KEMSA. Then they're being taken to the drugstore, where an bin card is being updated. Then to the pharmacy, still a bin card manual being updated, and they dispense at the end user. So most of these transactions are manual. This system, what we really like, we like a real-time monitoring. We are not able manual. We keep manual. We have manual records, and these records are also not integrated. So, what's the research question? What are the key factors leading to this loss of drugs in the pharmaceutical chain? Which block protocol can we use to do this? And how are we going to blockchain-based framework? How are we going to develop that the block-based blockchain-based framework? And how are we going to validate it? Significance of this research, we look around what blockchain structure overview. We talk about distributed ledger architecture. These are records of being placed across several nodes, distributed across the network on the nodes, and so you cannot alter them. Talk about data utility, node distribution network, and consensus in this mechanism. The proposed blockchain here will be data collection, decentralizing the ledger, and also managing the user access. For this county, what would be the specific? Have a drug tracking requirement system, have a security infrastructure, and also have an integration of stakeholders. Proposed phase initial assessment, deployment pilot, stakeholders training, and full deployment schedule. What are the benefits? Of course, improved accountability, enhanced security, and above all, a good promotion of good management of healthcare system. Challenges that we tend to have, one will be technological adoption. We're going to have capacity and as well stakeholders and even the political will on this. Integration of existing products and also regulatory compliance. Conclusion, this research is going to address the research questions that we've discussed, and also the research will inform basis for further research solving drug counterfeit, data protection, and more so, this research is going to be a pilot project, not only for Kilifi, but also for the Kenya, and also build a knowledge base to the research. Thank you. We say everything will be tokenized, connected to blockchain one day. So we need to get there. We need to be able to, instead of saying they're not drugs, the drugs might be there, but we may not be able to say where are they. We are not able to. We are not able to make right decision. We are not able to have a good decision in a good decision in the healthcare management system. Thank you.
Asante sana. Basi tumtokenize na makofi, mpatieni makofi mazuri. Asante sana. Sasa tutaweza kusonga mbele na tutaweza kumwamsha Masi Atieno ili aweze kutupatia kile ambacho amekipanga. Masi, chukua na uanguke nayo.
Good morning. So my name is Dr. Masi Atieno. I am a pharmacist by training, which will explain my first love, medication. And my second love is mental health and neurological disorders, which will explain my talk. I hope I can figure this out. Okay, good. So I'm going to present part of my PhD work. These are very initial findings, so take it with a pinch of salt. Trial, and they don't know what's happening. So the first point of care, especially in our setting in Kilifi, would be a traditional health practitioner. So they probably go to a mganga, tell them what's happening, and see if they might have a solution for them. If the mganga is not successful, then now they probably come to your health facility. Maybe they go to Kiwandani dispensary for Dr. Rebecca to find out what's happening to them. So in Africa, we have people who will continue to have these seizures at home, never actually going to either it's the mganga or even the health facility. And this is what we call the diagnostic gap. Then we have what we call now the primary, or rather the general therapeutic gap. So let's say Kadzo is having seizures, they've gone to the mganga, they've been sent to Kiwandani dispensary, and now they're being told you actually have epilepsy. What happens then? Kadzo will be started on treatment. But what if Kadzo arrives there and Dr. Rebecca says there's no medication? So then now Kadzo knows they have epilepsy, but now she is not actually on treatment, and this is what we are calling the primary therapeutic gap. We'll move on. Kadzo has actually found medication at Kiwandani dispensary, but then Kadzo goes home, takes the medication for maybe a month, realizes the seizures have disappeared, and Kadzo believes that now she is healed. Kadzo stops taking the medication. This is what we're calling the adherence gap, and this is what my talk will mostly focus on. Now, in countries outside of Africa, there's something we do with epilepsy that's opposed to just giving medication. So there are certain kinds of epilepsy where you could just do a surgery and the seizures are cured. This is not readily available, but in those countries, for those people who know that their epilepsy would be cured by surgery but are not able to have the surgery, this is what we'd call the advanced gap. So the objectives of my study were basically to find out whether actually sending these SMSs would improve adherence. But then apart from adherence, what actually matters to the patient is whether their seizures are actually controlled, whether there's an improvement in their quality of life, whether there's an improvement in their level of disability, and their general beliefs towards their illness. My methods, I used a single-blinded randomized control trial. This was done here in Kilifi County, and it was also done in Nairobi in partnership with APHRC. In Kilifi, I targeted about 1,200 people, and most of my findings from here on will focus on Kilifi, as this is the data that I have at the moment. If you look to the, I believe that's the right for you, I am showing you like a snapshot of what the dashboard looked like. So this is sort of the dashboard we're using to send out messages. And these were also customized. So you could get it in Kiswahili, you could get it in Giriama, you could get a phone call instead of a text. And then we also had people who would get the messages either in the morning only, in the morning and in the evening, depending on what you wanted and what you preferred. We had 4 arms in our trial. So we had the people who were getting only text messages. We had an arm that were getting a text and then followed up shortly with a call only, and then we had a control arm. So just briefly on the results, again, I repeat, this is an initial analysis. I'm still doing the work. But when you look at the top panel, you can clearly see that there's a change, especially in self-reported non-adherence. So you see the graphs are sort of getting smaller as you move for the first bars. Then the second one, I was now looking at drug levels. So as much as someone reports to me that they're taking their medication, what do they actually have in their blood? Here, things just get messy. So you see the graphs are getting bigger and shorter all over. So it seems like even if your patient tells you they're taking their medication, they might actually not. Now the bottom panel looks a little complex, but the idea here was just to let you know whether there was actually a change over time in adherence. And again, anything that is less than 1, so anything that's on the left shows you that there's a change, anything on the right is not. And the findings are a little mixed. Again, I talked about the outcomes that are important to the patient. So whether their seizures are reducing, whether their quality of life is improving. So clearly, for their seizures, the difference is huge. You can see what they started with at baseline, nearly 20-something%, I believe. But then it sort of just quickly declines all the way up to the final time point, which was about a year of follow-up. Interesting to note here is that this change was across whichever arm. It didn't matter whether you were getting the reminders or the control. Your seizure frequency decreased. For poor quality of life, we don't see a difference, and for the other outcomes as well, it's there, but it's not significant. Again, this is just to elaborate whether there was a difference before and after. And as you can see, the findings are all over the place. So I'm hoping with more data, this might make a bit more sense. When I just quickly looked at what might then be affecting this adherence, so clearly I'm sending reminders, but there's no difference. So generally, anyone who's taking more than one medication appeared to have better adherence. This is unusual, because you usually think that if you give someone many medications to take, then they'll get bored or get annoyed. But here we found that actually anyone who's on more than one would actually have better adherence. But this is a factor of carbamazepine. So carbamazepine was the drug that was most available and is generally most available in our facilities. So then naturally, if this is available, they're likely to take it. So generally, as I conclude, we did see some improvement, especially in the seizure frequency, but I said this was across both sides and across both arms as well. It didn't matter what you're getting. What I think is most important, and if you remember nothing else, just remember this: the access to medications is what's most important. So whether I send a reminder or not, if there's no medication in the facility, or we don't know where it is, as Moses alluded to, then we are not really making a change. And also, I think, alluding to Dr. Kandie's talk as well, access to medicines is one of the WHO building blocks. So as you come up with whatever interventions, the idea is just to make sure that medications are available and at a cost that the patient can actually afford. Thank you very much.
Okay, thank you very much. Deservingly, she actually deserves a very coordinated club. Yeah, tumsafishie mikono. That's not very coordinated. Tafadhali safisha mkono mpatie. Thank you very much. We are moving on to the next presenter. Caroline, please take it away. Give us the carols.
It's the season. Good morning, everyone. My name is Caroline Getza from Kemri Wellcome Trust Kilifi, and the topic of my discussion today is I don't know how to do this. Okay, thank you. So my topic today is establishing reference ranges for adults and children in Kilifi, Kenya. And to start us off is the introduction. What are reference ranges? So these are a set of values expected for a designated population, where at least 95% of the individuals are presumed healthy. And how do they help us? So they are a powerful tool that aid in decision making, allowing monitoring of disease progression and treatment response in both clinical care and clinical trials. And in the Clinical and Laboratory Standard Institute guidelines, laboratory are recommended to determine their local ranges. So the objectives of this study was to evaluate and establish both adult and children and pediatric reference ranges, and to compare ranges based on geographical location. And ethical consideration was sought from Kemri Seru, relevant ethical bodies for collaborating institutes, Farmers and Poisons Board of Kenya. And the study design, so this was a secondary analysis of 6 clinical trials, where 4 of them were for adults and 2 are for children, which were conducted at Kemri in Kilifi between 2016 and 2020. And the participants were randomly selected in the study area. So, sorry. So the participants were randomly selected from the study area, and you see this is the map of Kilifi, and the orange part is the study area that is covered by Kilifi Health Demographic Surveillance System, where the participants were randomly selected. These participants were deemed healthy by study physician, and there was a lot of screening for chronic diseases such as HIV, hepatitis B, hepatitis C, malaria, and pregnant women were also not included in these studies. So the consent was sought for blood collection, and different parameters were tested for hematology and biochemistry. And our methods, so we have the Clinical and Laboratory Standard Institute recommending a sample size of 120, and lab tests included hematology and biochemistry. We had 3 levels of QCs daily, and we were also enrolled in external quality assurance schemes from UK NECAS and RCPA. And for data analysis, all analyses were performed using version 3.6.1, and data cleaning was done, and this involved removal of outliers. So this is a schematic diagram to show you that outliers are the very low results and the very high results that interfere with statistical analysis. So we remain with this bit that is usually in the middle. And the adults were categorized by gender, male and female, and children were categorized by age. And those were the age groups that we had, 4 categories. So for results, we had a total of 2,333 adults, of which 52% were male. And for children, we had a total of 2,054, and 51% were male. And the parameters varied in sample size because different studies required different variables. So the median age for adults was 32.5, and the children age range from 0.9 months to 17 years. This is a snap preview of the results, how they look like, and you can see, sorry. I can't get it to work. Okay, so the columns are male and female, and the N is the total number of participants in each parameter. The ones highlighted in red are the ones that did not attain the recommended sample size of 120. And these are for children. You can see a number of parameters also did not attain the 120 sample size. Biochemistry had a lot of challenges. Most of the pediatric studies did not require all those other tests, so we only had results for a few. Under discussion, we see HB was lower in women compared to men, and you can see the differences there. Platelets were higher in women compared to men. And for chemistry, ALT was lower in women compared to men, and you can see the results there. And creatinine was lower in women compared to men. For children, platelets decreased from the very young, from 752 to 451 for those aged 60 to 215 months. And the upper limit of normal for the WBCs changed from 14.9 at 1 to 5 months to 8.5 for 60 to 215 months. So the reasons for variation included, for adults, we had HB was could be attributed to hormonal differences and increased iron deficiency in menstruating women. Platelets are well described but not well understood. Liver functions are also very complex but could be attributed to environmental, dietary, and hormonal factors, while creatinine could be attributed to lower muscle mass in women. And for children, differences between ages have been previously well described. So for the results, you can see a comparison by location. These are forest plots. Yeah, so these are forest plots. The blue are men, the red are women, and we have different locations on the y-axis. Again, the y-axis is a line of no effect. So quickly you can see the differences, because if they were comparable, you'd see the lines are overlapping. So these forest plots are suitable for you to see that the different parameters from different locations appear differently. So those are the different, these are snap previews for hemoglobin, platelets, there's ALT down here, and creatinine for biochemistry. And again, for children, we had different locations. You can see from the y-axis and the line of no effect, you see the lines are different in size. Those are actual reference ranges, and they are not overlapping, so meaning they are very different in the different categories. So reasons for variation by location include climate, dietary habits, environmental factors, ethnicity, or race. And we had some limitations because some of the studies that we included for this reference ranges evaluation did not have all the parameters. So the sample size did not attain the 120, and participants were not screened for all diseases, so it is still possible that there was underlying organ damage which could not be picked up on routine screening, and women of childbearing age were also excluded. So in conclusion, the study was able to demonstrate considerable regional variation, both Africa and further afield, hence the need for locally derived reference ranges. And for our recommendations, we say that future pediatric studies to include the biochemistry parameters which had a smaller sample size. Thank you very much, and I would like to acknowledge all the following, and plus the organizers of this conference. Thank you.
Okay, asanteni sana. Pia tumpatie makofi mazuri, tumsafishie mikono, tumpatie. Haya, kwa muda huu labda pengine ningetaka kumwamsha Dr. Kashero aweze kutupatia kile ambacho amekiandalia. Tafadhali Dr. Kashero.
Good morning, everyone. My name is Dr. Kashero. I'm a pediatrician in Mariakani Sub-County Hospital, and I'm also the medical superintendent. So I'm here today to share about a success story in the 3 high-volume facilities. That is Malindi, Kilifi, and Mariakani. And before I start this presentation, I want to echo the words of a famous writer. And he says, with every newborn baby, a little sun rises. This means with every newborn birth, there is a beginning of all things. That is a beginning of hope, a beginning of wonder, and a dream of possibilities. And that's why neonatal mortality is very significant to us. With the death of a neonate comes when we limit a neonate, or we subject a neonate to death before 28 days of life, we have denied this neonate rights. That is, one of the rights is a right to a name and a right to a nationality. So neonatal mortality contributes to 51% of Kenya's under 5 mortality. And the indicator neonatal mortality rate is a very significant indicator. Why? Because 1, it normally reflects a country's socioeconomic development, and 2, it's in its reduction, it's a major goal in the specific development goals. And hence, when you reduce it, you are a benchmark for progress and quality of life. So the Kenya neonatal mortality rate as per 2023 was at 22 per every 1,000 live births. The primary causes of neonatal mortality are normally prematurity, birth asphyxia, and neonatal sepsis. And this data is not only the local data, but even the international data. It has shown that majority of our neonatal mortalities are normally because of 1, prematurity, asphyxia, and neonatal sepsis. And that is among the data that we will share today, even in our own studies. Then, for us to achieve the Millennium Development Set goals for 2030, to achieve 12 per 1,000 live births, that is the target that we've been set for that. By 2030, we should at least reduce our neonatal mortality rate to 12 per 1,000 live births. Kenya has to work 5 times to other nations. There are nations like Rwanda that have already achieved this. So as I told you, we are at 22 per 1,000. That means for us to achieve 12 per 1,000, we have to work 5 times more than others. In 2022, WHO published simple interventions. And these are interventions that can be done. They do not need a lot of, investment. These interventions that have proven that they can greatly improve, reduce neonatal mortality. One of it is kangaroo mother care. I won't go into details of that. Number 2, early initiation of breastfeeding. Number 3, continuous use of CPAP. And number 4, use of caffeine citrate as a medication for apnea of prematurity. So today, I want to share a success story about CPAP. CPAP, I'll just recap a little bit for the students in the room, is one of the best way to give humidified oxygen. It's a simple, most cheapest way. You're giving oxygen that is titrated. And why is oxygen that is titrated and humidified better than 100% oxygen? Because this oxygen is not harmful to your brain, is not harmful to your sight, and it has shown that it improves even quality of life for all preterms and low birth weights. So early this year, around April, USAID and the government of Kenya issued CPAP machines to our facilities, 10 to Mariakani, Kilifi, and Malindi each. And that was the beginning of our change. Before that, we had a baseline data that we were looking at our neonatal mortality rate for the previous year. And it was alarming. Just like the whole world is fighting towards fighting neonatal mortality, even as a county, we were not left behind. And I'm proudly to say that in this period that we have used CPAP, we have seen a lot of babies, a lot of premature babies go home alive. So we were looking at our previous data as a set goal for the previous financial year, that is 2024-2025. We selected the 3 big facilities because that's where CPAP was distributed. And we were looking at the live births versus neonatal deaths. And the implementation of CPAP is normally done in 2 ways. We do prophylactic CPAP for any preterm who is born with kilos less than 1.1. And we also do rescue CPAP for the sick preterms who have either been exposed to oxygen and did not improve, and it's done as an intermediate measure for them not to either go to ICU or to observe them before they go to ICU. So that is our data. Basically, that is our baseline data. As you can see, in the year 2024-2025, we had 14,168 live births in the big volume facilities. And majority, just like the data for the international data, majority of these babies are either born with kilos less than 2.5, and these are the risk babies who are at risk of getting respiratory distress syndrome. The premature babies, remember, lungs maturity happens at 32 weeks. So if a baby is born with less than 38 or 37 weeks, the term maturity, they are normally at risk of getting respiratory distress. And then we also have a high burden of low APGAR scores. And in that financial year, as you can see, we had a total of 428 neonatal mortalities from the 3 high volume facilities. So from April, when we received the CPAP from the 3 volume facilities, Malindi has done really well. I'm not saying Kilifi and Mariakani is not doing well, but Malindi has really utilized CPAP. You can see Malindi has done 107 CPAPs. 107 babies have been introduced to CPAP. Kilifi is second with 49, and Mariakani is third with 26. And the majority of them, the indication is preterm. I told you preterm, premature babies, highest complication is normally respiratory distress. And surfactant is not as available. So CPAP is one of the best, cheapest measure that can help us sustain the respiratory system. And as you can look at the data, not only prematurity, but also birth asphyxia is the other indicator why we introduce CPAP to these babies. And then Malindi and even Kilifi, there are other causes like meconium aspiration among the causes that they introduce CPAP. And I'm really happy that among the 182 preterms or other causes that were introduced to CPAP, 134 babies went home alive. This is really good. So as I wind up, I'm already almost, before you ring for me the bell. So this is just, I specifically chose this photo because this shows the work that has been done for this success. And in that photo is a reflection of the healthcare workers, both in Malindi, in Kilifi, in Mariakani. And one thing that I am really happy about is even before the national government came to start training us in the facilities, people were so eager to use CPAP. And people went on their own in the different facilities to train. You can see, and if you look at the composition of the people who are training, it's not only consultants. In fact, there is no consultant in those photos. Those are our nurses, those are our students, Those are our medical officers who are eager to look at this new intervention and the way it's saving our neonates. So this is a really reflection of how CPAP has been embraced in this county, and I'm really happy for the people who have taken up this initiative. The other thing about this photo, why I'm really happy about it, is now we have CPAP committees in our facilities. And these CPAP committees are active. Like the CPAP committee in Mariakani is headed by a medical officer, Dr. Tsuma. And they're active committees, and whenever we see a baby who has indication to start CPAP, you always just call the committee, and the committee picks it up. Last but not least, I think a lot has been said before about the use of CPAP and why it's important. I'm not going to go back to that. A lot needs in terms of training, equipment, so that at least we can go into these new interventions. Majority of these new interventions have proven to improve life. Studies have shown that a premature low birth weight who is exposed to CPAP has 66% survival rate compared to a baby who has not been exposed to CPAP. In my recommendations, I told you CPAP is the bridge between giving oxygen and going to intensive care. If we can actually get an intensive care in this county, it will really help us. For those babies who might not benefit from CPAP, they can go to intensive care. I will not do justice if I don't acknowledge our partners who have been very helpful, USAID Kenya and the county government for training us nurses in neonatal department, Aga Khan University in your different studies, Protect study, the low birth weight study by Helen Nabwire. They're always there to help us in training, capacity building. The nurses who have devoted themselves to learn about CPAP and initiated it in our facilities. Thank you very much.
Thank you very much. If you noted, she spoke with a lot of words, and also the non-verbal communication was also very strong. The body language was that she was speaking from the heart. Thank you very much. Tumsafishie mikono tumpatie. There was a lot of acknowledgement for different persons. Lakini sisi tunasahauliwa. Nikisema sisi namaanisha the translators and transcribers. Hata mkimaliza huku mwisho tusemeni kitu kimoja kuhusu sisi, because sometimes we spend a lot of, tunaweka mitochi mbili, project inaitwa mtochi, huku Kigiriama, huku Kizungu. So we really work on that also. Sometimes pia mnatushukuru pia sisi for the good work about makofi mazuri kwa translators wote. Okay, thank you very much. So at this juncture now, I'll ask my sister to take it up and do the question and answer session. Thank you very much.
Thanks a lot, Mwamuye. I'd like to take questions for our presenter, including for Dr. Kandie. So I'll take about 3 questions, then we have the responses, and then another set of questions.
Thank you very much. My name is Dennis. I'm from North Coast Medical Training College. I have a question for Dr. Charles. Actually, 2 questions. First of all, I really want to thank you for the insightful presentation. Actually, I didn't know that there exists an office that ensures quality for such things, especially at the national level. Now, my question is, as we all know, in Kenya, we would significantly advance our country's progress. However, there often exists substantial gap between this policy formulation and the implementation, which I think there is quite conflict between these policies. Now my question is for you, or for your office in charge of ensuring quality. How do you, or what specific mechanisms are being implemented to bridge this gap and ensure that existing policies and frameworks are executed as intended? My second question, you also highlighted the importance of health system strengthening, particularly the innovation part. And most of these innovations are actually implemented at the local level. And they are mostly pushed by the private sector. Unfortunately, there sometimes exists opposition between these private sectors implementing these initiative or innovations and the government, which mostly impacts the sustainability of these innovations. Now, my question is, what strategies are being employed to foster better intersectoral coordination, particularly between these NGOs and the government to ensure long-term sustainability of these innovations? Thank you.
Please, I will ask you to just ask one question so that we have more people asking questions.
Okay, stay as guided, brief and precise.
Thank you so much. I'm Polly Kapoyo. I work for ICRHK. I have a question for Dr. Kandie. When you are speaking about the quality improvement in reference to the PDCA, the Plan, Do, Check and Act, there have been several improvements to that because I was thinking about the ISO 710 for the healthcare quality that recommends us to come from PDCA to now PDSA. So can you provide a guidance what the ministry is pushing in regards to whether PDCA or PDSA, or we have that we can leverage on both?
Yes, good morning. My name is Marianne Darwinkel. Dr. Kandie, I'm afraid my question also goes to you. I think your presentation was very interesting. My question is, when you want to keep people responsible for the quality of the healthcare, someone needs to have some influence or some authority to be held, to help support that budget and resources are available to provide the services that he's responsible for. So several issues arose already in this conference that touched on that. I think it was mentioned that within the public system, people are involved with the planning, and the annual plans are often very different from the people who make the budget. I think there have been comments about the SHA when people said there are issues with disbursement. Today, I think there was another thing that was mentioned by one of the other speakers about the medication, that the chains often have problems. So are you also capturing those major system issues within the Kenya quality management for health activities that you are carrying out, Asante?
Okay, I want to ask the other presenters a question so that we give Dr. Kandie some room to breathe. The person that spoke to us about blockchain, anyone with a question for the others? Okay. Take it to the back. The people at the back have not. Then you pass it.
Good morning, everybody. My name is Dr. Jamal. I work with the AIDS Healthcare Foundation. My question is to Dr. Mercy Atieno. Your presentation was actually amazing. But I had a question with regards to one of the results that you mentioned in terms of when the patients who are on polypharmacy, the adherence was much better. It sparked an interest to me because I work with HIV patients and non-adherence is a big issue. You realize that by the time a patient is on multiple anticonvulsants, it means the severity of the disease is much worse. Similar to the behavior of our patients with HIV, they start to react when like the severity has gone really bad. So with that regard, were there any behavioral what is it called? Conclusions that you could be able to come up from that? That was my main question.
Thank you very much. There's been a hand which has been raised persistently here. Maybe after him, we will take the last question here.
Thank you very much. My name is Dr. Paul, I work in Kilifi County. My question goes to Moses. I have to admit I was really looking forward to your presentation, given the existential challenge of drug diversions and avoidable stockouts in our facilities. Unfortunately, it came out to be more of a proposal. I expected a case study that was already done so that we could pick some of the lessons learned to address that. But I would just want to ask, as you plan to maybe implement or carry out this case study in Kilifi, what is your plan in terms of the implementation framework to be able to mitigate against the challenges you have experienced before in terms of the systems that have come in place to ensure end-to-end visibilities, either linkage to the KEMSA EPOD system, which you mentioned is now manual, and being cognizant of the fact that over 90% of our facilities are rural and have the challenges in terms of the network and software, is your blockchain system going to mitigate against those challenges? Thank you.
Okay. Thank you very much. Okay, my name is Helen Nabuera. My question is to Mercy Otieno. Thank you so much for really that excellent piece of work. Just wanted to ask, especially in Kilifi County, our experience in the community is that there's an issue of ownership of mobile phones. And so therefore, one household may have one mobile phone, and therefore that mobile phone may not be in the compound where that child is. So really just wanted to hear your thoughts on whether those messages actually got to the people who needed them to then provide the medication for the children. Thank you so much.
Good morning. Mine is a very brief one to Sister Mwangi on the presentation in Malindi. I think I would call for a little bit of being careful with the numbers, because we say Kenya, maternal mortality rate years ago, 365 per 100,000. Now we say Kilifi, 522 per 100,000. But if you look at, as I said yesterday, in Kilifi, the facility maternal mortality rate is about 130. 522, 130 is a lot of difference. So even if in Kilifi, as I said yesterday, we know that 90% of the women, they deliver in a facility. Maternal mortality rate in the facilities, 140, 30, 40 per 100,000. So even if all the 10% who deliver at home, even if all of them would die, you never come to 522. So I know there is a lot of confusion about, and WHO never said SDGs are asking for an average, global, 70 per 100,000. The figure for Kenya by 2030 has to reach 140 per 100,000. So not 70, that is impossible. 70 is for the world, right? So we have to be very careful in how we communicate to the outside world, because then there's 522, 365, 140, and it becomes chaotic. So maybe we can agree on looking at these targets.
Okay, I'm being warned
Thank
about
you. There's somebody who has been
time.
asking persistently here. Okay, so please proceed.
Yeah, and I'm being warned about the time, but as chair, I will want to ask two questions to the people, to the presenters, just so that they can also say something. Caroline Getzer, you've introduced to us new reference ranges for this population. I wanted to ask, can we now take forward the reference ranges that you have given to us to use in our future studies and say these are the ones we will use for the Kilifi population? And then for Dr. Kashero, in Malindi, you showed significant use of CPAP. What did Malindi do differently after the training that all the three facilities went through that, caused them to just take the CPAP and run with it? Okay. I don't know who wants to go first. Maybe we go with you, and then you can come back to the other question.
Yes. Okay. Thank you very much, Dennis, for what you have asked. When it comes to quality of care, we used to say, is it everybody's business? Because every sector, every service area within a health facility must improve quality. And we debated it as a country, regionally, and we found that it is important that we have a coordinating mechanism. If it is everybody's business, then nobody does it. So it's important that we have. So as a Ministry of Health, from the national level, we have a Directorate of Health Standard Quality Assurance and Regulations that does that. So we inspire the counties, we coordinate quality, and we have done the same similarly at the county level, at the national, at the county level, at the hospital level, and even at the community, even at the health facilities. So the question was asked, what is it, we have come up with policies, we have guidelines. What can we do to ensure that there is adherence to that? So we have, one of them is incentivize, ensuring that for you to access maybe share resources, you must show that you have adhered to these standards. So we are doing that. That is one of them. The other one is to legislate for it. Currently, we are legislating for facilities to have quality improvement teams through a piece of legislation that is currently in the Ministry of Health. So that is another one. So we shall have a mechanism of assessing health facilities, and they will be given what you call a quality index. For you, you'll be told you have not adhered to this. So you'll inspire teams to work on that. From where I sit, we've really ensured that we came up with quality of care framework, and we have already disseminated it. So it needs to be disseminated appropriately, and to ensure that all the regions, we undertake that. Then the other question was on innovations that we are getting from private sector. So we have what you call partnership framework, where we bring in counties, both to national and county government. We sit down as a team. So the counties have what you call thematic TTCs, where one looks at HPTs, another one looks at health financing, another one looks at quality and quality assurance. And we sit down with the private sector, with the NGOs, and discuss things around that. So innovation, and even so innovations work around that. If you look at today, we have Aga Khan here, we have Jacaranda Health, and they have been, wherever they work within the county, you can see them supporting a health center, adopting, and we embrace these new innovations that are coming in. So they should be aware. We've been having an arm's length relationship with researchers, but we now need to work together and discuss this further. So the other questions don't want to be answered. So the last question. Okay, the other one is on PDSA. I'll just quickly say. So I agree that we have got a number of quality improvement tools. So they are all generally the same. So PDSA and PDSA are the same, but we adopt the one of PDSA, study. Because check and study, check, you just check. We want study is more in-depth, so we will go by the study. We are coming up with quality improvement framework for the sector, and it will guide on this. Lastly, on the responsibility of, we have budgeting and what have you, especially for quality, budgets are not there. So we need to have an institutionalization of budgeting to ensure budgeting around quality is undertaken. You talked about SHA not paying. I'll be on their neck to ensure that counties are really making. I was not happy when the two county governments, Lamu and Kilifi, saying that they have not been paid. So we shall see, we'll advocate for that and see how that one is undertaken. I agree on that. And then we shall ensure that we institutionalize quality improvement to ensure initiatives where we have gaps. And that's why we are saying we need to do assessment of all the service area within a county and a health facility so that we come up with interventions that we can address the improvement of care for this country. Thank you very much.
Okay, thank you for the question about maternal mortality ratio. Okay, the figures that I gave here are from the KDHS 2022. And for the KDHS, it's normally calculated over a period of time, and also including the community maternal mortality. But for the facility maternal mortality, always it's low. The 146 is for the facility maternal mortality. But when it comes now to the study for the KDHS, I don't know the formula that they normally use. And they gave us Kilifi as 532 and Kenya as 355. Okay, thank you.
Okay, thank you for the question, Dr. And implementation of this technology. One thing that we need to agree, yes, these technologies are here and we need to embrace them. But again, how are we going to implement? Yes, it's a proposal and a time that we have donors checking out, but still we'd expect more from donors as well on how to implement them, so that we can be able to cover most of our facilities which not have internet, because at the end of the day, yes, we need to have presence of internet into implementation of these systems. And also integration, yes, those manual systems, yes, where they are systems, they'll be integrated to the blockchain technology. Thank you.
Okay. clearly. I thought I was going to get away from this. Thank you so much, Dr. from AIDS Health Foundation. I hope I can be seen. I'm very short. So in terms of polypharmacy, the situation is exactly the same in all chronic conditions. So two things. One, adherence counseling is usually your first step if you realize there's no treatment response. But in epilepsy, the other thing to think about is the diagnosis. Is it actually epilepsy? So we do have a lot of misdiagnoses of epilepsy, and then we also have what we call now treatment-resistant epilepsy. Again, so those are two areas you want to think about in terms of epilepsy. The other question from Dr. Helen Aga Khan Foundation was on the ownership of mobile phones. Generally, at least for our study, we're able to get at least 90% of the patients who are attending our clinic would have a mobile phone within the household, even if they don't own it themselves. So what we did is we improvised such that the intervention would be sent at your preferred time. So we'd ask you, what time do you usually give the baby the medication? And therefore, we will send that reminder a few minutes before that time so that we know you're home. This is the time that you usually give the medication. So it was sort of a workaround to just ensure that the intervention works. Thank you.
Thank you, Nancy, for your question, whether we need to move forward and implement the reference ranges. Yes, and the reason is that most of the parameters we surpassed the CLSI recommended sample size of 120. So this becomes a true representation of Kilifi. So we have implemented these reference ranges at our facility, Cambridge Wellcome Trust Research Program, and anyone else is welcome to use them. They are published in the Wellcome Open Journal. Thank you.
Okay. For the case of Malindi, Malindi started both prophylaxis and rescue CPAP from the beginning. Kilifi and Mariakani, we started with rescue. This is the time we are all picking up with prophylactic CPAP. So that's why the data for Malindi is higher than everyone else. So right now in all facilities, any preterm low birth weight, 1.1 stable, we start them on CPAP. Any preterm who has been exposed to oxygen is not improving above 1.1 sick, we give them rescue CPAP. So Malindi was way ahead of everyone because they started with both prophylaxis and rescue.
Thank you very much. I apologize profusely for taking up more time in this session, but I really loved the engagement. I saw that there were more hands up. Please reach out to the presenters. Moses, I'm feeling like you needed to answer a question. There was no question for you. He talked. Okay, all right. So I just want to thank you so much for your active engagement in this session, and apologies again for taking your 10 minutes. Thank you, and please let's give a big
Thank you. Or maybe you can step up on stage for a photo session.
Great. Now get off the stage. This is what happens when you have a chair who has veto power. I didn't know that some of these announcements are going to be made such a forum. But owner of KBX 746A, please attend to your car. I only thought these are reserved for weddings and burials. But KBX 746A, attend to your car. We're going to have a drill on eclampsia by Jacaranda Health.
When I'm in trouble, He is my help. I know no fear, I know Come on, we say, He really knows what He says He will do. I can't really move. Oh, what would I do when He always comes through? I can't really move.
Good morning, everyone. Today we will be conducting a clinical simulation, or we call it a drill, focusing on a very important emergency that usually happens in maternity. It's one of the leading preventable causes of maternal morbidity and mortality. And this drill is designed to demonstrate real-time decision-making, teamwork, communication, and adherence to evidence-based emergency protocols. Our aim is not only to showcase the technical steps of emergency management, but also to highlight the system readiness, availability of essential drugs, clarity of roles, and efficiency of team response. So we encourage you to observe the flow, identify the gaps, and reflect on how such drills can be integrated within our routine, our facility quality improvement processes. So we are going to have our own healthcare workers in the facilities who are going to demonstrate this within a very short time. I hope we are ready. We might have a few of medical jargons, but we'll make sure that we make it as simple as possible for everyone to understand.
Hii kichwa inauma tangu usiku. Sijui tutafika hospitali saa ngapi.
Pole.
Kinauma kabisa, kinauma kabisa.
Pole.
Nisaidie. Kinauma kabisa. Nasikia vibaya. Hata hii miwani hainisaidii. Hainisaidii kabisa, hainisaidii. Na wewe bwana kichwa daktari. Kidogo wote kinaniuma. Usiku wote.
Amelalamika kichwa kinamuuma.
Niambie shida ni nini mama? Kichwa kinauma usiku wote, nimeteswa na kichwa kabisa.
Pole, waitwa nani?
Naitwa Mary.
Mary.
Karibu
sana Mary. Acha nikusaidie upande hapa kwa kitanda. Tafadhali hizo kinauma.
Vibaya wewe. Vibaya kabisa, vibaya. Hey. Achana nayo kwanza, achana. Daktari nisaidie. Hii kichwa kinaniua mimi. Hii kichwa. Kinaniumiza vibaya. Nasikia macho inang'oka, hata sioni kabisa. Sioni kabisa daktari.
Nataka kumsikiza mtoto.
Anacheza, namsikia anacheza, yuko sawa huyo. Aya, sawa daktari. Harakisha basi unisaidie. Saidie. Hakuna tebe hata moja. Naweza nisaidie. Haya, sawa.
Daktari, Dr. Busra, we have a patient who has just arrived with severe features suggesting preeclampsia. Please, we need your attendance.
Macho hayaoni kabisa saa hii. Asante daktari.
Yes, Sister Nyazua, what do we have here? This is Mary. She's just arrived. She's a premigravida at 40 weeks gestation with severe headache. Now it's 2 days. She has blood visions. According to her BPs I've taken, she has a blood pressure of 170/110, pulse of 80, and the fetal heart rate is 140.
Those are features of impending eclampsia. We need help. Please help.
Pressure yake imepanda juu sana, so tunataka kumsaidia.
Don't panic.
Malemba,
We are
please
safe.
check for us the airway. Check the airway. Make sure there are no secretions and put the patient on oxygen.
Mageni haya. Haya ni mageni haya.
Let's put her in recovery position.
Okay, let's put Airway first. Let's put the airway first. Chin lift. Head tilt, chin lift. There's no secretion. Insertion of airway. Oxygen. Thank you. Let's put the oxygen and then we put her in the recovery position. Okay, let's turn her on the left side for the recovery. Thank you.
Sister Nyazua, please prepare for us magnesium sulfate. 4 grams IV of 20%, 10 grams of 50%, 5 on each buttock.
Sasa mzee, bibi yako Mary pressure iko juu na amefitika. Lakini saa hii tumemweka katika hali ya usalama, tumemwekea oxygen, tunamsaidia yeye na mtoto. Okay. Tutampatia dawa za kuzuia kufitika na kuteremsha pressure. Kisha tutakuambia vile itakuwa.
Msaidieni.
Bwana Mary, tunataka kuweka mama mpira ya mkojo, tuna test tunataka kufanya na ile dawa tutamdunga, pia ni muhimu kujua mkojo uko kiasi gani.
Samples for volumegram GXM UECs and LFTs taken.
We have 3 proteins. This is confirmed preeclampsia. Now we're dealing with eclampsia. Huwa hana ugonjwa wa kufitika? Okay, how's the BPs?
I'm administering magnesium sulfate 4 grams IV. Administered. Now I administer the IM dose of magnesium sulfate, 5 grams plus 1 ml of lignocaine.
Alikuwa nafitika mara ya kwanza, amefitika alafu madaktari wanamshughulikia. Njoni sahihi tu.
What is the current BP?
160 over 110.
The BP is very high. Let's give her labetalol, 40 milligrams IV, slowly over 10 minutes. Mary, unasikiaje sahi? Mary, the patient is still unresponsive. Please bring the labetalol.
Did you say labetalol 20 milligrams IV?
Yes.
Labetalol 20 milligrams IV given.
I would like to do a secondary survey. Mary, unasikiaje sahi?
Niko wapi?
Hapo kwa hospitali.
Hii ni nini mmeniweka hiyo? Daktari, hii ni nini?
Hii ni hewa safi mami, usitoe, itakusaidia wewe na mtoto, usitoe. Bring me a vaginal pack. Okay, it's a term pregnancy. We need to assess if she's in labor or not. Bwana ya Mary, tunaomba tupime mama njia ya kuzaa, tuangalie kama ameanza kwenda into labor or not, ndio tujue ile njia tutamzalisha. Sawa sawa. Hai.
Tunakugeuza kidogo ili tuweze kukupima. Asante.
Vitatulia, tutakuwa sawa. Kichwa kimetulia.
Tunapima njia ya mtoto.
The cervical os is closed and the poor bishop score. So we are going to have to call Kilifi County Referral Hospital. Please inform covering to call for the ambulance. We need to refer this patient for possible cesarean section.
Good morning. This is Nyadzua calling from Ganze Health Center. We have a case of eclampsia, a mother called Mary, gestation by date 40 weeks. She's a primigravida. She has just arrived in our facility like 20 minutes ago with complaints of severe headache, blood vision for the past 2 days. Currently, we have administered magnesium sulfate loading dose. We have given labetalol IV 20 milligram stat. And we've also taken samples for full hemogram, GXM, UECs, and LFTs. So we'd like to refer to your facility for emergency cesarean section, simply because the mother is still not in labor yet. On her vaginal examination findings, cervical dilatation is 2 centimeters, and the cervix is not favorable for vaginal delivery. Thank you. Sasa Bwana Mary, tumemsaidia Mary, tumemweka stable sahihi. Tumeona ni afadhali aende kwa hospitali ya juu kidogo ili juu ili aweze kusaidika. Tunampeleka Kilifi ili aweze kusaidika zaidi.
Atakuwa sawa lakini.
Atakuwa sawa. Maana mtoto pia yuko sawa kwa sasa.
We have 2 minutes of debriefing for the same. Please have a seat. Have a seat. Getting well. So I want to start with the mother. How did you feel? Were you cared for?
Yes, I was cared for.
Given another opportunity, will you visit the same facility?
I would, very comfortably.
Thank you.
Everybody was caring for me.
Thank you. We go to the primary health care health profession who was on duty. What were the earliest signs that you identified that suggested it was eclampsia?
So the mother presented with severe headache, blood vision, and also she had epigastric pain, which lasted for 2 days. And also we've taken the blood pressure. It was so high, a blood pressure of 170 over 110. That suggested.
How quickly did you initiate magnesium sulfate, and was the dosing correct?
The dosage was very correct, and we quickly administered magnesium sulfate after confirmation of the diagnosis with proteinuria +3.
Thank you. We go to the second one. Malemba, what challenges did you face in securing the airway? I saw you struggling with the airway. What challenges did you face ensuring that the patient's safety during the Caesar?
Okay, I had to wait until the patient had finished, the convulsion had ended. There was no secretions during from the way I could see, so there was no need for me to sanction. The airway tube was available, so I didn't get.
Were you confident to
Yes,
put
I was.
the airway?
Yes, I was.
Thank you. Was blood pressure monitoring timely and accurate?
Yes, it was. She did the first time. Nyadzua did it the first time, and then immediately after, when we had given labetalol, after 15 minutes, we took it again.
Thank you so much. We now go to the secondary healthcare provider. I saw you being called as the doctor on duty. Was all the required equipment available and functional?
Yes, they were functional. They were all available and functional.
Anything that caused the delay that could have proceeded this mother to go into something else that we could not reverse?
Readiness is very key. The team, when they called me, they had everything in place. They have done their survey, and everything I needed to manage the patient was available, and it was timely, hence the good outcome.
Thank you. What actions can we take to improve our readiness in our previous facilities that we come from?
Always ensure you are prepared. That's why the healthcare called to the referral facility for them to prepare. Always have your crash cards updated, and improvise, innovation. Make your own kits so that you are ready for such emergencies. To avoid running up and down, you could see that the table was prepared with all supplies in one place, where the timely interventions were able to be given to the patient.
Thank you. How can we ensure that learning translates to the real clinical scenario?
It's just through the drills and practice, and then review of the case management after every case of emergency to see which areas of improvement that can be done.
Do you think that there's something that can make you not to attend to these mothers in our real setup?
Not at all. We don't have reasons to. Through mentorship and the CMEs, we've been having these drills. There's no reason that mothers should not be managed effectively, even in peripheral centers.
Thank you. Then lastly, we go to the companion. What is one thing that you think the team attended so well to your wife?
I was welcomed very well, and the healthcare workers attended to me and my partner, so I was not left behind during the service provision, and I think I was glad that in every step they involved me.
Thank you. Would you recommend going to the same facility next time, having the next pregnancy?
Yeah, sure.
Thank you so much. Thank you, the congregation. That is all our setup that we had. That is one of the high impact interventions that we are doing as Jacaranda. We are supporting these drills in our facilities to ensure that we have well capacity built healthcare workers in our facilities. So this is what we encourage, translating what we are doing into the real setup in our mothers to ensure that we are able to be ready, promoting readiness and even teamwork and leadership during the emergencies to avoid delays that are happening and making mothers proceeding to severe complications. I hope you learned. Thank you.
A better hand to Jacaranda for that drill, which actually now paves way for the panel discussion on using evidence to model watertight MNH interventions to reduce maternal mortality. Or maybe one other question they would have asked the companion is whether they want to have another baby after giving water and it's not taken, yeah? Miriti, please bring your panel here.
Good morning. Good morning once again. Okay. So we want to have a very good panel. But before that, I want to read something. I want to tell you that Kilifi County, our maternal mortality ratio as per 2019 census is 532 per 100,000 live births. 502 per 100,000 live births. So across the county, we have interventions like you have seen, various interventions, including MPDSR reviews that have consistently shown that maternal and prenatal deaths are not random events. And you have heard from various presentations that they are not just random events. They follow patterns, they expose systemic weaknesses, and most importantly, they are largely preventable. So we continue to see mothers dying from complications we can anticipate and manage, delays in decision-making, delays in reaching care, suboptimal triage, and emergency response and gaps in readiness at level 2 and 3 facilities, where most women in Kilifi seek delivery services. So filled in this hall are various partners who support us to ensure that we are giving good care, both technically and also financially. And so I want to welcome you for this panel. The panel title is Using Evidence to Model Watertight Maternal and Newborn Health Interventions to Reduce Maternal Mortality in Kilifi County. So allow me to welcome my panelists. The first one I want to welcome is Dr. Busra. Dr. Busra, where are you? Yeah, Dr. Busra is a obstetrician gynecologist, as she said earlier. She works in KCRH. And then we have the next one is Joseph Mutwereri. Joseph Mutwereri is the head of partnerships, IMOC mentorship lead in Jacaranda Health. Then we have Polycarp Oyo. Polycarp Oyo works in ICRH, maternal, newborn, and child health, health system strengthening. Our next panelist is Pauline Karaoke. Pauline works with Helen Keller, nutrition and MNH integration. And then we have John Kutner. He is with the Salama Amref digital MNH platforms partner, and also the lead in MNCH in Amref. And finally, we have my friend. Your name is very hard. Please come in front. I only remember the one name that is conversant with my mouth. That is Mungatia. Mungatia, you know, Mungatia is mdomo changu. And my name is Kenneth Meriti. I work in the Department of Health, Kilifi, as the Reproductive Maternal, Child and Adolescent Health Program Coordinator. So we are going to have a very candid discussion. So I want to start this conversation. I don't know. I want to start this conversation with, and I want to start with my colleague, Dr. Busra. So based on clinical evidence from Kilifi's MPDSR reviews, what would you identify as the top 3 preventable clinical drivers of maternal deaths in the county, especially for those occurring in level 2 and 3 facilities or emanating from level 2 and 3 facilities, and what specific evidence-backed interventions would most effectively address them?
Thank you, Mr. Meriti, for that question. When you're talking of maternal mortality, it's next to impossible to have zero maternal mortality, but it is possible to have preventable zero maternal mortalities. So when you're talking of preventable clinical drivers that lead to maternal mortality, I will speak of 3. Number 1, delayed in recognition or failure to identify high-risk women. And this can be due to lack of skills or burnouts or reduced workforce, where a care provider is there seeing so many patients that they are not able to pick these danger signs or high-risk women. Another preventable clinical driver is poor referral processes. And lastly, limited and erratic supplies, both in terms of blood, essential medicines, non-pharmaceuticals, everything. So if these 3 things we are able to make sure that we have them, then we will be able to reduce preventable maternal mortalities. On the evidence-based intervention, I would say we need to ensure that all BMOG facilities, that is level 2 and level 3 facilities, have all the essential commodities as per that level, including IV antibiotics, parenteral drugs, anticonvulsant, uterotonics, all those things, IV fluids. Another thing is to ensure that the supply chain is reliable and consistent for these essential drugs. Another thing, competency-based training and mentorship, and on-site drills like what we had for these care providers in those facilities, so that they are able to handle those obstetric emergency when they encounter them. MPDSR reviews. Whenever we have a maternal mortality or a neonatal mortality, when the reviews are done, the actions have to be implemented to the latter, rather than just ticking a box. And lastly, we need to ensure community and antenatal care strengthening, because when this mother comes to us with PPH, when you look back, the problem has started antenatally, and it is from the community. It doesn't start when the patient is there in the facility. So we need to prevent anemia antenatally and treat, if any. We need to identify these high-risk mothers and then link them to the high tertiary facilities where there are specialists to see these mothers. We need to ensure timely health-seeking behavior, and this is by talking to the mothers when they come to the antenatal, telling them about danger signs. Sometimes you'll find mothers coming to you with IUFD, fetal death in utero. And when you ask them, when was the last time you perceived fetal movement, they tell you a week ago. So you wonder, why didn't she come to the facility that 1 week ago? Because she didn't know that having reduced movement it's alarming. So it's important that we explain to these mothers when they're having severe persistent headache, epigastric pain, dizziness, those are features that is not normal. Yeah, so you need to seek care very early. So community and antenatal care strengthening. Maternal death. Thank you.
Thank you very much, Dr. for that. And I want to pick from where you stopped in terms of community engagement, the interchange between healthcare providers and the mothers at home. So, Joseph, you are working in Kilifi County and other counties in terms of that interlink by use of the prompt platforms that generate rich provider level and community level data. So how can these data sets be used to identify persistent gaps in respective maternity care, delay, the first delay, second delay patterns, and quality bottlenecks across Kilifi County?
Yeah, thank you, Miriti, for that. And I just be picking up from where Dr. Bushra left it. Yes, for our country over time, I think our maternal mortality has remained to be very high, both as a country and across the counties, including Kilifi County. And just to give an example of where we are at, 355 across the country. That means every day we are losing 15 moms. Every single day in the country, we are losing 15 moms. For neonatal mortality, 21 per 1,000 live births, we are losing 60 babies every single day. Every single day. That's a full Simba coach from Nairobi to coming to Kilifi. We are losing those number of babies. Every day we have those statistics. We know it's happening, and it has remained for some time. And as Dr. Bushra says, the causes of these deaths, we actually know them. Eclampsia, PPH, and all those are preventable. And we know they are preventable. And yesterday I was looking at the MPDSR 2024 report by the Ministry of Health. And it's actually saying, for the first delay, just as Dr. Bushra has said, moms who died because there was a first delay, 60% of them was because they actually did not know it was a danger sign. They actually did not know at that time they needed to go at facility and seek care. So they came late. And about 30% of them actually did not know, if I am experiencing this danger sign, then where should I go and seek this care? So there we have a problem at the community where moms are either not recognizing a danger sign, or even if they realize the danger sign, they don't know where they should go and seek care. Okay? That report still continues to identify challenges at the facility level. And about 30% of those deaths is because either there was a misdiagnosis. So for the example that we are seeing here, it was eclampsia and a health provider did not know it's eclampsia. Or among that 30%, or they did not know what to do. A mother has come to a facility and they did not know this is eclampsia and this is what I need to do. So at Jacaranda Health, we have been collaborating with Kilifi County to be able to address those challenges. And as you have mentioned, Miriti, one of them is PROMS. And what PROMS is doing is that, one, it's giving moms information through SMS, okay? So at the community, a mom in Kilifi County, in Swahili, receives information telling them, if the baby does not move for this period of time, you need to go and seek care services. Not only that, it's also giving them opportunity to ask questions. From morning, if it's evening, a mom can ask, from morning, mtoto hajacheza, is it normal? And our system is able to flag that, identify a danger sign, and a clinical team calls that mom and links them to care. But to come specifically to your question, what data are we seeing? So PROMS is helping to collect data on what number of ANC visits moms are attending. We are able to track the questions that moms are asking. They are also able to give us quality of care that they receive when they come to facilities. So they tell us when they come to your facilities for the providers here, and I think you know this, they tell us whether they liked the care that you provided. About 95% give us that positive response, but about 5% are also complaining, and we relay that feedback to Miriti, the county leadership and team. And we have a lot of data that we are collecting around that space on quality of care, ANC, PPFP, uptake, and so on and so on. We're also working with the county to deliver the mentorship program, which is an example of what happens is what we have seen here. And what we are doing is that we are identifying a cadre of health service providers in the maternity ward, from cadres from OBGYN like Dr. Bushra, medical officers, nurses, clinical officers, and working with them to ensure that they gain competency. Just like PROMS, we're also collecting data from this program, and we are able to see how many mentors are completing curriculum, where are the skill gaps, and so on and so on. And with that data, we put it into a dashboard that we have given access to Miriti and the see where gaps are and make decision. So just to sum it up, I think specifically to your question, Mr. Militi, the problem now is not actually data availability. We have the data that we need to make the right decision. I think the discussion we need to have now is how are we going now to transition from the data that we already have to action, and what the data is saying and speaking to us. Thank you.
Thank you very much. That data for action is what I want to pose a question to John Kutner. Ladies and gentlemen, we are launching Uzazi Salama Extended tomorrow. And Uzazi Salama has been here for the last 1 year in 2 sub-counties. So you are poised to generate large data sets after the launch tomorrow. And that is on ANC attendance, risk profiling, referral compliance, and bad outcomes. So what insights from your data points to structural or systemic gaps, maybe from what you have done in the Kilifi South and Magarini, gaps that may require urgent redesign to fit into emerging county priorities in the scale-up, and you know them.
Yeah, thank you very much, Ken, for that good question. And thank you, my brother and colleague Mdeleli, for setting the foundation. But I want to start from where my brother left. And the key question, when I looked at the team, where we're talking about using evidence to design high-impact interventions that will transform the health of mothers and our newborns, the key question that normally comes is, where is the evidence? Is there evidence? And when we pose a question around issues of evidence, then what comes to our minds is the publications. How many publications do we have about maternal, newborn, and child health care? How many publications do we have on interventions that are working, and things like that, reviewing WHO records, things like that. But I want to say that there's an opportunity. The opportunity that we have is the existence of data that we collect routinely from our programs. It's important that us as healthcare workers, we take a pause and try asking ourselves questions. These data that we collect on a daily basis, on a monthly basis, on a yearly basis, how is it helping us to inform decisions and inform programs around healthcare? And that is the key question that we have. Many a times, we are data generators, but not data users. And we normally say that data is not useful unless it is providing insights that inform decision-making or delivery of care. So thank you very much for bringing that up. Going back to Uzazi Salama app, when we were designing Uzazi Salama app, what came to our mind is that if you look at the traditional approach where mothers used to, or my young girls used to interact with their elderly moms, grandmothers, just asking their grandmothers, when I feel this kind of tickling in my womb, what does this mean? But remember, the kind of lifestyle that we have currently does not allow us to be able to share the challenges that we face as mothers, to share our aspirations, and even share our concerns. So the initial name of this app was Bump Buddy. A Bump Buddy is a buddy that walks the journey with this mother throughout that pregnancy. That was their initial idea. Do you have a bump buddy, a buddy that you can talk to, oh, something is happening here, or that can call you, can come and visit you whenever you have a challenge you can reach out to. So since then, we have grown this, and to call it Uzai Salama app because it is bringing more than just the bump buddy into helping in decisions around healthcare. So just briefly about the bump buddy or the Uzai Salama app. One, it ensures in addressing key challenges within the health system. One, and we all know that the number of women attending ANC before 12 weeks is very low in Kilifi County and in many other parts of the country. That is one thing that the Uzai Salama app is helping us identify, to increase the number of mothers that are coming early so that they are able to attain the 8 ANC that is required. Two, retention in care. Sometimes mothers come, but they are not retained in care. They disappear. And thirdly, to ensure that we have personalized care, that every mother is well taken care of in a personalized way. So what are the systemic gaps that this app is addressing? One, it supports the healthcare system to be able to retain mothers in care and get the required number of services that they need. That's one. Two, Uzai Salama app also allows the healthcare system to be able to provide differentiated care to mothers based on their risk profile and also based on where they come from. Because remember, these women come from different geographies that require tailored interventions and programs to address that. Three, Uzai Salam allows us to strengthen our referral systems. Remember, Uzai Salama app allows the healthcare worker to refer that client to care at another level, at a higher level. For example, if this mother required more specialized care, then they're able to allow that. So using this app, you're able to know how many of our mothers default when we refer them to a higher level of care. And that helps us make decisions and strengthen our referral system. Last but not least is the issues of accountability. Uzai Salama app allows us to have visibility of the challenge, of the number of mothers that die, number of children that succumb, number of mothers that are within care, number of women that are defaulting. Through that, we are able to account. We remember our mantra is accountability for every mother and every newborn. Now, lastly, and most importantly, for us to achieve this, and I'm linking this to one of the questions that one of our members asked earlier, that for this to work, there must be elements, principles that we must follow up. One, issues of governance, that the data is accurate, data is well taken care of, and data is owned by a government. And there's an act to that, Data Protection Act, and also issues of Digital Health Act that gives us the confidence to be able to use this data, to be able to get this data. The second thing is that as we talk about the apps that we have, what my brother talked about, the interoperability, the integration, so that we avoid a situation whereby we are duplicating data, or we avoid a situation whereby we are having data that is not being used to address system gaps. And then lastly, and is the aspect of capacity. Do we build the capacity of our healthcare workers, our program managers, to be able to use this data and use this data to make decisions? Thank you.
Polycarp, thank you very much, John. About you have talked in a broad way about how we can do interoperationality of the applications we have, use of data for decision making, etc. So I want to pass this to Polycarp in a short way. How can Kilifi County leverage evidence from global and national newborn quality improvement models, such as NEST 360, KMC Scale Up, oxygen ecosystem? You have heard Dr. Kashero talk about issues of oxygen ecosystem strengthening, to design an integrated newborn survival package that fits into the rural context.
Thank you so much, Ken, for that question. Just to dive deep, I appreciate that there have been very significant efforts recently, both in country and even globally, to address both maternal and newborn mortality. And I will say as ICRHK, we are taking the bull by its horns by addressing both the mother and the newborns in alignment with the every woman, every newborn, everywhere. I'll just give one or two examples of what is there across. And currently we have several updates in regards to how do we end preventable maternal and newborn deaths. And we've had several recommendations, both from the WHO, which have been adopted in the country, including the emotive care bundle for PPH. And we also have other areas that are being pushed, like having caffeine citrate, the CPAPs, and all that for the newborn. I think Kilifi is at an advantageous point from where I sit, because one, I think as a county there is goodwill, both from the leadership of the county and even the different facilities, and everyone has a burden to see to it that we end the preventable mortalities both. One of the areas that I think Kilifi can leverage on is the recent Kenya Health Quality Assessment that was released by the Ministry of Health, and it brought about glaring issues around. And I think one of the issues from the report was that nationally we have about 5%, only 5% of the facilities nationally provide the whole spectrum of quality ANC services. And so when we speak about women who require to go for ANC, it is not just ANC, but we should emphasize on quality. It means they should get the whole range of the required services. We look at the facility infrastructure. Does it meet the standards, the quality standards required for it to be designated as that kind of level? There's also one study that I think Kemri Wellcome Trust published recently, and it shows disparities in terms of the healthcare providers. It showed that we have, within the country, we have about one nurse taking care of about 19 babies, on average. That's in a public facility. And you'll find a baby getting an average of 30 minutes in a 12-hour shift. So you only get to see a baby, or they get attention, they receive care for 30 minutes in 12 hours. If we can look at those and review and think about how do we improve, one, our workforce, two, the services that we give out there, three, the availability of health commodities. And I'm also glad the ministry finally has launched about 3 weeks ago the small and sick newborns and the newborn investment case, that I think Kilifi can look at that and we can support in tailoring to meet our specific context, so that we don't reinvent the wheel, but we use what evidence are out there to improve the quality of services for both our mothers and the babies.
Thank you very much, Polycarp. I think there are so many models that are coming up. I hoped you will talk about NEST 360, but we are going to continue with the conversation as we move on. Pauline, I want to say that over the time, actually for our data, our maternal data, antenatal care data, around 85% of our mothers are anemic. And that's a big problem for us in maternities, because majority of these women are coming, they get PPH, and they die out of course, issues of blood and what have you. So from your nutrition MNH integration work, what evidence demonstrates the impact of maternal undernutrition and anemia on maternal and newborn outcomes in Kilifi? And what targeted interventions are you assisting us in providing, in improving that are proving most effective?
Thank you so much for the question. I want to start from yesterday. We had some presentations, and one of the presenters reminded us that the stunting levels in Kilifi, we are at 37%. And this takes me back to Professor Ann Kihara, the president of FIGO, when she was assisting us in coming up with the obstetric care SOPs. She kept reminding us that malnutrition starts in utero. And as you have alluded to that, that is where it all begins. That, as you've mentioned, 80% of our mothers, or about 50% of our mothers, are anemic. And this is due to the lack of the nutritious foods that they're supposed to take. And the other thing is because that this is also multi-generational. It's an intergenerational issue, cycle that affects the mothers, that you find that since we also have issues of adolescent pregnancies, you find that an adolescent will also give birth to a malnourished child who will also grow to also be malnourished and maybe just continue with the same generation. So like you've mentioned, in the recent maternal, infant and young child nutrition survey that we had in 2023, it was noted that most of our mothers, 1 out of 10, are the ones that are taking the minimum dietary diversity that pregnant women are required to take. So looking at that, it tells us that over 90% of our mothers are not accessing the required diets. And the other thing that contributes to that is the low purchasing power. So this shows that it's also multi-sectoral issue, not just the a nutritional or health issue. So one of the other outcomes, I think it has been alluded here by many of the presenters, is the issue of low birth weights. We know that for Kilifi, we are above the national levels. Kilifi, we are over 12%, and the national levels are 8.7%. So these issues of low birth weights are also associated to the poor nutrition and undernutrition that our mothers are facing. And I think we've also been discussing about issues to do with preconception care that is also lacking. We know that most of our mothers, even as ourselves, most mothers here, if you asked us if we ever prepared for anything, for pregnancy, most people don't. You just find yourself into it. So, and on to the second part of the interventions that are working for this, we know that WHO has recommended we carry out IFAS, iron and folic acid supplementation for all pregnant women, and especially where anemia is prevalent, like in places like Kilifi County. So that is one of the interventions that together with the county we are doing. And as Helen Keller, we are supporting the county in providing the iron folic tablets to just come to stop the stockouts issue. We have provided 12 million tablets of the same, of IFAS, that is targeted to over 63,000 pregnant women in the county. One of the other working interventions is infection prevention. I know a lot is also happening, coming from other efforts from other partners, that is prevention of malaria and also deworming among the mothers. The other thing is also to have targeted nutritional support for these women who come and are already malnourished. So going with the thresholds that are required, some of them are targeted for food by prescription to address malnutrition matters. And as Helen Keller, I know we have also provided a number, almost 36,000 sachets of FBF that is going to these malnourished women, just to make sure that they improve their delivery outcomes as they deliver. The other thing is working with our community health strategy. I know we have a potential and a big opportunity to work with community health promoters to assist us in early mobilization of mothers to come early for ANC services. And if this happens through the system, it will come in handy, because then they are able to receive the IFAS supplements in good time, and then they are able to access all the other services to ensure that the outcomes are ideal. Yeah. Then the other thing that I should not forget to mention is the point of care HB testing. Point of care HB testing, I want to give an example of Kilifi North, who are doing this, I think, in all their health facilities to ensure that once the mothers come to the facility, they're tested, they get to know their HB levels and start them on the adequate care that is required for them. Thank you.
Thank you very much, and thank you for mentioning that. So many efforts going across the county. We even have others in Malindi. So my friend Aquinius, I think that's the name. Yes. Aquinius. So Aquinius Strides is coming on board, and we are very excited. So the biggest problem that we have in the facility is that if you ask of most of the healthcare providers, they'll tell you that we lack basic equipment, and we lack space, and we lack privacy. Those three things are a big problem for us. So what do you think should be done to help us, especially in maternal health care, to reduce the problem with equipment and the problems that are mentioned, issues to do with privacy, and also basically develop the infrastructural a space for mothers to deliver well in our facilities?
Thank you, Miriti. For the question, I'll look at it from two different perspectives. One from what our colleague talked about when he talked about quality, that when you look at the 6 pillars of WHO service delivery is one of it. And he mentioned something that I want to quote: providing quality service in appropriate facilities. I think that struck me. Again, when he was talking about component of quality, he talked as a infrastructure, as a part of system input, which is very key in terms of delivering the service and also the interventions in M&H areas. I can't speak about infrastructure, equipment, without looking at the intersection between climate change and M&H and all these facilities and equipment. As you know, those who are in the space of climate change, there is evidence of disproportionate impact of pregnant women and newborns in terms of climate change. Ideally, we have pregnant women and neonates being much affected, being much vulnerable to climate hazards. And also, when you look at the health outcomes from the effect of climate change, for instance, in Aga Khan Hospital, we took data from 2017 to 2024, trying to look at the impact of it on, for instance, low birth weight as one of the components. And it's clear that there is evidence of effect of heat on low birth weight. Again, in terms of infrastructure and climate resilience, which is key, because we put these equipments, we renovate facilities, but we don't look at whether the design and the building is climate smart, climate smart health facility, in the sense that the facility itself is climate resilience when you look at our mitigation adaptation actions that we're taking, and also the facility as low carbon emission. In fact, I like when my sister talked about the issue of malnutrition, talked about low birth weight again. When we emit so much in the atmosphere, then we create a problem which is detrimental to the health outcomes. So simple things, passive and active cooling, instead of we put ACs in our rooms, but we are not careful on what kind of refrigerant we are using. We are treating our children who have respiratory issues with inhalers. We are not careful. The global warming potential of the inhalers we are using. In ORs, we are using anesthesia gases, but we are not considerate on the global warming potential of the anesthesia gases we are using in our facilities. It's very important that we look at this aspect. We have lights that we are using, a lot of energy use. Again, passive and active nature-based activities. We have our facilities. We don't care about providing shades, planting trees around the facilities and all that. He's talked about essential infrastructure. I'll be, other than privacy provision in M&H areas, I also look at essential infrastructure that also takes care of water, sanitation, and hygiene, which is key action that we take. As Aga Khan Hospital Mombasa, and AKDN in general, we developed a tool to measure carbon emission in health facilities, and that's one of the interventions we'll be rolling out under strains. Is a tool that is approved by WHO, which is at our use, and maybe as we move on, we'll be able to talk about more and more. Thank you.
Thank you very much. Let's give an applause to them. So because of time, I want to give only one person a chance, and that's Dr. Busra, because all these are partners. I want to give you this chance. to make a wish to them. So, what is your ask to the government and partners in regards to helping healthcare providers reduce maternal mortalities in Kilifi County?
Okay, it's just three. Number one is the personnel, staffing. The number of staffs currently in our units are very few, so I think this will go to the county government. If we can increase the personnel in terms of numbers, because currently the staff to patients ratio is wanting, which impacts directly on the quality of care. When you look at antenatal clinic, you will find a nurse with 60 mothers that she's supposed to give them antenatal care. So she's supposed to dispense the IFAS, review the labs, and then talk to them about danger signs. This one nurse, how much time will she allocate each client? That on one for the quality. We like to talk about number of ANC visits, but we need to look at quality of ANC visit, so that even if this mother comes for only one ANC visit, we are able to maximize on that particular visit. So number one is personnel. Number two is commodities, that is essential drugs. No maternity unit should be operating without essential drugs, and this includes blood and blood products. And lastly, we improve on our referral system. If we'll be able to support these three pillars, that is personnel, commodities, and referral system, then I'm sure 100% that we'll have zero preventable maternal deaths.
Thank you very much. And I always say that solutions for maternal mortalities are at bedside. That's why we should take regard of what our healthcare providers, the frontline healthcare providers tell us. Let us give them what they need. Most of the times we give them what we feel in boardrooms, but it is always good for us as we program as partners and as donors, let us listen to the healthcare providers and the people that really touch the patient. Thank you very much. I want to thank you for this. Please stand up for a group photo. Thank you. Let's have a group photo, then we leave. It's time for tea. It's time for tea. Let's go for tea. Then when you come back, you are going to have a short period for questions. Thank you. The panelists are still here.
Welcome back, colleagues. I think we should have encouraged our colleagues to just pick their coffee and come back to the room, but I think that is going on, being enforced by Rogers to get people back to the room. We've now come to the fourth plenary session. It's going to be a very, very short one, and we're looking at primary healthcare experiences in operationalization of PH-need networks. And I want to invite Elizabeth Omondi, to please come and usher in the two presenters as we move on quickly to plenary 5.
Good morning, everyone. I hope we've had a great tea. Those who are getting in, please get in so that we can start. My name is Elizabeth Omondi. I work for Uzazi Salama, supporting a program on reproductive, maternal, and child health interventions in the county. And for this session, we are going to have a sharing on primary health care. We are going to listen to presenters that are going to share their experiences in terms of implementing the primary health care networks. And you know, currently the county is going through this implementation. And I'll request the presenters that are coming that you have 8 minutes to present. And our first presenter is
that which can be replicated in other countries and even in other counties, like we have done in several other counties. And that's basically what came out of it. An example of Rabai PCN model, where you can see we have the hub and spoke model. We have the network drawn very well, and the coordination is now ongoing. And then distribution of the super hubs. Again, this is a hub and spoke model, but Kilifi County again came up with a sub hub, so that we have a super hub, we have a sub hub, and we have the spoke. What we call the 3 facilities, we call them the sub hubs, and then we have the super hubs, that the level 4 facilities, and spokes being the dispensaries. Then a conclusion, to sustain and expand these gains, the county must invest consistently in health workforce, strengthening commodity security, reliable financing, including performance-based mechanisms, and continuous data use for decision making. So the experience positions Kilifi as a national leader in operationalizing USC through strong primary health care systems. So credits to all those people and others that are not there, if you are, for work that we have done to establish those, to establish the model, which has actually been used in the rest of the sub-counties, so that we have 100% coverage of PCNs. Thank you very much.
A round of applause for Mr. Miriti. I'll request you to have a seat. We'll take questions after this. At this point, I want to welcome Dr. Mariam. Dr. Mariam is going to share on a presentation on our journey with antenatal point-of-care ultrasound, nurses' experience, bringing ultrasound to primary healthcare facilities in Kilifi County. Is Mariam in the house? All right. So you can take it away.
My names are James Lewa Chishenga, a nurse by profession, working in Kilifi County, stationed at Dida Dispensary, that is in Ganze sub-county. So me and my colleague Bakita, we are here to share our experiences on point-of-care ultrasound, bringing it into our primary healthcare facilities. Point-of-care ultrasound is, the focus is basically an ultrasound that can be performed by either a nurse, a clinical officer at the bedside. This point of care ultrasound doesn't replace the it doesn't replace the comprehensive ultrasound that is normally done by our colleagues, the radiographers, but it is just a supplement. And ours is just screening to identify the edge cases and which enhance in clinical decision making and making early referral. So those are the outline of our experience. And just as I have just highlighted, so why do we need POCUS, the point of care ultrasound? It's because when we go by the WHO recommendation that all our pregnant mothers should at least get one basic ultrasound before 24 weeks of gestation. And when we look at the Kenya Health Facility Census report that was done in 2023, we found that only 1 in 10 facilities offer basic radiology services, that is the X-ray and the ultrasound. And the reason for the decrease in access to ultrasound is simply because shortage of skilled ultrasound providers, limited or unlimited equipments, weak imaging effects. So our aim is just to share our experiences implementing antenatal POCUS, that is the point of care ultrasound in primary health facilities for the last 4 years. And as well, share success of partnership when the county government, donor, the private organization work together to improve access to maternal care. So our context of experience is drawn from the 3 weeks training that we were given, which was done in Mariakani. Then, after that, we were engaged hands-on with Mimba Wangu. Then another project came in 2023, which is running to date. And the aim of the project, that is IMAMA, is to take ultrasound to the AI level. So, my colleague will speak about the experiences that we had, the challenges, and probably the take-home messages. Thank you.
Good morning. I'm Bakita Nyambu, a nurse from Gotani Health Center, Kaloleni Sub-County. What we experienced during this study, we were all excited at first, but still in fear. Remember, you are a nurse only limited to conducting deliveries and among other services. So for us, we were continued support from our trainers from Aga Khan and also from Philips. And from there, we were able to gain confidence, and we were able to have more skills in providing these scans. We had multiple number of increasing women attending antenatal care due to these services, because now we had like 8,000 scans so far, and due to these scans we are able to detect high-risk pregnancies like oligohydramnios, polyhydramnios, and also placenta previa. We have a very unique case whereby our mother went to the routine antenatal care, and the trained nurse there performed the ultrasound, and she detected not 1, not 2, but 3 fetus in her belly. They were both shocked, the mother and the nurse. So the nurse there was able to counsel her, advise her accordingly the importance of referral, and she went to Kilifi and delivered her 3 healthy babies. So that is the better outcome that we all want to achieve. So, thank you. We also have some challenges here and there, like increased workload can also make us have delayed service delivery, and also some mothers still present late in their NC clinic. So this one will delay us in detecting the early high-risk pregnancies. Our take-home message is we nurses in primary health care facilities, we can safely and effectively provide antenatal POCUS when we are mentored well, trained, and clinical oversight. Thank you so much. There is a beautiful photo of us, Team Aga Khan, Team Philips, and our managers from the county government and our sub-county teams and the nurses. Thank you.
You can do better than that. Thank you so much for sharing your experiences. We'll take 2 questions. 2 questions for each presenter. I know James and Bakita, they were doing one presentation. So by show of hands, 2 questions. 1. You don't have questions for them? Then comments, now that they've shared great experiences. Ni smiles too. Oh, thank you, thank you. Thank you for that encouraging hand. Any other?
I have a question for Ken Miriti. Thank you so much for sharing the progress of the primary care networks in Kilifi. I know you highlighted Rabai as one of the PCNs that is working. So 2 questions. The language that I'm familiar with for PCNs is hubs and spokes. You talked about a super hub. If you can please tell us if a super hub is slightly at a higher level, then if you could just tell us a little bit about what's happening in the other sub-counties. Is it that the Rabai PCN is the one that is most active, and what's happening in the others, and what has contributed to Rabai PCN, being the one that you highlighted as most active? Thank you.
Yeah, thank you. Thank you very much for that question. I have shared a model that was used by Kilifi County for the establishment of PCNs. I was not sharing the best, I was sharing the model. I actually shared what we did to come up with the PCNs. And the reason is initially when we started, with the Rabai was the first PCN that we tried, actually we piloted the model with. We had to bring somebody from Kisumu to coach us on how to establish PCNs. And so we had our whole team from national level and from Kisumu, and when they came, we realized that whatever they were telling us was not working for us. So we decided to remodel how PCNs are supposed to be established, and we came up with the model that I've actually shared. So basically, whatever happened in Rabai for the first PCN was replicated in Kaloleni, which was the second one. We grew further better in Kilifi South, and much better in Magarini, and then the rest of the sub-counties, where we have PCNs, used the same model for establishment of their PCNs. So the language in PCN is a bit new for people, and I know that's why people are wondering what was this he was talking about. But actually, there is a paradigm shift in terms of provision of care in the country, where we are now doing we are now focusing on prevention more than curative services. So the PCNs are established to interlink, and yesterday Professor Barasa mentioned it, to interlink the facilities, the lowest actually the household to the facility, to the lowest facility, that's level 1, level 2, to level 3, level 4, and then level 5 and 6 going up. So where it ends is actually at level 4, which is called the hub, and then we have the dispensaries, which are the spokes. That was the initial. And for Kilifi model, we came up with a sub-hub, because the super hub is actually the level 4 facility. A sub-hub is the health center that can provide most of these services that can be provided at level 4 facilities, although not at a specialized level. So what is happening in other sub-counties? We have established 7 PCNs in the county. So the rest of the sub-counties established their PCNs. We are now working towards operationalization of smart PCNs. And that's where actually we are telling our partners to come in handy to help us to come up with smart PCNs. Thank you.
Thank you so much. Any more questions? The room is very silent. Thank you. So a round of applause for them. We'll have a group photo. Hakuna mtu wa picha? Haya. Asanteni sana. Thank you so much. I'll welcome Mr. Kamau to take us through the next session. Thank you so much.
Thank you. A better hand to that plenary. I think most of that plenary, most of it went into the posters, so please make sure that you go through the posters. Alan Zablon will be taking us a very short presentation for about 8 minutes on mastering AI. This is what you're calling a quick masterclass. After this, he's happy to come to the organizations and do the same.
Thank you. Good morning, everyone. I hope you're all well. So, I do have a presentation. So I've been hearing lots and lots of talk around data. And most of the times we say we have the data, but we don't use the data. I'm hearing most of the time when you need to do a research, you have to send people out, collect the data, come and analyze. But most of the time we realize that we actually have that data. We don't use that data. So this is the beginning of all the problems, paper. Right? If you have paper, if you write your records on paper, on the black books, that paper is not searchable, right? Can you type control find and search a paper? No. If you have paper, it cannot really be analyzed at scale. You'll need someone to possibly come in, type in those records, and you to be able to analyze that data. But I'm not saying that paper is a problem. It is just the beginning of a very comprehensive life cycle of how a health system matures. So I believe most, if not all of us began here, and then now we move to the edge of the EMRs. EMRs in themselves are not so clinical focused. They are more or less transactions. So someone comes to the hospital, we get a record of them. But if the same fella goes to a different hospital, say in Mandera, will you find their records there? Will you find their records there? Exactly. So with this, we cannot really have longitudinal view of the entire patient's journey, right? And I believe most of us could be here. But now here comes the edge of the EHR. So what is an EHR? I know most of the times we use these terms interchangeably. So an EMR is basically like a digital version of the paper charts you write. But an EHR is a clinical focused. So think of this. You go to a hospital, probably suffering from sepsis. The doctor writes a couple of notes. Those notes will likely be found in an EHR. And someone, somewhere, some doctor in a distant place can be able to check and actually see what the doctor wrote about you, about the infection you had. And this in itself defines our journey as the Aga Khan University Hospital in Nairobi. So it is a journey that has taken quite a long time. So before then, we did have, of course, everyone starts with paper. And then in 2008, we moved on to an EMR. But in 2022, we moved on into an EHR. So this EHR enables like a full longitudinal analysis of a patient across all their encounters. And this EHR is available in all the Aga Khan University Hospital and outreach clinics for Nairobi. So in this case, it has taken us quite some time to move from paper to a full paperless system, about 14 years. And the only paper you'll actually get to sign at the University Hospital in Nairobi is the consent form. So This in itself gives us a really good picture. And there are county government officials here, and many a times when you think of systems, it suddenly becomes a procurement issue or an IT issue. Transitioning from paper to an EHR essentially is not any of those. It is a change in the clinical mindset. We need to think of how we're going to improve our patients' outcomes and capturing their records appropriately. So from all this, we have all this rich data set. How are we going to use it to actually power AI? Here comes what we call the data repository. So when data gets into an EHR, it is not really in a usable form, right? So if you have plain text, like a doctor's note, how are you going to analyze that at scale? And considering that the Aga Khan University Hospital, our current data repository has 3.2 million plus patient lives. How are you going to analyze that at scale? Here comes the data repository. This is now where we have done our data pipelines. The data pipelines essentially clean the data and make the data available for whoever wants to use the data for any other research. And from this, we are now getting to enjoy some of the fruits. And I'll take you through a simple project here called the Afya Jema project. It is a clinical decision support platform. More or less, people call it the AI solution. So with this, for now, we have only loaded the clinical guidelines, the curated clinical guidelines on how a doctor or a specialist should treat a patient. But now, think of the impossibilities that we can actually overcome if we plug in the electronic health records data. You'll be able to get personalized data that is really optimized for your care. And as I said, we only have 3.2 million plus records. But now think of the scale of moving global. We do have the concept of federation. So federation is a point whereby you have the data, someone else has their data, you get to experience their data without you sharing their data to them or them sharing their data to you. So think of this, you have, I think you have the Jumuiya Makaunti za Pwani, right? Kilifi has its own medical data. Mombasa has its data. You want to do comparisons. Research has been done and maybe a machine learning model has been done, and you want to validate that model against that. So currently the Aga Khan University Hospital is in the process of joining a federated global network. And with that, we will not only have access to seeing the insights from our 3.2 million plus records, but we are now getting access to actually have a feel and test our models on 32.5 million plus patient lives across board. And all this has not been possible. It's all a team effort. And I would actually encourage you guys to scan that QR code to know the guys behind all this. Thank you so much.
Thank you very much, Zablon. And as said, he's very happy to offer some of these insights through your CMEs and seminars or otherwise. So please scan the QR code to get more information about him and his team. I want us now to move very quickly to the final plenary session of this symposium, that is plenary 5. And let me invite Catherine Monyoki. Catherine Monyoki, who is the head of preventive and promotive unit here at Kilifi County, co-chaired by Abednego Kioko, rapporteured by Walter Kagohu, and to take it up from here. Catherine.
Okay, good afternoon. At this juncture, let me call upon the presenters. I start with Professor Isabella. Come forward, please. You'll do a presentation on advancing malaria surveillance and control through health facility-based molecular innovations. So kindly start doing the presentation. Thank you.
So good afternoon, everybody, and thank you to the organizers for this opportunity to share some of the work that we're doing at the Kemri Wellcome Trust Research Program to move molecular tools into the public health space. Oh, wrong direction. So by way of introduction, malaria, just to remind you, is still a deadly disease, and there's a resurgence, and there's a storm coming. And why are we particularly worried about that? Because the current statistics as of 2024 was that we had about 282 million deaths globally, and 282 million cases globally, and 610,000 deaths globally. However, there are projections that with this perfect storm that I'll explain shortly, that they're projecting 525 million cases and then 990,000 deaths as of 2030. And why are they projecting this? Because of climate change. There's also a rise in drug resistance, insecticide resistance. Of course, we know there are global trade disruptions and global insecurity. And so what's that's going to do is reverse the gains we've made over the last 2 decades in terms of controlling malaria. And what it could potentially do is take us back in time in the year 2000, when we had about 864,000 deaths due to malaria. So as you can see, over the last 2 decades, between 2000 and 2024, we've made a significant reduction in the number of cases and deaths due to malaria. So I'll just bring it back to Kilifi, where we have had a presence over the last 30 years in Kilifi County Hospital. And we looked at the number of malaria admissions. And in around the 1990s, we had about 50% of your admissions in Kilifi County Hospital were due to malaria. And this was severe malaria. So when you went to the high dependency unit, you would find maybe 3 to 4 children per bed with severe malaria. We moved to about 2009. And we had a reduction. Only 7% of your admissions in Kilifi County Hospital were due to malaria. So that's a major shift in the the burden of malaria in our county. As you can see, that line is rising. And that's the challenge that we will need to face for malaria. And so why is it rising? Because we have new challenges for malaria. We've seen the introduction of a new species of malaria mosquito vector called Anopheles stevensii. This species of malaria vector is usually found in Asia, Pakistan, Iran area. But now it's introduced. It's come into Eritrea, into Ethiopia. We've even identified it in Kenya. And what does this bring? It brings a new challenge. Potentially, you won't find malaria only in rural areas, but Anopheles stevensii is actually an urban vector. So you might find malaria cases in our urban areas. And then with that comes the challenge of insecticide resistance. So when you're doing your indoor residual spraying or using your bed nets, it might not protect us and prevent malaria. The second challenge is what we call diagnostic resistance. I think malaria is the only disease that actually can escape detection from a rapid diagnostic test. So that's unusual. We usually use microscopy in our health facilities, even here in Kilifi County. And in around 2018, globally, there was a massive increase in the number of rapid diagnostic tests we used. And that changed the landscape of how quickly we could detect malaria cases. The malaria parasite that's found in the blood that causes this disease is very clever. And it changes its genetic makeup. And so it's able to escape detection by removing a number of genes. For the sake of your biology lesson for malaria, you will learn that there's histidine-rich protein 2. That's what you use in your rapid diagnostic test. When you're now infected with malaria, some of the parasites don't have this protein. So you won't detect it with your rapid test. So it's now invisible to detection. So that's a case management problem. And these deletions have been found in Eritrea and Ethiopia. In Kenya, we've been doing screening for these using molecular tools, and the reason I put it in green, because it's not a problem as per WHO standard. But that doesn't mean you don't want to keep checking. So we did the checking in Kilifi County in one of the dispensaries in Pinglikani, where we have malaria monitoring study going on. So we do a rapid diagnostic test, we do microscopy. And what I just want to highlight here is our concern, really, is this box here, where you're RDT negative and microscopy positive. And we found about 12 of the samples with that scenario. So what we did is take those 12 samples, which is here, there, that column, and did the molecular analysis. And this is essentially a PCR test to determine whether these parasites that we couldn't detect by we detected by microscopy, but not by RDT, had these proteins removed. And when we looked at genetic makeup of the parasite, luckily, luckily we found it was 0, so look at column 1. However, we just extended the sample set by using real-time PCR, and what you see in the red circle is it's at about 2%. So there are parasites in Kilifi that have these 2 deletions, so might make it possible that when you look for these cases in the health facility, you won't find them. No cause for alarm at the moment, but just to take note, it's at 2%, which means you want to keep monitoring and making sure that our RDTs work. Our third problem with malaria is artemisinin resistance. So currently, you know, our first-line treatment is Coartem. Second-line treatment is dihydroartemisinin piperacin or duocotexin. And what they found in Southeast Asia, where these problems generally begin, is that the parasites, again, have these genetic changes that allow the parasite to escape treatment. So you will treat with your AL, and it will not work, and the parasites will continue to grow in that patient. So the problem initially was in Southeast Asia. That was about 2008, and we thought that's far away and we don't need to worry. But as recently as 2015 in Rwanda, they found parasites with these genetic changes. And when they looked, they found that actually after 3 days of treatment with AL, these parasites were not going down to 0, and the patients were not clearing as fast as they used to. So if you look at the red dots, that's Uganda, Rwanda, and Tanzania. They've shown these studies. In other countries where you have the orange dots, including Kenya, we do have these genetic changes in our population. So that, again, is a cause for concern. If we lose our first and second line treatment for malaria control, we will have a problem in terms of case management. Wrong one. So there's a cost to having anti-malaria drug resistance in the public health system. And this has been shown through time. Initially, our first anti-malarial treatment was chloroquine, when the cost of the drug or treatment was potentially 40 shillings. As we move on and kept changing drugs, if you look at artemether lumefantrine, you've had a 163% increase in the cost of having this change of drug resistance. And dihydroartemisinin piperacin, our second-line treatment, the cost is 400%. So that's a public health cost in terms of what we need to do in our health system. The other challenge with antimalarial drug resistance is when you have resistance, as we saw historically when we used to use chloroquine, this was in the late 90s, there was a 2 to 3-fold increase in malaria deaths and admissions. And that's why I was showing you the statistics in the beginning, that if we don't control this, we could go back to the year 2000, where deaths due to malaria were very high. And of course, the impact on public health is increased morbidity, mortality, hospital admissions, and hours away from work. And in terms of your economics and productivity also goes down. So again, I show you data from Kilifi County Hospital, excuse me, where we've looked over about 20 years of sampling from patients who've been admitted to Kilifi County with malaria. And we take the blood sample, do a microscopy, and take the blood sample on a filter paper, and then screen them over time. So if you look at the red line, that's where you have the genetic change, what we call a mutation, to chloroquine. And if you look at the peak in the late 90s, where we had chloroquine resistance, we had a lot of these mutations. But then when we did the drug policy change and had a cost of increase to the public health impact, we have had a reduction. So there's value in monitoring these things using molecular tools to understand what the impact will be. And so you see the black line, those are the parasites that can respond to the chloroquine treatment, and those are rising in the population. So that's a positive outcome from using molecular data. But this is historical. So we did this study way after we've changed and we're in the AL era. Thank you. So what are we doing now? We want to move what we've been doing specifically in Kilifi County to a national scale, even to a continental scale, because I've shown you that we have a problem with antimalarial drug resistance. So we're developing tools in the lab here at the Kemri Wellcome Trust Labs to take filter paper dry blood spots, an easy way to ship blood across the country without it being in a vial and no cold chain, and that's kept at room temperature. we look for the parasites, and we sequence them. So in COVID, you probably remember COVID sequencing, where you had the alpha, beta, gamma, the whole Greek alphabet of variants, and we're able to look for these variants in the malaria parasite, the ones that will cause problems for drug resistance. And we're able to use next-generation sequencing tools. These are from companies like Illumina and the Oxford Nanopore, and use that to do at scale, looking at drug resistance, diagnostic resistance, and just understanding how the parasite population is changing in our setting. And so with that, we've developed what we call the AMDR-AMSeq panel, where we're able to look at the drug resistance markers in the malaria parasite and monitor those over time. So we tested this tool on a school survey that we did, a national school survey, where we went out into our primary schools, including here in Kilifi, in collaboration with the Kilifi County team, health management team, as well as the education, as well as within the Ministry of Education within Kilifi County. We collected these dry blood spots, as you can see them in the image there, and went around and collected the dry blood spots as well as RDT, malaria RDT, to understand how many children in our schools have malaria. And this is the map for the period with all the dots where we were able to sample school children. Kilifi, you can see it at the bottom there, but I'll zoom in the next slide. And all those dots is where we sampled in 2021 and 2023 to determine whether we have any of these artemisinin resistance mutations, ones that would cause a problem for us if we gave any of these children AL, artemether-lumefantrine treatment, or Coartem. Thankfully, in 2021, we only found one variant. As per the WHO standard, it is an important variant, but we've not seen an increase in that variant. In 2023, we saw another variant, again, not of major concern. So we put it down that we've not found any what we call artemisinin resistance mutations or K13 mutations between that period. And this is in school children. So these are children in school with no fever, but they have malaria parasites. So I'm presenting another burden of asymptomatic malaria in our population. However, they have no mutations. So we looked in our Junju and Pinglikani dispensary studies, where you have cases who are coming in with symptoms and asked, do these patients have these mutations? And they don't. However, the story is different in the west of Kenya, all the way from Turkana County, all the way down to Migori County, and a small glimpse in Kwale County. So along the western corridor of Kenya, we do have these drug resistance mutations. And these have been reported to the National Malaria Control Program. So I just show you in 2022 what we did in Western Kenya, and 2023 at the bottom. And I'm essentially saying where I put the red line for the 675 variant, that there's been an increase in the 8 Western Kenya counties between 2022 and 2023, and we're hitting that 5%, which is sort of that magical number by WHO where you might want to be concerned. Again, these were in school children, so the studies then need to be done at a health facility level, and this is what we're pushing for. So at the health facility level, we are working with 14 counties, including Kilifi County, and thank you to Dr. Muye and the team, where we've gone into 3 health facilities in Kilifi County and have set up a platform where we're collecting dry blood spots and screening for these mutations. And that's the same across these 14 counties where you see the blue dot on the malaria map for Kenya. We've also been working with the National Public Health Lab because we would like these tools not to remain in the research setting, but to go into the public health lab so that they are monitoring this routinely and they can set up these systems. Data was talked about, so we want to have all this data within a repository so you can look at them over time. And hopefully I've shown that when you look at this over time in one health facility, you can begin to see patterns and trends. And so this is the framework to push out this molecular tool into the public health facility level. You go to a health facility, you collect the dry blood spot sample with a case investigation form. We'll try and get that onto an automated system into the central lab, produce a policy brief, and start monitoring whether we have any changes in these drug resistance mutations at health facility level across the 14 counties that I've mentioned. And the idea is then Kenya will be able to, at least through the Ministry of Health, say whether they have these mutations or not, and whether there's any cause for concern for malaria at that level for case management. So this is moving to scale as well across Africa, where the countries that are shown in green, through national public health laboratories, where we would like to make sure we have an early warning system to detect anti-malarial disease resistance, diagnostic resistance, as well as insecticide resistance by doing monitoring vectors as well. So though I've shown you with one example, this will move to scale to really think about malaria control. And so finally, just to thank a whole lot of people that we've been working with, and thank you very much for listening.
Thank you so much. Another round of applause. Get seated, please. Look, we can have the following come forward for the next presentations. We can have Dr. Nadia. Dr. Nadia, please. Dr. Nancy Kangwaja, Dr. Moses Masha, Dr. Paulo Cheng, Dr. Nahida Salim. Kindly come forward. Come forward, please. We can start with Dr. Nancy Kangwaja to start. Because I cannot see Dr. Nadia. Oh, you are the one who is representing Dr. Nadia. Okay, welcome. Come forward, please.
Good afternoon. Yes, my name is Dr. Jamal. I work with the AIDS Healthcare Foundation, and today I will be presenting on apologies for that. So I'll be presenting on integration. Maybe if I could have someone from IT assist me to get. I hope the timekeeper has not started the clock yet. Thank you. So this was basically I'll give you the background to integration, but let me introduce myself first. As I said, I'm Dr. Jamal. I work with the AIDS Healthcare Foundation. I'm the zonal lead for Kilifi County. So basically, I'm in charge of around 11 facilities all around Kilifi County. And what we see right now is we are acknowledging that there is integration that's taking place. Part of this integration comes from the fact that there was a stop work order initially earlier on, but the county was well prepared in the fact that integration planning had taken place earlier on. So let me see if I can get this right. Yes. So we co-authored the study with Dr. Nadia, together with the AHF team, together with the CASCO, Maria Mulwa. Thank you for that. So basically, this is the example of the clinic that we have at Kilifi County Referral Hospital. So for integration, what we see in this picture is there is an intern that's having a health talk to the patients. And what we see is the patients, you can't tell from the congregation or the gathering what diagnosis that they do have, because it's a mixture of hypertension, DM, and HTN, and the hypertensive patients. Yeah. So basically, what we did is, from the background of understanding what's happening currently, is we are very thankful to God that we are living in the 21st century. Why is that so? Because there is a new advent of new medications that is able to treat or, so to speak, reduce the viral load of patients for HIV. We realize that they will live longer, and because our patients with HIV live longer, they are prone to getting some of the non-communicable diseases, including diabetes and hypertension. So this is exactly what the background says. So we conducted a retrospective study. It was a review by our Kenya EMR at 2 data points. We were looking at July 2024 before integration and July 2025 after integration. What is our main target? We want to see from our population how many have been identified as having hypertension, how many have been identified as having diabetes. Are we capturing patients, are we diagnosing patients on time? So the indicators of the diagnosis counts and control proportions, and the analysis comparison using Excel. So basically, what is integration? It is a routine NCD clinic integrated with HIV clinic. In other words, wagonjwa wa sukari, wagonjwa wa pressure, hao wote wanakusanyika na wanatibika pamoja. Sawa sawa. And we conduct multidisciplinary team meeting management together. And there is clinical mentorship and capacity building. So the digital Kenya EMR is actually used for monitoring for these patients. So what was the results for the study? We realized that for the diagnosis trends, the hypertension cases increased. Like we noticed that there is an increase in the hypertension incidences and prevalence. And we look at the diabetes and hypertensive comorbidities, there was a 45% increase. And disease control, we actually also looked at how well we controlled our patients, that is the hypertensive and diabetics. So we realized that there was a 57% increase in patients whose diabetes we controlled, and there was for diabetes and hypertension comorbidities, we realized that there was a 77% increase in controlling the outcome. But this is a work in progress. Integration in the current chronic care clinic is a work in progress. In what sense? There are some things that we can do better. That is, we can follow up the patients better through integrated visits. We can do enhanced EMR monitoring, given the fact that Zablon talked about AI. And at this juncture, we can actually even look at mortality rates from our EMR and from the records and use AI to actually find out and analyze the mortality issues. And then we continue with a continuous mentorship and clinical audits and infrastructural support. For integration to actually work, all patients need to feel like they're at home. It does have a decrease in stigma, but every single patient needs to feel comfortable, okay? So our discussion is integrated chronic care model. It improves case finding and disease control. It's clearly evidenced by the retrospective study. There is reduced client burden via a single stop service delivery, and there is improved provider efficiency and team coordination. So in conclusion, HIV NCD service integration at KCRH markedly improved quality of care. And then we also realized that there is enhanced detection and better control of DM and HTN amongst our patients. Basically, when we were discussing about this study with Dr. Nadia, we did realize that there was added advantages to any patients who are living with HIV. That is, it's a one-stop shop where a patient who's coming to take drugs has other problems, other issues, can also see the consultant, can get the best standard of care. And we'd like to make Kilifi County Referral Hospital be the benchmark for the entire nation. Thank you so much. I think I'll leave it at that.
Thank you so much. And our next presenter is Nancy, Dr. Nancy. Kindly move forward.
Thank you. Yeah, I'm going to present to you findings from study, a work this is early phases of this work, so some of it is still ongoing. And it's about community health worker involvement in hypertension service delivery. We're thinking about the opportunities and challenges explored through a community health system lens. So I'm presenting on behalf of a large group of people you see listed here, and the overall project is improving hypertension control in rural sub-Saharan Africa. So the sub-Saharan countries in which this work has been done is Kenya and the Gambia, but I will be focusing only on our findings for Kilifi. So this is the outline of the presentation. And so by way of background, community-centered interventions for the management of hypertension have been demonstrated in cluster randomized trials to be effective for the management of hypertension. So we've seen that if we engage trained community health workers, we could raise hypertension awareness, we could identify who is at risk for cardiovascular disease, we could also encourage individuals to seek medical care, and also there's been evidence of improved outcomes for people who are hypertensive, which means that their blood pressure is well controlled. And so with that evidence, there are still some important evidence gaps. So for example, what is not in the literature, what we don't really understand is what is required to ensure that the interventions involving community health workers are implemented in a sustainable manner beyond a trial period or beyond a research study. And then secondly, how can these community-centered interventions involving community health workers become routine or embedded within health system context? And so this is what the ICO Africa project seeks to understand. And we did this project collecting data across various levels of the health system to just community health promoters. So now, thinking back to the framework that I have shown you that has both the health system dimensions and the community dimensions, what we teased out about capacities that can support community health workers to deliver hypertension care, this is for Kilifi County, is if you look at the service delivery block in Kilifi County, we have a very good coverage of community health units, almost 90%, and majority of the community health promoters in these community units have received the basic community health worker training, and also they are active. So the community units are active, and community health promoters conduct home visits consistently. Then the health workforce themselves at the community level, which is the CHPs and their supervisors, the community health assistants, are motivated to take on, because this is an additional role of hypertension care. Why? Because for them it's an opportunity to gain more knowledge, it's an opportunity to also understand, because some of them are living with hypertension, so to care for themselves, as well as it increases their legitimacy in the community. And then they have the good support of their community health assistants. On the side of the community, how does the community receive CHPs now being involved in hypertension care when traditionally they haven't? So there's community members appreciate community health workers because of their experience with them for other more common conditions and issues around water, sanitation, and hygiene. And then the links with the community organizations that community health promoters have also enable them to navigate to the targeted individuals. But there are still some unmet system requirements that could constrain the involvement of community health promoters in hypertension care. A major one that came up across all our participants or respondents was the issue of financing and commodity supply. So many of the people that we spoke to who were health managers felt that there was inadequate planning and consultation prior to the launch of the CHP kits, and there were questions about how will this CHP kit continue to be replenished once its supplies are over, and also concerns about, so we have given kits to community health promoters with a BP machine. What about at the facility if some of our facilities don't have BP machines? Another thing was related to the workforce, both at the community level and the health system, on the health system side, where there were tensions. So in this study, we were also asking our participants, what do you think of community health workers being involved, not just in screening, but also in delivering medication and so on. And for some of our healthcare workers, there were concerns about, but that is our role, we need to do drug monitoring, we don't just give people medication, and so on. And on the community side, while they appreciate community health worker involvement in WASH and maternal child health issues, there were concerns about hypertension being slightly more complex than this. So I'm not going to read those quotes, they just demonstrate what I've just said. So I'm winding up. So in summary, we see that there are already existing health system capacities that can be leveraged so that community health promoters can be involved in hypertension care. And I think this is already going on to some extent. But there are some constraints that need to be addressed. Now, in conclusion, expanding the role of community health promoters is an organizational change. So looking at the different dimensions that I've shown you in the previous slides, it's important to address all of this and to also recognize that there are some people that might not be carried along with this idea of community health promoters being involved in NCD care if it is not clearly articulated who is losing which role, who is taking up which role. So in summary, I just want to reiterate what has been said, that adopting a systems view is very important when introducing an intervention such as the one we are proposing. Thank you.
Thank you, Nancy. Thank you, Nancy. Thank you, Nancy. Next is Dr. Masha.
Good afternoon. So my parents named me Moses Masha, but at work they call me Dr. Moses Masha. I'm a medical officer. I currently serve at Rabai Sub-County Hospital. So it's my pleasure today to stand before you and present our work on cancer patterns in Kilifi County. Special thanks to Dr. Omar Abdi Hamid. He was the co-author of this work. He's a clinical oncologist at the Garissa Cancer Center. Now, before we dig in, I'd like to pause and ask a question so that we can reflect. How many of us have had someone they know, either a colleague, a relative, or a friend who has cancer? No, you don't need to raise your hand, sorry. Just reflect, okay? I want you to think about that person, okay? How about their journey? So how easy or difficult was it for them to navigate the system? How did they get the diagnosis? Did they understand the next steps after the diagnosis was given? And how did they access treatment? Finally, what was the outcome? So as we dig into this, think about that person and remember that in every statistic, it's always somebody's story, okay? Okay, so background. Cancer is one of the most aggressive public health challenge currently globally. It is attributed to be responsible for 1 in 6 deaths. Unfortunately, 70% of these deaths occur in low and middle income countries, Kenya being one of them. So we have reported low cancer incidence, but the mortality rates are high, even exceeding the countries that have high incidence rates. In Kenya, cancer is the second leading cause of death in non-communicable diseases. And in Kilifi County, we have a magnified problem where there are late presentations, diagnostic gaps, and also limited access to diagnostic services. So baseline cancer data from the coastal region is scarce. Nationally, we only have the Nairobi Cancer Registry. This is a population-based cancer registry, and the Eldoret one, and recently Machakos had a cancer registry. So our work basically was to provide the first structured baseline data for cancer burden in the county. So I put this slide up here. This was a 2028 data from Globocan about the number of deaths. So this mirrors our findings in this presentation because esophagus, cervical cancer, and breast cancer are the leading causes of death in our county. But this is 2018. According to 2022 Globocan survey, are the same cancers, although right now it's cervix cancer. Second is breast, and then followed by esophagus. So what did we aim to do when we were doing this study? So our aim basically was to answer 3 or 4 simple but very critical questions, depending in who, what, and where. So who are our patients? What cancers are they suffering from? Okay? And then how was the diagnosis done, and how was the staging done? Finally, what was the outcome? So we did a descriptive retrospective study done at Kilifi County Referral Hospital, because it's our county referral hospital, between January 2020 and June 2025. We extracted data from inpatient adult files. So we only took confirmed cancer diagnoses. The ones that were unconfirmed or incomplete data were not included. So data was analyzed and descriptive statistics were used, frequencies, percentages, and means. Importantly, consent from the KCRH management and ethical review were considered. On the results, 101 cases were retrieved, of which 58% were female, 42 were male, 54 was the mean age, showing that cancer is affecting our adults at their most productive years. It actually affects livelihoods, families, and the economy. Geographically, the three main sub-counties, Kilifi North, Ganze, and Kilifi South, shared majority of the cases, with Kilifi North at 47%, and other sub-counties, Magarini, Malindi, Rabai, and Kaloleni had the rest. But this shows, one, either population density, two, disparities in access to diagnostic services, and three, remember this study was done at KCRH. We also have other high volume facilities like Mariakani and Malindi. So Malindi serves Magarini and Malindi, okay? And then Kaloleni serves, Mariakani serves Kaloleni and Rabai. Social economic characteristics, so vulnerabilities were evident. Most of the patients actually reported no employment, and farmers had recorded at 26.7%, formal employment at 9.9%. What were the cancer types? So this mirrors the GlobalCan survey that I showed for 2018. Esophagus and cervix predominate, followed by breast and prostate. Our major concern was about staging. 70% of the cases were not staged. And among those that were staged, more than 50% presented at stage 3 and 4. This is advanced stage. Okay. How was the diagnosis made? The most widely used diagnostic criteria was histopathology, followed by radiology, and the others. Treatment, chemotherapy alone was the mostly widely used. Currently, we don't have a comprehensive cancer center in the county. 50% of the patients were referred to higher level facilities. Follow-up, sadly, we had high mortality. At the time of this study, 43% had passed on. Loss to follow-up were more than 30%. So we found gaps in patient navigation and follow-up and survival cases. Conclusion and recommendations. Key findings. In Kilifi, cancers that are killing our people are esophageal and cervical cancers. There are high mortality rates. We have substantial diagnostic and follow-up gaps. So what do we need to do? We need to establish a county cancer registry, because we cannot deal with what we don't know. Okay? Infrastructure, strengthen diagnostic capacity, and also enhance patient navigation, which is really important. Lastly but not least, when we were opening the symposium yesterday, Professor Shauri yesterday actually talked about preventive measures. So in cancer care, we talk about priority setting using data. Primary prevention, secondary prevention. Lastly, outcome improvement through multidisciplinary cancer care. So cancer does not have a face until it's yours or someone you know. Thank you.
Thank you, Moses. Another round of applause. That was very touching. Next presentation, Dr. Paul Ocheng.
Yeah, good afternoon. I'm Dr. Paul. I'm going to take you through a presentation on one of the studies conducted in Malindi and Magarini. Which one? Yeah, sorry, it's the reverse. Yeah, so my study was titled Correlate of Tuberculosis Preventive Therapy Uptake Among Healthcare Workers And this study was conducted in Malindi and Magarini sub-counties in Kilifi County. Basically, it was to assess or determine the factors that influence TPT uptake by the healthcare workers in these two sub-counties. In terms of background, so TB is an infectious disease, highly infectious, and a major public health concern, not just globally, but also as a country. According to the World TB report in 2022, an estimated 10.6 million cases are reported annually, and out of those we have 1.6 million mortalities. Again, by virtue of how it is spread or transmitted, it is postulated that as healthcare workers, based on their occupation, they are at higher risk of TB infection because of their occupations, and estimately 2 billion people globally, that's 25% of the world population, are estimated to be infected with TB. There's a difference between infection and actually having the disease. So that latent infection is what we call the latent TB infection. However, that proportion is even higher among healthcare workers, with up to 10 times higher risk in that population. And with respect to latent TB infection, the risk among healthcare workers is up to 5.7%, 5.7 times. And this has actually been shown even within Kenya by some two studies in Kisumu in 2015 and the recent one in Kiambu, where 62% of healthcare workers were found to be infected with LTBI. However, there is a solution to TB, managing TB or controlling TB transmission, and that is the TPT, which is TB preventive therapy options available for free in our facilities, and they have been shown to reduce the progression from latency to active TB by up to 60 to 90%. However, in these two sub-counties and Kilifi in general, we don't have existing data on the TPT uptake, and that is what informed the decision to conduct this study. So we purpose to examine the individual, systemic, and systemic factors that influence this uptake. So this study employed an analytical cross-sectional mixed methods whereby we used both quantitative, using structured questionnaires, and then qualitative, where we identified purposively key informants. The sample selection was stratified proportionate with a sample size of 151 of our healthcare workers with a margin of error of 5%. And the key informant interviews were conducted by selecting purposefully our respondents who are key TB program implementation managers. As I mentioned, it was conducted in Malindi and Magarini. The selection was based on the high TB burden in this sub-county, especially Malindi, which also serves Magarini, who, according to the latest data, has a case notification rate of 206. That's above the counties, which is 189 per 100,000, and nationally, which is approximately 165 per 100,000. So this study was premised on two theoretical foundations: the health belief method, model which focuses on perception, as well as the socio-ecological model, which focuses on the individual, organizational, interpersonal, and even policy. So in my findings, the response rate out of the targeted 151, we got a response rate of 96.7%. That is 146 participants. Screening uptake among healthcare workers was 58.9%. Females screened more at 60% compared to males at 57%, but when it came to uptake, which was 29.5% actual uptake of TPT, and in the uptake, male, despite having lesser screening, had higher uptake at 37% compared to the females. Completion rate for those who took TPT was high at 84%, which compares with other studies like in South Africa, which recorded 87% in 2021. Again, in terms of the determinants, The key determinants that we found to be significant were the years of experience, the duration they had served, employment terms, the facility level, and then the attitude in terms of the fear of side effects of these TPT regimens. However, other determinants like other factors like knowledge did not have significant contribution to their decision to take up TPT. The knowledge level were generally high, but they did not translate into actual uptake of TPT. Systemic level factors like availability, like readiness in terms of infrastructure, again, were very strong in terms of readiness, but did not translate into actual TPT uptake. In our qualitative insights, as I already mentioned, you can see knowledge was 95% both qualitatively and quantitative. However, that awareness did not significantly contribute to uptake. Side effects was mentioned by both our key informants as well as the other healthcare workers, and the main one was about side effects. And then the designation of the point of taking TPT, which indicated there's actually even stigma among healthcare workers, was also pointed out by both KEIs and the healthcare workers. So in conclusion, those are the conclusion drawn from the results. So TPT uptake is low despite high knowledge. Attitude, especially side effects, is a key barrier to uptake. And then health system readiness exists, but there's lack of consistency in terms of translating that into action. So we also suggest that it's better to have target, especially the male staff, the PNP who performed poorly in uptake compared to those who are actually on contract as well as temporary terms, pairing of training with motivation cues to translate that knowledge into action, improving attitude through peer, so that to reduce the stigma, you can take TPT as a group, as a department, for instance, so that there's that peer kind of motivation. Strengthening supply chain was identified as one of the recommendations, and also we recommend that maybe in future we can consider longitudinal research so that we can have a clear picture on how there's behavior change along the continuum. Thank you, and we're looking for questions.
Thank you. Another applause for Dr. Paul. Okay, thank you. So I think Dr. Nahida Salim is not here. Dr. Nahida Salim. So if Dr. Nahida Salim is not there, then we can go to a round of questions and answers. And at this juncture, I welcome Prof to come forward. Professor Oyer, kindly come forward. At the same time, I'm going to hand over to my co-chair, Mr. Abenego Kioko, to run the next session. Mr. Kioko, kindly run this session. And Mr. Kioko, he works at Pwani University in the Department of Health Sciences. Welcome.
Thank you. Thank you. We want to appreciate our presenters for the good presentations, and I want us to take a few minutes to raise questions so that they can address. So, yes. Welcome. There's somebody who had raised a hand there. Yes, a question? Can we have a mic? So kindly take note of the questions so that we get all the questions so that they can be addressed together.
Yes, thank you very much. My name is Simon Kibera. I work with USAID, Stawisha Pwani. I will not call the names because I might confuse. I'll just say the person who presented on chronic care. So it was actually quite excellent because I have visited the chronic care center at Kilifi. But maybe you may tell us about the different. The last time I came there were different systems. There was Kenya EMR, the epileptic were being seen using a different health record system. So maybe you might tell us what you are doing to address that. And then the other one is on healthcare worker screening. That's actually quite commendable. And there's a lot of stigma we know with healthcare workers screening for TB and therefore starting TPT. Maybe you may consider the second research you conduct to compare what you did and right now. Right now, I know the USAID Sausha Pwani has procured an X-ray digital artificial intelligence machine, which is based at Mutwapa Sub-County Hospital. It is quite very good in identifying the TB with a very high sensitivity rate. It will even give you the score and tell you there's a very high likelihood maybe somebody has got TB. You can compare and you take it at your area and screen them for TB, and they will know if they don't have TB, they can now take the TPT. And then you can compare before and after using the machine. Thank you very much.
Okay, thank you. Another question? Yes. Yes.
Thank you for the wonderful presentations. Actually have, is it on? Yeah, okay. Thanks. I have questions for, I think, almost everyone. I really enjoyed this session. So for Professor Isabella, thank you for the keynote address. I noticed there's sort of like a drop in the resistance to chloroquine after the introduction of AL. So do you think there's potential use or reintroduction of chloroquine in the management of malaria as we now look at the mutations that are coming up? And then for Dr. Nancy as well, when we now bring in the community health promoters, how then do we navigate these tensions between them and the healthcare workers, especially for managing something as complex as hypertension, and also, having them go home with medications and that kind of thing? How do you navigate that to ensure that there's still quality maintained and also people don't feel like their roles are being taken? And then for Dr. Marsha, I noticed the mean age is quite old, in my opinion. So you said 54 and you said it was young, and I was like, hey, that's a bit old. So I wonder, are we missing people in the younger age groups? And if so, maybe there's need for more screening. And then also for the females who are slightly more than the males, could this just be driven by the cervical cancer, which is predominantly only in females? So then perhaps a slightly different approach towards looking at which are the most common. And then also the issue with the staging, majority of these were not staged. Again, this is just a huge gap and might also mean we are missing out something. And finally, for Dr. Paul, as a pharmacist, I think side effects are a real concern as comes to TPT. So again, how would you address that to ensure that there's better?
Thank you.
Okay, thank you very
Just
much.
summarize. Yes, there's the last one there. Yes. Maybe as we wait for as we get the last question, we can start getting some responses. Let's get the last question, then somebody will respond. They'll start responding.
Thank you very much, Esther Muthumbi from Aga Khan University. This is for the doctor who presented on cancer care in Kilifi. So mine is just seeking clarification. I'm wondering the population that you sampled from for the adult patients, was it outpatient or inpatient only? Mostly because they would, depending on the sampling, it would select for the kind of severity that you will find in the patients that you select.
Okay, thank you.
Thank you and good afternoon. My name is Christina Julu. I work with the Open Institute. So my question goes to Dr. Marsha, and it's related to what my colleague has asked. You mentioned, I don't know if I got it correctly or I missed something. You mentioned that you picked the sample from the patient files. So
did the patient get hydroxyurea? And we realized that majority of staff members aren't aware about the small things about sickle cell disease, the different types of crises, acute chest syndrome, the side effects of hydroxyurea, and that's the first step, in my opinion, towards integration with sickle cell disease. Once our healthcare workers have the capacity to fully understand
the introduction of digital X-ray, I think that's a very good recommendation. We are going to consider that, especially given that we're also asking ourselves why this screening and uptake is generally low among the caregivers who cares for the carer. So especially in level 4, which was Malindi, the higher the facility level, the lower the uptake. It was much better in dispensary and health center. And also the more experienced the physicians and the medical officers and the veteran nurses, the lower the uptake. So we were wondering what, so I think that would form part of our research questions as we consider that suggestion. To the case of side effect, I think that is very real, and healthcare workers having that knowledge also has a downside. They understand the side effects, so they even decide not to take it up because they already know, as opposed to the patients. And one way we maneuvered this, and I want to thank my MOH who is here, we decided to address this low uptake and side effect at sub-county level, led by our sub-county MOH, by first in bringing up this peer-to-peer support. Through our coordinator, we agreed that on Monday, before we start our meeting, we take our tablet of TPT, led by the MOH, and that's what we also cascaded to our healthcare workers. So before we ask you about your TPT uptake, we ask you about whether you have taken care of your staff, so that you can be able to share. And you are receiving calls from colleagues. I'm having this urine, is it this drug, or now I'm sick? And you are telling them, I'm also having the same. So we are in this together, that's common. And it allayed those fears. So I think that is something that you can do as healthcare workers. And once you go through that process, you become empathetic and put yourself in the shoe of the patient. Is easy to ensure the scale up of TPT. As I finish, I want to just ask, how many in this room have taken TPT? By show of hands. So 29% may not be an outlier result. I hope when we go back, we'll do something about that. Thank you.
I think I've had most of the questions for me, which I think is good because I think my work is done, and people were basically listening, okay? This study was basically to elicit the questions that you're having. I'll start with mean age of 54. As I said, we have a problem with late presentation. And then this was inpatient adult files, okay, inpatient. So most of our patients actually show up at an advanced stage. So that's why the mean was 54. So we need to find ways on finding out why our patients coming late. And then the next one was about the female numbers. So the clinicians who are here can tell you that if you go to any county hospital right now, female ward is more than what the male patients, the number of male patients you'll see. This is health-seeking behavior of our male patients. Even the men here, by the time they go to the hospital, I think it's the time when they cannot walk or they cannot function. So health-seeking behavior and cancer literacy, awareness of cancer risk factors. So that answers about the female patients, and also predominantly cervical cancer and mostly breast cancer comes from our female patients. Lastly, there was a question about time between diagnosis and death. I think we need to capture that, and that's some of the limitations that we had because you're only using inpatient files and documentation. Because one of the things that this study brought out was poor documentation. Because as you can see, the numbers were just 101 cases in 5 years. But if you think critically, that number is so low with the cases that we see. But documentation is missing. So this is something that we need to work on as Kilifi. Thank you.
Okay, and thank you for the question about the potential reintroduction of chloroquine, given that we don't have the resistant parasites in circulation. My first response to that is that it's given us lessons that you can cycle medicines, and it will change the profile of parasites in circulation. So that's moved forward an agenda around multiple first lines. So you'll cycle every 2 years different drugs. The challenge with chloroquine, though, is at the time it was taken for 7 days, so there are adherence challenges. Will people take medicine for 7 days? It doesn't taste very nice. So unless we come up with a modified version of chloroquine that we can combine with our current artemisinin-based combination therapies, then maybe it might find its way back. So maybe there's a research question out there for anyone who's interested in pharmaceutical production. Thanks.
Thank you. Thank you. Let's appreciate our presenters. It has been a good session, and probably we can take a quick photo with the team before we invite the next group. Thank you. Now, we are going to have the last group. We are going to have the next group, which we are still on communicable and non-communicable diseases. And we have Maria Mulwa. Is Maria Mulwa in? Just come over if she's around. Then we also have Robinson Karuga. Maria Mulwa will be presenting on elimination of vertical HIV transmission through quality improvement approach in prevention of mother-to-child transmission in Kilifi. Then we have Robinson Karuga, yes. Then Nation Baraka. Nation Baraka. Is Nation Baraka around? Yes, Nation Baraka will be presenting on education, social engagement, and healthcare access, key determinants of cognitive outcome among older adults. Then we have Peter Kasutu. Peter Kasutu is supposed to be presenting on prevalence of HIV among presumptive TB cases in rural and urban settings in Kilifi County. Yes. Karibuni sana. So let's have our first presenter, that is Maria.
Good afternoon. My name is Maria Mulwa, and I work with the County Department of Health, Kilifi County. I will take you through a small presentation. How does this work? On vertical transmission elimination of HIV through quality improvement approach in Kilifi County, Kenya. And this was done through the support and coordination between the county government of Kilifi and the USAID Stawisha Pwani. So that is the outline that is similar to all the other presenters. So as a way of introduction, globally mother-to-child transmission of HIV rates range between 15 to 45%. This is according to WHO, and this is without any intervention. We have made strides as a country. However, we still have a very high MTCT rate of 7.3%. And as a county, our rate is at 11.3%. And this is according to our HIV estimates that we receive on an annual basis through our National AIDS and STI Control Program for 2024. So the contributing factors to mother-to-child transmission rate have been treatment interruptions during pregnancy and breastfeeding, and our mothers coming very late in ANC, so making it very difficult to intervene during that time, and that leads to children getting infected. So we were using continuous quality improvement to see whether this can address the health challenges that we have and the service delivery gaps. So our goal was to reduce children getting infected with HIV from their mother that we had recorded as a county was around 42 to 0. We were being ambitious to see whether we can achieve that. Okay. And our review period was financial year 23-24, and we wanted to do that in 1 year. So we have a system that we report and we send samples and we get feedback in terms of the children that are HIV infected. And this is called the Early Infant Diagnosis Portal. It is a national portal, so you get results for all the clients. So we were picking any child who was HIV positive and we test them from the time they are born up to 24 months. So we are tested at 6 months, at 6 weeks, and at 1 year. So any child who had a PCR positive was identified, and we had 42 of them in the county in that year, and they were reported in 29 health facilities. So we conducted a HIV-exposed infant audit. So HIV-exposed infant is a child who is born from HIV-positive mother. So for any facility that reported a PCR positive, we conducted a HAE audit just to find out what were the contributing factors that led to that infant getting infected. 105 healthcare providers were also trained across the county, and we did this in 3 clusters, having healthcare workers from neighboring counties, neighboring sub-counties. So we had Malindi, Magarini, Kilifi North, South, and Ganze, one training, and Kaloleni Rabai. So we also included the sub-county health management teams in the part of the training so that they can be able to assist the healthcare workers come up with their QI projects as well as follow up on the projects as well. So during the training, it was a practical training, and we did come up with a goal statement. They did their situation analysis, looked at their gaps, did a fishbone diagram, and this was just done on a manila paper before taking it back to the CQI platform. So at the end of the day, each facility had a QI project. So the key findings were most of the women that were found to have led to a transmission of HIV to their infant, 30% of them had interrupted treatment during pregnancy. And this is because some of our mothers in our setup, our cultural setup, when they are pregnant and they are nearing delivery, they will go to their maternal homes and not take their medication. The others will relocate with their husbands if their husband has a new job. So those are the contributing factors. And then 27% of the mothers were newly diagnosed HIV positive during the breastfeeding period. And then 16% of them seroconverted positive postnatally. So this is a mother who came during the pregnancy period. She was HIV negative, but during postnatal period, in the breastfeeding period, she turned HIV positive. And then the other factors were late ANC attendances. Most of our women come to ANC when they are 7 months, 8 months old. So by the time you are diagnosing a HIV positive, putting her on treatment, she's already in labor and delivery, delivering her child, and by the time you're testing the PCR is positive. And then we also have non-positive mothers who interrupt treatment during the breastfeeding period as well, contributing to a very high number of children who seroconverted. So we had a meeting with all the 29 facilities. The 105 healthcare workers were trained, and all of them had a QI project. Some of the change ideas that they came up with was service integration. So instead of having a mother go to CCC to pick her drugs and then go back to MCH, those are 2 different clinics. You'll have to queue. Why not have that all under one roof? So integration really came in handy to reduce the back and forth between the mother. And then tracking their appointments was another issue. I think the mothers will get lost and the healthcare workers will need to know whether this mother was supposed to come for clinic. So appointment tracking was also key, and that helped in defaulter tracing the mothers early enough. And then assisted disclosure was also another intervention to their sexual partners. Most of the women feared explaining to their husband that they're HIV positive. So they will prefer coming to the clinic together with their husband. We test them again afresh and then disclose the HIV testers, the status of the husband and also the wife at the facility. So this really assisted improved adherence to treatment and viral suppression, leading to a very low number of children getting infected. And then client-centered scheduling was also one of the interventions. So instead of the healthcare worker setting up the schedules that you need to come to clinic on Thursday or you need to come to clinic on Tuesday, we were giving an opportunity to the mother to decide whether to come between Monday and Friday. So having the clinics across the week. And then identifying a treatment supporter was also another intervention. And here the mother will either choose a sexual partner or a friend or a peer just to support her through the journey. So our results after 1 year was we had reduced the HIV seroconversions amongst children from 42 to 16. We did not achieve the 0, but at least we reduced to 16, and this was a 62% reduction in the new pediatric infections in the county. So our conclusion is empowering facility teams to identify and solve their local PMTCT challenges significantly reduces the pediatric HIV infections. Participatory data-driven QI projects or approaches is cost-effective, and it strengthens the local capacity of the healthcare workers, and it promotes elimination. The recommendations are we need to scale up the CQI projects to all the other facilities and even to other programs, malaria, nutrition, RAMCA, continuous mentorship to the healthcare workers, and also follow up on the CQI projects, as well as digitize our health facilities to ease digital CQI dashboard. Thank you. I want to acknowledge the Department of Health, the county and the sub-county team, the healthcare providers, and our implementing partner, Stawisha, as well as the mothers. Asante sana.
Right, good afternoon, everyone. All right, so I'm delighted to share with you our research. I'm delighted to share with you our research about acceptability, feasibility, and the cost of integrating female genital schistosomiasis services in routine SRH services. So this work is a combination of efforts from the Ministry of Health, the NPHI, county governments in Homa Bay, Kwale, and Kilifi. There are 3 partners. There was Frontline AIDS as our lead partner, LVCT Health, where I'm from, and Bridges to Development. And we got funding from CIF. So this is what we're going to cover in the next 8 minutes. And I'll start by introduction. Now you can imagine a young boy or a young girl who starts swimming in our freshwater inland ponds from nursery school. So they get infected and reinfected with urinary schistosomiasis, or kichocho as it's called. Then now, from the pathology or how this disease progresses, the eggs move from the capillaries around the bladder out into the bladder and pass out urine, and the life cycle continues. But now, not all the eggs go out into the urine or to the bladder. Other eggs are lodged within the urogenital tissue and the organs. And now this chronic inflammation leads to what we call genital schistosomiasis. Amongst females, it's FGS, and I'll use FGS. Amongst males is male genital schisto, MGS. So most often, this condition is misdiagnosed and treated wrongly as an STI. You can imagine the amount of stigma that comes with this condition, the discomfort, the domestic violence, and even education is affected by this discomfort and the stigma. So across the globe, over 56 million women and girls are affected by MGS. Men are also affected. They suffer silently, and there's no data about genital schisto in Kenya. So from the 40s, this condition was known as gynecological schistosomiasis, but then with time, it's being understood better. But then this condition interacts with other diseases. So for example, studies have shown that women with genital schisto are 4 times more likely to contract HIV than those women who do not have FGS. This condition also increases the risk of cervical cancer and infection, or rather, cancers that are caused by HPV. Then there's a term that's been going around, which is called a syndemic, and it shows the interaction between genital schisto, HIV, and cancers that are attributed or that are associated with HPV. Now, you will find that the same populations that we address or that are affected by genital schisto receive services in silos. These family planning services, antenatal services, HIV services, all these are provided in silos. And we thought, why don't we integrate genital schisto into SRH services. So we started off by conducting a literature review to see how can we integrate FGS in SRH, and with our partner Frontline AIDS, which Frontline AIDS led in the development of a minimum service package for this integration. We contextualized it in the Kenyan counties where we worked to see whether it is practical. Then now we conducted what we call implementation science research. Now, the minimum service package has four components. The first one is raising or sensitizing health workers, both at community and facility level, about FGS. The second component is building capacity on how to screen and diagnose FGS using simple pelvic examination, using a speculum, which is commonly available in our SRH settings. We also built capacity with the county governments on how to treat with praziquantel. And then now, how do we incorporate FGS into other spheres that are commonly left out? So as part of the minimum service package, we were able to sensitize over 55,000 women in the 3 counties using community dialogue, community outreaches. Then now we used a cascade model with the county governments, Kilifi, Kwale, and Homa Bay, and we reached over 600 health workers and over 300 community health promoters. Then now, from the facility settings and community settings, we're able to screen about 9,000 women and girls, and those who were suspected to have genital schisto were referred for pelvic examination. So our question is, this integration, how acceptable is this? How feasible is it? And what's the cost of the integration? Now, you will see from the screen here, we have very high positivity of FGS in the sites where we, oh my God, in the sites where we did this implementation science. Homa Bay was over 28%, Kilifi about slightly over 15%, Kwale about 35%. So overall, positivity was round it off to 28%. And mark you, we didn't go to the areas with the highest prevalence of urinary schisto because this was a demonstration project. So the outpatient department and community outreaches yielded the highest percentages of positivity. And then the MCH department was another place where we had the highest yield of positivity for FGS. And we did in Kilifi County, we did this in across 7 community units, the Teaching and Referral Hospital, Vipingo, and Junju Health Center. There was high acceptability of this integration amongst both the clients and the health workers. Health workers said they didn't know about FGS, and they were hearing about FGS for the first time during this study. And after the cascade training that was done by the county officials, and the health workers, they felt confident they could diagnose. We had health workers modified registration because there are no indicators for FGS, so they use the cervical cancer register to record the numbers. Health workers found integration feasible. And now in terms of the cost, because that's the biggest question, in the first year of integration, it will cost about $10 because of the training per woman to integrate. Then after 3 years, it will cost about 700 shillings to integrate these services. When you do community outreaches, it costs about 30 shillings per woman, and we are assuming that we are going to reach huge numbers. Say we reached 55,000 women, and the unit cost to reach every woman was about 30 shillings, which is doable. Capital costs took the bulk of the expense, and for women to come to the health facility, it costs about 300 shillings. The bell is about to ring, and this is my last slide, I promise. Key takeaways, if we were to integrate these services, the places that will give you the highest yield will be community outreaches, the MCH department, and the outpatient department. It will be really important to integrate management of genital schisto into existing protocols and clinical guidelines, include FGS in preclinical and in-service training. We need indicators for FGS, so that's an advocacy activity we are doing, and scale up the integration across the county and other counties with high endemicity. For more details, please read the work we've published on PLOS Global Health. Thank you.
Thank you. Hello, everyone. So my name is Mary Mochama, in place of Nashon Baraka students at North Coast Medical Training College. So today I'm going to present our study about determinants of cognitive outcomes among older adults in Kilifi, Kenya. So cognitive function, this is the ability to acquire information, process it, and also storing it. And as people get older, we see there's a cognitive decline, especially those aged 60 years and above, and severe cognitive decline, which is dementia, is seen to be higher in older adults. And we realized that 57.4 million people globally had dementia in the year 2019, and in Kenya, that had to be 91,000 cases, which was projected to have an increase of 316% by the year 2050, which shows you how serious this is. That is 361,000 cases and 42. And these people, over 60%, reside in low and middle income countries. And this is seen to be one of the most leading causes of death globally. And why there is a projection of the 316% increase in cognitive decline is because of the increased life expectancy, unhealthy lifestyle, non-communicable diseases, and also lack of education. So why we did this health study in rural coastal Kenya is because 5% of the people in Kenya are aged 60 years and above. We also see that there is high cases of poverty in coastal Kenya, poor lifestyles, and also low health access. We also see the endemic malaria and tungiasis, which is so common in coastal, which leads to the neurocognitive impairment. So our research gap was limited data on cognitive outcomes among the older adults in this region. And our objective was to determine the cognitive outcomes and identify their determinants among the older adults. So the methods we used in this study, the study design was a community-based, cross-sectional, and this was done in 934 households in Bomani, Kilifi, which had more than 3,000 residents, and all these people are seen to share one dispensary, and the Kilifi poverty rate, which is said to be 70.8, as we compare to the one in Kenya, which is 45.9. And this, we did it in June to July 2024. The participants were the people aged 60 years and above, and we excluded the severely ill and speech impaired. Yeah, and the primary outcomes were from the MOCA and mini-mental scores, which MOCA had a cutoff of 23, and mini-mental had a cutoff of 26. And MOCA focused on the visual-spatial, naming, memory, attention, language, abstraction, and also the orientation, while mini-mental focused on orientation, registration, attention, recall, and language. And they were both adapted and translated to Swahili for easy understanding because not all these people know English, and also due to the low education. And so we see that we collected these through the structured interviews of MOCA and mini-mental, PHQ-9 and ISI administered by the trained Swahili Choni proficient assistants. The age of these people was verified with the ID, and those without the CHP was used, and it was done in a quiet and private environment. And we see that there was a good and acceptable internal reliability and also a multivariable GLM model. And we analyzed our data using the Stata 15.0. We computed the medians, frequencies, and the inferentials were the Mann-Whitney U, chi-square, or Fisher's exact where appropriate, and the GLM model. And we see that we have these factors, and we compare the males to females and see that gender is also a factor that is considered in the cognitive outcomes, and also the social economic and access, that is income, phone ownership, social group membership, government cash transfers, and distance to health facilities, and also the varied sex. And we see that, so in every unit increase in age, there's a unit decrease in the cognitive outcomes, in the mini-mental scores. And for the education, those with no formal education compared to those with primary and post-primary education, we see every unit increase in education gives you a unit increase of 6.44 and 7.93 respectively for the cognitive outcomes. And the distance, every unit increase in the distance from the health facility gives you a unit decrease of 0.02 in the cognitive outcomes. The same is seen in the MOCA scores. And we discussed that for the MOCA cutoff, majority of the women, that is 74.3, were seen to be below the MOCA cutoff. And the mechanisms are the ApoE for carrier risk, and the estrogen decline post-oophorectomy, that is ovary removal. And education was seen to be a protective factor because for every unit increase in the age, the cognitive outcomes improved. And also, a decline in age led to cognitive decline. And we see the healthcare access also is a factor because of the proximity. And we concluded that gender gap is substantially mitigated by the educational achievement, and cognitive outcomes can also be improved considering the proximity to the healthcare. And we recommend that there should be enhancement of formal education access for women in the rural, low resource areas to strengthen the cognitive reserve, exploration of other roles, healthcare infrastructure and proximity in undeserved areas, and establish routine cognitive screening programs for older adults. I would like to acknowledge Berry Otieno and Associates. Thank you for your time.
Yes, good afternoon. My name is Peter Katsutsu. I work with the USAID Stausha Pwani in Kilifi County supporting HIV services. So I'm going to take you through our research. That is, we were looking at the prevalence of HIV among presumptive TB cases. And we are looking at the rural and also the urban settings. We are trying to compare the rural and the urban settings in Kilifi County. This is the presentation outline, not very different from the rest. So as an introduction, you may be aware, you may not, be aware that TB is one of the commonest opportunistic infections among people who are living with HIV. And for the people who live with HIV, they have a bigger risk of contracting TB. That is about 16 to 27 times if you compare the HIV positive and the HIV negative. And also, if you look at, again, the people who are living with HIV, they also have an increased lifetime risk of having TB, almost 5 to 10%, 5 to 10 to around 50%. So basically what we did to establish the prevalence, we collected data across the whole county, and we focused at 14 facilities. These were for various levels, level 1, level 2, level 3 facilities. But again, we're looking at the urban and the rural settings. The data that we analyzed was for November, that January to November 2024. This is something that we started doing earlier, but we came to a halt a bit when there was a bit of uncertainties in our program. But then, after we resumed work, we decided to go ahead with the analysis. So for the facilities, we had 10 rural facilities, and we had 4 urban facilities that were involved. And the number of participants that were involved were 435. All these were presumptive TB cases. So we analyzed our data through statistical description analysis, and also we did bivariate analysis using the chi-square and also some tests to determine the association. So for the results, you can see for all the presumptive cases, we had 39% of the presumptive TB cases were HIV positive, as compared to 61% who were HIV negative. But looking at the ones who had done TB workup, either they were TB positive or TB negative, you'll see that 18% of those particular clients, that 74 cases were positive, and then we had, they had TB, and then 82% of the presumptive cases we analyzed, we found that they were TB negative. If you come down here, we further analyzed the TB positive clients and the TB negative clients and compared the HIV positivity among the two groups. So if you look at the ones who are TB, they were HIV negative, you'll find that for the TB, for the ones who had who are TB negative, we had 30. My site is failing me. We had 85.4% of the ones who are TB negative, they were also HIV negative. If you go to the ones who are having TB and they were HIV negative, they were 14.6%. If you count the ones who are HIV positive, that is a 76.9% were TB negative, while 23.1% were TB positive. So we compared the two groups through an odds ratio, and you'll find that the ones who are HIV positive, comparing to the ones who are HIV negative, the odds ratio was 1.75, and this one we found that it was statistically significant because the p-value was less than 0.5. Then we also compared the gender and the settings. Again, if you look at the gender, for the females, if you compare the female and the male, again, the male, the ratio was again high. There was ratio at 2.17 with a p-value of 0.001, again, below 0.5. And if you look at the settings, again, the rural settings over the urban settings, again, it had an upper hand because the odds ratio was 2.13 with a p-value of 0.001, meaning that the rural settings, clients, they are likely to be HIV positive if they have presumptive TB. This one was looking at the different age groups, and we looked at below 15 to 24, 25 to 19, and also above 50 years. And as you can see, if you look at the younger age, we have up to 24, if you compare the two age groups, that is below 15 and 15 to 24, 23%, again the other one has 55%. We have a higher percentage in the younger age in terms of HIV, if they're presumptive TB cases. So basically what we came to conclude is that HIV burden among presumptive TB cases is high with significant gender, geographic, and also age disparities. And basically what we are recommending after this analysis is that we need to be targeted in terms of interventions. We need to be targeted in addressing the rural populations alongside the general HIV testing that we normally conduct. So whenever we have presumptive TB cases, especially from the rural settings, we really need to focus in terms of HIV testing, and more so among women and also among the young population. So our acknowledgements goes to the Department of Health in Kilifi, more so the County TB and Leprosy Coordinator, whom we work together, the CASCO, and also the USAID Staushapani, the colleagues that really supported in terms of analyzing this particular data. I hope I've met the time. Yeah. So maybe as I leave, I think the message home is that if you've had a cough, maybe today, yesterday, or today, I think you need to access a TB test, because we normally say a cough of any duration, you're a presumptive TB case. Thank you.
Thank you, Mr. Kasusu, and the rest of the. Can you appreciate them well for the good work? Let's appreciate them well. Yes. Thank you for the nice presentations. And now, in the interest of time, we would want to summarize and don't repeat what somebody else has asked. Any question? Yes?
Thank you all for the presentations. Mine is not necessarily a question, but a comment on female genital schistosomiasis. And just to emphasize on what I'd said yesterday, that when I trained as a doctor, if you're doing your assessment for female genitalia, a lot of us will be looking for cervical cancer. Even right now, cervical cancer screening is going on in the health facilities. And the community has a lot of stories. The stories of families that were breaking up because they thought that the lady had STIs, only for praziquantel to do the magic. And some of the women are actually getting pregnant just after that. So there's a lot of good stories. For me, I would encourage Kilifi County government and even Kwale to take this seriously. And going back to the training colleges, that we need to take this knowledge and start teaching the students right now, the nurses, as they graduate, let them know that things are different. So thank you for that study. Let's take it to the next level.
Okay, thank you. Thank you. Another? Another question? There's no other question. Yes. Any response to that?
I thought that was a comment.
Yeah, I think for me, just to thank you very much, Dr. Oyaro. Yeah, and just to say other unintended consequences, as clients would come and they're treated, they're given antibiotics because the health workers were not aware of genital schisto, it can lead to other problems like the antimicrobial resistance and other issues. So this study has been very consequential, and there are a lot of very good stories. I agree with you. Asante sana.
Thank you. I think in the interest of time, you can see the presenters because we really time constrained. So thank you very much. Let's applaud the team, and the rapporteur can come forward so that we take a photo for this team. Yes, I take the program back to Mr. Charles.
Thank you. Thank you very much. A big clap to that plenary session. It was indeed packed, but thank you for telling us what's happening in the front of communicable and non-communicable diseases. I have conferred with my good friend here, Dr. Charles Dadu, and has accepted that we can go for lunch and come back and start with him. So allow me to invite you for lunch, and let's be back here by, I see half of the room has actually gone out for lunch. So mkiwapata kwa laini muambie, sio fair. But let's break for lunch and be back at exactly 3 for some 3 or 4 exciting presentations. We're going to have a spotlight on science communication. We're going to hear something on One Health. And then we're going to hear something very exciting, by the way, on the Eastern African Global Health Security Summit. And then we move on to the closing ceremony. See you at 3 o'clock, at exactly 3 o'clock. Bon appetit.
Feel the rhythm, feel the fire. We dance all night, no tire. Like somebody moving slow. Summer breeze and the speakers blow. You and I losing all control. In the rhythm, let the music flow. Baby, don't stop now, keep it tight. Baseline heavy, feel the vibe tonight. Heartbeat sing to the groove so right. We shining bright like city lights. Dance in the heat, don't stop the beat. Move your body, feel that energy. Let it take you high, sweet melody. We're living free, on my piano dream. Yeah, on my piano dream. I'm a better fire, can I divide? We come alive, dance in the heat, we on the night. Feel the beat inside, I'm a better fire, can I divide? Feel the beat inside, I'm a better fire, can I divide? We come alive, dance in the heat, we on the night. Feel the beat inside, I'm a better fire, can I divide? So fine, lost in the rhythm, your hand in mine. Every move, baby, feels divine. I'm up in a love of pure sunshine. Keep it real, keep it flowing slow. Baseline deep like the ocean glow. No tomorrow, no place to go. Just you and me and the sound we know. Damn, in the heat, don't stop the beat. Move your body, feel that energy. Let it take you high, sweet melody. We're living free. to waste. We dey celebrate it. Dance all night, make the body elevate. Energy high, nothing go complicate. Living my life, I got no time to waste. Step in the place and the vibe too strong. Shawty one down to the champion song. Lights and they shine and the groove too long. We go keep moving to the early morning. No, no, we no slowing down. Feel the rhythm, let it turn you round. Hands up high, we there on New Town. Good vibes, only no bring no frown. No time to waste, we just celebrate. Dance all night, make the body elevate. Energy high, nothing go complicate. Living my life, I got no time to waste. Na, 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 na. From Lagos down to the world we just slay. Past fire, nothing go fade away. No time, no time, no time to waste. Oh, celebrate life, you this sweet day. Good on say, make we all embrace. Living my life, I got no time to waste. Matter how. Woke up spinning like a satellite. My heart's a rocket taking flight. Every step I take feels like a spark. Even in the daylight, I glow like a star. Electric rivers running through my veins. A surge of power I can't contain. I'm a energy, it's wild, it's free. Lighting up the world like a galaxy. I'm a energy, it's you, it's me. A supernova love endlessly. Chasing moments like a commerce trail. Every beat a drum, every breath a sail. Gravity can't hold us, we defy the rules. The cosmos is ours, we're breaking all schools. With the thunder, the flash, the storm. A force of nature breaking form. Feel it pulse, feel it rise. A universe in our eyes. I'm a energy, it's wild, it's free. Lighting up the world like a galaxy. I'm a energy, it's you, it's me. Supernova love endlessly. corner of my eye. Electric pulse like thunder in the sky. Shoes untied, but I'm flying anyway. Who needs rules when the rhythm's got sway? I'm the vibe controller. Turn it up, it's never over. Feel the beat, let it take you under. I'm the vibe controller. Neon whispers paint the walls in glow. Hands up high, let the energy flow. Clock's ticking, but we're still in time. This groove's a thief and it's still in mine. Bassline's heavy, heartbeats collide. Ride the wave, let it amplify. I'm the vibe controller. Turn it up, it's never over. Feel the beat, let it take you under. I'm the vibe controller. Fingers snapping, planets spinning wide. I'm the spark, the fire, the wild ride. Let your soul be the signal tonight. I'm the vibe controller. Ignite the light. I'm the vibe controller. Turn it up, it's never over. Feel the beat, let it take you under. I'm the vibe controller. I'm the vibe controller.
Design the perfect voice for your brand with 11 Labs. Change the way you record podcasts, voiceovers, and branded content with the #1 AI-powered voice generating technology. Stop searching for the perfect voice and stop wasting time re-recording take after take. Try 11 Labs for free and start elevating your content today.
We go dance with the sun, shine till the day is done. Groove with the fire, feel the heat, be there. Life is sweet when the rhythm they come, celebrate love. We go dance with the sun, dance with the sun. Shawty they move, body shine like gold. Step to the beat, story never old. Every vibe strong, energy unfold. Afro swing, sweet melody we hold. Dance in the sky, make we elevate. Lock drum, maybe no time to wait. From morning light till it's getting late. Two vibes there, we then celebrate. We go dance with the sun, shine till the day is done. Groove with the fire, feel the heat. We dey run up. Life is sweet when the rhythm they come. Celebrate love. We go dance with the sun. We go dance with the sun. Funny feel the breeze on the ocean side. Music they carry us forward. Happiness we know go wide. Together we there with the song we ride. this on, no worry, no stress. That's our phone, Afrobeat spirit, number one. We go dance with this song. Dance till morning light, no stopping tonight. Body moving right, shawty hold me tight. Music take control, we gon' feel so high. Dance till morning under African sky. DJ turn it up, make this speaker blow. Energy they rise, everybody know. Shawty wine slow, then she take it low. We dey groove, steady vibes overflow. Now celebration, love in the air. Hands up high, no stress anywhere. One by one, people got their head. Dance till morning. Dance till morning light. No stopping tonight. Body moving right. Body hold me tight. Music take control. We gon' feel so high. Dance till morning under African sky. From Lagos down to Joburg City. Rhythm sweet, make the vibe so pretty. No bad energy, we dey keep it litty. Sundown to Joburg City. Rhythm sweet, make the vibe so pretty. No bad energy, we dey keep it litty. No slowing down, we go all the way. Sunrise comes till the music play. Past time and spirits never stray. Dance till morning, forever we stay. Kiss the sky. Shadows stretch the days goodbye. A lonely bird, it hums its tune. The night will follow far too soon. Sunset flows like melted gold. The world feels quiet, soft and low. Tell me why it feels so near, but fades away. It disappears. Footsteps echo on the sand.
Hey, productivity enthusiasts. Check out this tool that I've been using to 10x my productivity every single day. So HubStack automatically shows me real-time insights into my productivity every day. It's like having a personal productivity coach right on my desktop. This little tool has made me work 10 times more productive. Give it a try and let me know how it goes for you.
Time slips through an open hand. colors bleed, they twist, they run. A masterpiece undone by sun. Sunset flows like melted gold. The world feels quiet, soft and low. Tell me why it feels so near, but fades away, it disappears. Oh. Every star will claim the skies. Still I chase it, hold it tight. The fleeting warmth of fading light. Sunset flows like melted gold. The world feels quiet, soft and low. Tell me why it feels so near, but fades away. Let's go, baseline heavy, body low. Yeah, no energy, let it show. Feel the beat, we up all night. DJ spinning the mood so right. Hands up how we touch the sky. I'm a piano, make you fly. No stress, no fear, just vibes. Let the rhythm take your life. One move, one groove inside. Yeah, no energy tonight. We got that, yeah, no energy. Move your body, set it free. Let the bassline carry me. I'm a piano melody. Oh, feel that power. Oh, dance for hours. Oh, sweet desire. Gonna know energy's fire. Tempo slow, the crowd go crazy. Girls in motion, rhythm wavy. Boys vibing, lights go hazy. Tonight we wild, feel amazing. Every move is synchronized. I'm a piano hypnotized. Lose yourself, don't compromise. We vibing under city lights. We got that, you know, energy. Move your body, set it free. Let the bassline carry. I'm a pure melody, yeah. City lights shining, we on the move. Baseline deep, we in the groove. You got that smile, I got the tune. Let's lose control under the moon. Oh, every heartbeat feels so right. Dancing close till the morning. DJ spin that magic sound. Every heart just spinning round. Lose yourself, don't look behind. Love and rhythm intertwine. Feel that freedom in your spine. This night is yours and mine. We got the vibe tonight. Let the rhythm take you high. Feel the fire, don't deny. I'm a piano in your mind. We got the vibe tonight. Hands up to the sky. Let it flow, don't fight. We got that I'm a piano like. Oh, 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 we vibing. Oh, 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 we smiling. Oh, 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 I'm gonna never die. Keep that energy alive. Oh, oh yeah, we got it. Oh yeah, we smiling. I'm a piano never die. Keep that energy alive. Oh, 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 baby, you they put me on sweet control. Body and soul, you they take my road. When you wind slow, I they lose control. Love don't catch me, I can't let go. Yeah. Shawty move steady, fire they burn. Every step heavy, groove they turn. Love drum knocking, passion we learn. Afrobeat sweet, energy return. No delay, girl, you they make me stay. Your rhythm they guide me night and day. From Lagos down to Montego Bay. Sweet control, you they lead the way. Baby, you they put me on sweet control. Body and soul, you they take my road. When you wind slow, I they lose control. Baby, you they put me on sweet control. Body and soul, you they take my road. When you wind slow, I they lose control. Wind to the left, to the right, don't stop. Energy high, make the body jump up. Your touch they sweet, till they feel my bunker. This we control, I can't give up. Oh, melody they roll. Shawty they take my soul. Rude on set, story on vogue. Forever we there, sweet control, yeah. Away.
GoDaddy has the perfect hosting plan for any website. From low-cost shared hosting to your own virtual server. Every plan comes with a 99.9% uptime guarantee, along with a free domain name and award-winning support. No wonder we're the world's #1 web host. Unlock your online potential today with GoDaddy.
Web scraping, data collection, retail intelligence. IP Royal Residential Proxies power it all. Now 50% with discount code IPR50. Get over 34 million IPs you can trust. No blocks, no surprise limits. Lightning fast, expert support in minutes. Save 50% today with code IPR50.
is young, the moon is loud. Electric hearts inside the crowd. Feet on fire, the ground's alive. We're not here to just survive. Neon dreams and midnight sky. Raise your hands and close your eyes. Party till sunrise. Don't let it fade. We own this moment. We own this parade. Party till sunrise. Dance through the night. The world is spinning, but we feel so right. Shadows twist, the stars ignite. Every move feels dynamite. Laughter sparks like chandelier glass. With the future, forget the past. Yeah. Glitter rains and music fly. Feel the rhythm, no goodbye. Party till sunrise. Don't let it fade. We own this moment. We own this parade. Party till sunrise. Dance through the night. The world is spinning, but we feel so right.
Mic check, 1, 2. Miss Magdalene, please confirm that you're able to hear us. How are you doing?
Yes. I can see and hear.
Oh, fantastic. Well, that's nice that you can also see. Well, will you have a slide you'll be sharing?
Yeah.
Okay.
Yes, we should be having some.
All right. Do you mind trying to share also on your end so that we see if it's possible to do so? I'm saying you try to share on your end.
Sharing. Been given to the hosts.
Hassan, Abu Cast. Ili tumuone.
Hello.
Hello, we can hear you.
Yeah, I'm saying the rights to share the screen have only been given to the host. So maybe you can leave it open so that I'm not the one who's really going to share. Dr. Nzai should be online to share.
Pardon, who's supposed to share?
Dr. Nzai is supposed to share. So we have one person who is physically going to start the session, Dr. Chima, then online. We're joined by other members, including Dr. Nzai, who will also be speaking. Dr. Emmanuel Zai, the chairperson for Vision 2030.
Okay.
Yeah.
All right. Let's get in touch with the technical team. Then we find out also in regards to the presentation.
No problem.
All right.
But if you need us to share that prior, then we can quickly make arrangements so you can have it and share from your end.
All right.
Okay.
Hassan.
Yes, I see.
I also move my slides. If you have like your tablet or your computer, you can move yours. Because you can use the pointer to move them. But if you need to see your slides closer, you can do that. Yeah. So the podium is the one that is here. You may move one, but it can be moved back here. There, then it's closer.
Good afternoon. I'm waiting for the networking to die down. Colleagues who are standing to have a seat. Thank you very much for coming back in good time. A big hand to yourselves for keeping time. And it's actually the same group from yesterday. So makofi tena kwenu. We are now getting to the tail end of the symposium, but it is a Secretariat's view for us to have a bit more spotlight conversation on what is happening across the entire ecosystem, not only through the scientific lens, but some of the emerging issues that are there currently. You're going to have 3 speakers join us this morning, and we'll start off with Dr. Charles Dadu, who is a former CEC of Health for Kilifi County and now working with the University of Nairobi and the Nairobi Rivers Commission to come and give us a talk on a World Health approach. Karibu sana daktari.
Asante sana. Namesake. Hamjambo. Good after lunch. Asante sana. Charles has made my work slightly easy because he has clarified that I'm among the very few people in this room who could be outside the course health sector as we know it. Okay, so based on that, I'd wish to make a 2-point disclaimer. One, I am a believer, not an expert in One Health. I want you to get the difference. So it's like those people who subscribe to religion. You could have a believer going to talk to a theologist or somebody who is specially trained in theology about spiritual matters. That person cannot be turned back, can they? Yeah, so a believer in One Health has come to talk to the experts in One Health. And there's a reason why I decided to do so. So currently I help the president in implementing a very ambitious vision that some of us might have encountered it on mainstream media, social media, or from some influencers. That is the regeneration of the Nairobi River. Now, I will also tell you why I decided then to join you in this auspicious event to discuss matters of the Nairobi River. So there's a special purpose vehicle, that is the Nairobi Rivers Commission, that was gazetted to coordinate the entire works of revitalization, and that's where I sit as a member. I will use this slide, therefore, to explain why I thought it was relevant to join you today. Nairobi is that fish sort of image you are seeing there. And there are so many tributaries and rivers, but the main ones are 3. We have the Nairobi, the Ngong, and the Mathare. But all that, we are saying, where does it end up? It ends up at Sabaki. Okay? So all that we're talking about up there, starting with Kiambu County, by the time these rivers or waters get to Kilifi at Malindi, they have traversed about 6 counties. There's Kiambu, there's Machakos, there's Makueni, there is Taita Taveta, then there is Kilifi. So quickly, that's one of the reasons why I thought it was relevant to you. But also the Conference of Parties, the next one, that we call COP31, which will happen in Turkey. The theme of that conference will be Clean and Healthy Oceans. And you might know that Kilifi is the county with the longest coastline and contact to the ocean. Therefore, this is very relevant. And you can't talk about health and cleanliness of oceans without addressing these waters that come down. Okay, we'll move quickly now. So from source from source. It goes through quite a number of landscapes within Nairobi. By the time it's leaving the city, that's about just 27 kilometers, that clean water has become black liquor, which is largely sewage. Okay, so that's the main challenge we are dealing with. So we are implementing the master plan for the renewal of this river. Some of the work has started, river training, bank stabilization, and other infrastructural work. We are also building the trunk sewers. Very big sewers, you can actually drive through this, 1.8 by 1.8 meters. We've also done special plans to help us renew, conserve, and develop those rivers. But why? Why the One Health gap? This is a missing gap because all that investment, without linking it to socio-economic objectives and transformations, will not achieve much. And from our perspective, we see the One Health as one of the promising framework that can help this regeneration achieve much more than just the physical investment. But also, the riverine ecosystem still remains one of the main food suppliers within the city. So in Nairobi, if you buy food from the informal sector, chances are 1 in 3 that you'll be buying food produced from this river ecosystem. And also we want, the theory of change must embrace the logic that a healthy community is wealth. A healthy community is socioeconomic asset. A healthy community is quality labor force, but also a healthy community is relief on the burden of health, which by extension then is budgetary relief. So how have we gone about it? Conceptually, we are looking at the riverine area as an area of exposure, man-to-man, animal-to-animal, man-to-plant, but the living organisms to the environment as well. There are some reported concerns that we don't have currently any empirical data to validate, but they are real. Stunting of animals, miscarriage, increasing cases of cancer. How have we organized it? The commission remains the main organizer plus those partners. Everybody else in the health sector has been provided for, from government, from non-state actors, including universities as well. Especially, we have zoned the river areas into communities, and each one of them has a center which will serve as a coordination and resource center. So we are looking at these kind of centers, very light architecture which is not intrusive to the environment. Now, I want us to take our space. It's about health. And we are saying we need to link this to the health system, CHUs, etc., okay? So the call, and this being my last slide, the call is we are looking at a very proper interface between this regeneration work and the health sector. But also we are saying there is need for a strategy beyond the achievement of the physical infrastructure. We will end up with a healthy, resilient, and a community that is prepared to things like disease outbreaks, which at the worst then can end up in pandemics. We have also tried to see what each one of us can do. So the commission can do the interagency etc. There are things that are specific to health, and this is what we can do together. Co-production in terms of planning, programming, implementation, but also resource mobilization. I submit. Thank you very much for your time.
Thank you. Maybe we can just have one quick question before we move to the next subject. I think maybe directly to you is what plans you have for the county government of Kilifi and how you can cascade this down to us now that you're in Nairobi.
Thank you. As we speak now, we are already in conversations with the 6 governors of those counties, including our own governor at Kilifi, and we will come now down for a targeted discussion about this. What we want as a commission is if all these 6 counties, plus the commission, can form the delegation that will accompany the president to COP31, that is in Turkey. It is a framework under climate change and the health and the cleanliness of oceans, and there cannot be better candidate than Kilifi to join the team for COP31. Thank you.
Thank you. Now that you mentioned travel, we are more motivated. Allow me to invite Dr. Patience Kiyuka to take us through on the evolving landscape of science communication.
Thank you, Charles. Can you hear me? Okay, I'm going to take you through health communication, which is some form of science communication as well, as Charles has said it. So the concept of health communication is relatively new. And what I'm showing you here is the number of when the publication started coming out about health communication. As you can see, it's up to around 2000 that we started getting more publication coming out discussing about health communication, which shows to you that it's fairly recently that people started appreciating health communication. But what is really health communication? It's defined as the science and art of using effective communication. And you're doing this to advance health and well-being of people and population. So it's very clear what its intended meaning. And this is sort of a multidisciplinary field of study. And it applies, you need to apply the evidence, the strategy, theory, and creativity, which is really important in how you disseminate this information. Some form of creativity is sometimes required. And you're doing this to promote behavior or policies or practices that advance the health and well-being of people and population. So here we are talking about health communication that serves the people and the population at large. But I thought I will want to sort of explain how different this is from healthcare communication, and which is the practice of sharing information between healthcare workers or professionals, between a doctor and a patient, or between doctors and the public. And you are aiming to also improve health outcomes, but more importantly about patient safety and allowing the patients to understand their health journey, which is more of the conversation that we all have when we visit a doctor for one reason or another, or when health professionals are talking, amongst themselves, but concerning the healthcare settings they are or related to the work that they do. So that's how different it is from health communication. So I thought I'd put this slide on to sort of pause here and ask how many people, this is obvious, everyone, at least almost everyone has visited a doctor, but there are barriers to, effective communication between a doctor and a patient, and we have experienced this. I think in our setting, what we know is that, there is a heavy workload, there are many patients to be seen, and sometimes some of the communication between the healthcare worker and the patient may not be effective as you will wish to do it. So I thought I'd put this so that I can help you, just for us to have a framework and alignment between the difference between health communication and healthcare communication. So when you talk about health communication, you're talking about public messaging for prevention and awareness, while healthcare communication, it's happening within the healthcare systems. For health communication, you are aiming to prevent disease and promote overall public health. But for healthcare communication, you're thinking about diagnosis, treatment, and ongoing care within the clinical setting. So those are the main differences that I want you to understand. And for me, I'll be talking about health communication because I'm not a medical doctor, so I won't be talking about the healthcare communication. I leave it to those who do it every day. So one of the main ways, there are many mediums for health communication, and radio has traditionally been appreciated and known as the main communication channel for most of the health communication that we've had. And this study shows how they used health communication to enable the community members to know that the CHVs, will be visiting their homes to tell them about the mass drug administration they were doing. So So this is to show to you that, health radio has, a long standing, and we still believe and appreciate that radio is important for communication. And we continue to use it even when we are doing now when we are talking about prevention and awareness as well. So, but then now we have the era of social media, and we can all appreciate that almost everyone who has a smartphone has a social media, is in a social media platform. And we have all these social media platform. And the idea is, how can we use social media platform to promote health communication as well? And so here I'm showing some of the examples of where they've used, social media platform. For example, in this one example is where they say they used WhatsApp to, explain to people about the Ebola services that their Ministry of Health was offering. And then you can see that in the second figure, they're using mobile communication data to have a sense of how populations are moving and how the Ebola virus may be spreading. And also we have instances where Facebook, for example, was involved in promoting information about the Ebola outbreak. So, we move from radio, the mainstream mass media, and we are seeing that people are moving to embrace platforms such as social media to promote health communication. As well as this study where they used mobile phones to communicate to the population about polio prevention. And then there's also this one very interesting platform in South Africa where they're using Mom Connect, where they're having a help desk as well as mobile health messaging so that people can communicate. What is interesting about this Mom Connect is that these mothers can actually raise concerns and interact with the help desk, and they'll get responses. So now we are in the era of AI, and now people are starting to think about how can we use AI to promote health communication. And this is actually from the WHO, where they have this, SARA, which is the Smart AI Resource Assistant for Health. And this is an AI platform where they have AI messaging. It's like chatting to a bot, and you can get information have conversation about anything you're thinking about, from health habits and all that. So we are seeing institutions like, WHO having such a platform shows that AI is still is getting its way into the health. And now we have, Kenya has the Kenya Artificial Intelligence Strategy, which was recently launched, providing a framework on how we can use AI to promote health as well within a particular framework. We have issues about AI. AI is relatively new. We have some reservation about it, and but it's gaining traction in health, so we're still trying to see. And this article tries to argue whether should we really use AI now in health, or should we not use? So, thank you very much. I think I've run out of time.
Maybe we can have a few, 2 quick questions. Professor?
Maybe not a question, but first to congratulate Patience for having this topic of health or science communication. I think it's one of the evolving field that is very new, and we have lost big time because we don't have many people in this field. In fact, now they have even expanded it. They talk of science communication and socialization of science and technology. One of the big losses in Kilifi, we lost the nuclear plant because of science communication was poor. And people, associated it with Hiroshima and Nagasaki, which is not the case. Nuclear science and technology, I sit in the high-level Human Resource Committee for Africa at Vienna, and we use it, Rays of Hope, that treats cancer. It's nuclear science and technology. It is a big project in Kenya, all over Africa, Rays of Hope. Atoms for Food, which is a FAO, uses nuclear science and technology. And energy is one of the use of nuclear science and technology. But we lost it big time to Siaya because probably they went to school earlier than us, and we don't have many people to communicate it. We lost a huge project for Kilifi. But we are not yet sure that we completely lost it, because Kilifi was the best girlfriend for nuclear science site in Kenya among the 3 sites. So we're still hopeful if Kiuka and others will help us bring it back by communicating the correct information about nuclear science and technology. Thank you very much. Moderator amepotea. Nimekuwa moderator. Nani mwingine ataka kuchangia?
Thank you, Daktari.
Presentation, though I will touch partly on the African Center for Global Health Security and the upcoming East Africa Regional Global Health Security Summit coming up next month from January 27th to 29th in Nairobi. But I will zero more into the Africa Global Health Security Academy. Okay, so colleagues, without meaning to bore you with stories, I am sure that we all experienced COVID-19, did we? I know you narrowly escaped Ebola. But I'm sure nobody in Africa can say that he escaped COVID-19. And you know, the experience of Ebola in 2014 and what happened during the COVID-19 issues from 2019 to some countries, up to even 2021 or even 2022, exposed Africa to a lot of vulnerabilities. We came to understand much more how unprepared we are as Africa to tackle health threats. And there's no doubt about it. Because if you see the way that Ebola was able to disrupt health systems, economic systems, communities, you need nobody to tell you that Africa, in Africa generally, we are not well prepared, especially for emergencies when it occurs. Therefore, countries began to think, regions began to meet, and conferences began to take place. That if this, and you can just imagine, if now we're in 2025, if this were 2029, with what has happened with USAID, with what has happened with CDC, with what is happening with our funding, and then you can imagine where we would have been by now. Therefore, one of the outcomes of those exposure to vulnerabilities of African continent to health threats was the issue of regions and the continent coming together. The first one that took place here was the East Africa Regional Global Health Security Summit, which took place when? Earlier this year, January this year in Mombasa. And at that summit, it was discussed issues concerning how to strengthen our public health sovereignty in Africa, especially in East Africa. The West Africa has got their own, was discussed. And then in January next year, the second summit will be coming up. Because at the summit of January this year, a number of issues were discussed. 4 pillars were identified as areas where Africa needs to come together to do what? To strengthen Africa's strength, Africa's security on issues that have to do with health. Do I need to go to school for this? So, now, these are just the 4 pillars. I will just, like I said, I will briefly touch on this. My other colleagues are online, Dr. Nzai and Dr. Linda from Africa CDC, because I will focus more on the academy. But one of the pillars that came out from that summit of this year was Africa's Global Health Security Exchange Summit. And then you can see that a number of other conferences and summits has taken place since then, including the one that took place in Rwanda this year, and even also the West Africa Regional Health Security. Because we need to come together as Africa. We have our neighbors here. I don't want you to mention the name. During the COVID era, you know what happened? They said there was no COVID in that country. Luckily for me, I was there. I didn't get COVID anyway. But, I mean, we need to come together as Africa to discuss and agree on how to tackle such issues through these kind of meetings, through plenaries, through summits. So Africa needs to come together, and that's one of the pillars that came out from that summit. Second is the Africa Global Health Security Academy, and that is where I belong to, because I work with AMREF as an adjunct in the academy. So this is where we need to talk about the health workforce. I liked one of the research studies that showed that nurses need to be mentored, they need to be trained, they need to be well paid, they need to be engaged. When I saw that, I said that this one is really talking about the academy. Because the academy talks more, and I'm going to delve further into that, about what? About the Africa health workforce. Then, of course, Africa Global Health Security Policy and Research, which is exactly what is happening here. But the only question I'm leaving for every one of us is, after this, so what next? Remember what the governor said yesterday, research data without implementation is what? History. We need to have the policy, we need to have the research, we need to have the data. But after that, we need to do what? Take it further. And then finally, the funding, the issue of funding. Like I said earlier, if this were 2019, you know what should be happening to Africa by now? Because one country has said, oh, we're not going to give money to you guys anymore. Does anyone know the country? You don't need to tell me in case you are going to apply for visa very soon. But the point remains that if a country elsewhere will say we're not giving money to Africa anymore to support your health programs or to support all your programs, then we're here shivering. Many of us have lost our jobs, and many more might still, including even in WHO. 21% staff cut in WHO. Why can't we in Africa as Africans do what? Generate our own resources. I'm happy that part of the discussions yesterday in the afternoon was about funding. So why the GHS Academy? Like I said, now I'm going further into the academy, proper. Why do we think the academy is important? And why is it a pillar that came out from the Regional Health Summit? Number one, an estimated 25% of global case burden occur in Africa, yet only 3% of the world health workforce work in Africa. So you can imagine the disproportion between our disease burden and the number of health workers that we have that work in Africa. In 2022 alone, about 4,000 institutions were able to produce only 255,000 health graduates, which is drastically inadequate to take care of our health needs. By 2030, WHO has already estimated that in its African region, there will be a shortage of 6.1 million health workforce, except we will continue to train and we continue to retain and we continue to build the capacities of healthcare workers. Consequently, the birth of Africa's Center for Global Health Security with an academy that is domiciled with AmRef International University. And you know why? I don't need to tell you more about AmRef, but just to re-emphasize once more. One, AmRef is deep-rooted in public health landscape in Africa. I mean, there's no doubt about this. This is not to say that other universities are not rooted in that, but we know that over decades, AmRef has been championing is a university that is modeled on applied and practical application with an edge on competency-based training, especially for health. If you ask me, permit me, I'm not being arrogant, but permit me to say that AmRef is the Pan-African University for Health Sciences. With due respect to all of you who have come from various very good universities, with very good medical and health schools, I am proud to say this about AmRef. Thank you. So what is the objective of the academy? The objective is to design a fit-for-purpose training. We have looked at what is happening across Africa, what is fit for what is happening. Instead of just giving students and graduates the same model training, the same theories, the same concept, the same models that have been developed over the years. This academy will look at what are the peculiarities of Africa and design trainings and courses and short courses and boot camps that will tailor to the needs. So that when graduates come out, they come out as graduates who are not only prepared for, but who also have hands-on, because most of the trainings will be experiential, and they will also target using African information, African data to solve African problems. So I now take us through one of the courses. Sorry. No, I want to go back. I want to go back. Yeah. Okay, thank you. So now, if you look at this, I wanted to take us through what we have for the academy. We have 4 main streams of courses. One is the boot camp, which is a 10-day course. The second one is Executive Africa GHS boot camp, which is equally 10 days. The third one is the master class, which will take about 10 weeks. And then the last one is the fellowship. Now, these are meant for different categories of audience. The first one, which is the GHS boot camp, is actually for subnational level, like where we are now. And this is meant to lay the foundation for you to probably participate in the fellowship. This is where we will discuss practically about the issues, for example, that affect Kilifi health. Like most of the research studies that I have listened to and participated in reviewing since yesterday, they will form part of what will become our boot camp, because they'll be tailored. The boot camp will be tailored to particular issues of the region, and that is what will be discussed by participants, and that is what will now form how to influence, how to impact, how to provide the necessary capacities for those who function at this level. But the master class, the executive master class, will be looking at industry leaders, manufacturers. And in this case, there is always a very limited relationship connection between industry practitioners and the academia. But we intend to bring them back again. Yes, they may have all gone through the universities, but the moment they get into the industry practice, I don't know when this gap usually starts, but there's always that disconnect. And there is need to bring them back, because the whole idea about the African Center for Global Health Security is to bring back the industry, the government, and academia into the triple helix, so that everyone can work together towards establishing and reinforcing African health sovereignty. Now, the third boot will be the African Global Health Security Master Class. And this will be the continental master class, where we'll bring not only policy leaders, but also innovators from across the continent to come together to talk, to look at the frameworks and policies that have to do with Africa global health security. And then, of course, the fellowship, which I encourage all of us to start from the foundation, and you get into the fellowship, which will now help you to do what? To become a real leader in public health practice. The same thing. Then, so I take the deep dive, which is the foundational, and then let's talk about this. So this will be a foundational training, and it will target subnational public health practitioners at the county levels like this. The duration is 2 weeks, and it will be delivered at AmRef International University. I don't know how many of you have visited our beautiful campus at Northlands. This will be a very good opportunity for you to come and see. Now, this will be a 2-week module, which will first of all start with the GHS fundamentals. And on this, we'll introduce you to the global health security framework. And then, of course, look at the international health regulations of WHO of 2005. Then we'll look at surveillance systems and early warnings, risk assessment, and health communication. And I'm glad that someone already presented something on health communication. This is where we can enlarge on that and also talk more generally about how these affect our health at the county level. In the second week, we'll now talk about the emergency preparedness and response. How do we prepare for emergencies? Every year we're taken unawares by cholera and by dengue and by other diseases that we know usually occur, perhaps by virtue of climate change. Yet, we're always taken unawares of this. And then we start running helter-skelter. How can we prepare better for emergencies in case they occur? And even if they don't, we lose nothing. But is it not always better to get prepared? So in the second week of our course, we're going to take you through that. How do we take laboratory samples? What do we use laboratory samples for? Now, this will help us to do what? To look through all this in the second week. This will be an interactive learning process. It will not be like the way we are now. It will be more of you and I talking to each other and looking at possibilities and exploring opportunities and options for strengthening Africa health security. So it will be more interaction, it will be more interactive, and it will be hands-on, and everyone will always have something to do. It's expected that at the end of the 2 weeks, you will have become stronger, your capacity will have been built better, and you'll be better off to do what? To advance the cause of African health security. And AmRef International University is not in this alone. Rather, we collaborate with Kenya Medical Research Institute, county health departments like Kilifi, Africa CDC, University of Nebraska, University of New Mexico. We're even already talking to Johns Hopkins University. So the more the merrier. We're not alone in this. And at the end of the day, there will be an assessment. In those days when I was younger, I usually avoid Friday lessons because there's always a test. I know some of us have what is called exam fever. There won't be an exam that you pass or fail, but there'll be need for us to test whether what we've discussed with you after 2 weeks can be put into practice. So there's going to be like a capstone assessment that will help us, country case studies that will help us to understand where we are with you. And that is very important. And at the end of the day, there will be a certificate that you can present anywhere in the whole world, because this will be more like an international certificate that will be endorsed and signed not only by AmRef, but also by all the other partners that you may have seen. These are the reasons why you have to join this program, and we can talk more about this in our booth, because I know I'm running out of time, even though I've been trying to ignore the timekeeper. Friends, colleagues, in a continent where the simplest health emergencies will disrupt our systems, there is need for us to continue to build the capacity of our frontline workers. Asante sana. So there are some colleagues are online who may also want to contribute. Dr. Nzai and Dr. Linda from Africa CDC. Thank you.
I think if Dr. Linda from Africa CDC is online, I would like to say a few words. Dr. Nzai first. Dr. Nzai, who is the CEO of Jumuiya. Chairman. maybe as chair comes on, Professor Chima, can I just ask you to get back on stage? If we have any questions about the academy, as Dr. Nzai, we can't hear you if you're talking. Any questions to Dr. Chima about the academy? We are quite excited. We had a meeting with the governor earlier on in the week, and we are planning to do quite a number of projects with them, and especially looking for more partners, so that some of you who are in this hall can get an opportunity to attend either the boot camps or the master classes in the coming year. Kilifi County aims to be the pilot for this at a subnational level, so we are quite excited about that. And we will cascade this to the department level so that we can get people who will be joining us. Questions, please. Yes.
Thank you, Daktari. Are there scholarships to your programs, or you can also just let us know what the cost is as well, so we can plan?
Okay, thank you. Well, there are scholarships. How do I put it? We are not offering direct scholarships, but like if you apply and probably you need like a backup letter or a supporting letter to help you process a scholarship from your partners or from your organizations, I think that will not be out of place. Yeah.
How much?
The how much is still being discussed, but it's not going to be expensive, I assure you of that.
Where can we access information once
Yeah,
it's out?
at our booth, we have a booth out here where you can even get flyers that will talk more, not only about the cost, but also about the other logistics and what you stand to enjoy. Because this is a place that will offer you learning and pleasure at the same time.
Maybe I can just give you 2 minutes to discuss about the upcoming summit. Is Dr. Nzai online? Dr. go ahead.
Yes, hear me okay now.
Hear me okay?
We are struggling to.
Okay, so. Let me try this. Can you hear me?
Yeah, that's better. Please go ahead.
Okay, Charles, sorry, I had to change devices here, but can you hear me okay?
Yes, we can.
Very good. So thank you, Dr. Chima and the team who is in there from yesterday up to today. My apologies, I had planned to come, but this was impossible. But nevertheless, I'm very, very happy to be with you virtually. With me, I see I'm joined by Linda. Linda is from the Africa CDC Eastern Region, which is headquartered in Nairobi. And also we have Professor Tamari. I think she's listening in, but she could also just say hello. So before I go, I know time is not on our side. Let me see if I could have maybe Professor Tamari go first, if she can, wherever you are, Professor Tamari, to chime in on what Dr. Chima has mentioned in terms of the programs and anything else you can add on into, and then Linda can say a few words and then I can finish. Professor Tamari.
Hi, everyone. I hope you can hear me. Yeah, thank you, Dr. Chima, and thank you, the Kilifi team, for inviting us to the Kilifi Symposium. I think it has been really great. Thank you, Dr. Chima, for making a great presentation.
Linda, Africa. Linda, Africa CDC.
Hello, thank you very much. I'm not in such, hope you can hear me clearly.
Yes, loud and clear. Proceed, please.
Okay, thank you very much. The Africa CDC, which is your Africa CDC, part of the Health Security Agency of the Africa Union, is excited to be part of this global health security activity that is being headed by AMREF International. As Professor Tamari has said, when we talk about the new public health order, which has been even strengthened by a strategy that looks at health sovereignty of health security in the continent. And one of the fuels that will ensure that this happens in the continent is through the healthcare workforce. And we're looking forward to hosting the East Africa Global Health Security Summit in January, where all these discussions will come to play, where we're looking at how to catalyze, especially local manufacturing, that will ensure that this will be the second independence of Africa, and glad to be working with all the teams. And also for the fellowship, Africa CDC will be one of the places where the fellows will be pleased to be able to work within the continent. Thank you, and over.
Thank you, Linda. So, team, I don't know how much time, Charles, we have, but let me wrap it up. There was one also of a colleague, the Executive Director of Africa Center for Global Health Security, Dr. Asma. I think she has a recording, which hopefully Charles and Dr. Chima, you could probably play it at the end so that you could also hear her voice. In a very, very short format, I'm very, very proud of this conversation, and especially the scientific conference that you have in my home county, Kilifi. I'm also the CEO of Jumuiya County Zapwani, and probably most of you in the audience, we know each other. So this makes me very, very proud that Kilifi could host this in a very timely moment as a pre-summit to the second Eastern Africa Global Health Security Summit, which is to be held on 27, 28, 29th at Safari Park. This summit, the first one, was to be held at Pwani University in January this year. And then we had to move it to Mombasa because of logistics issues. But the point around that is this initiative that we are talking about has the home roots of Kilifi County in many, many ways. And the reason for that is it was really inspired by what we experienced in Kilifi County during the COVID time and as Jumuiya County Zapwani. We were able to manage the COVID pandemic in a little more structured way than other counties who could have probably managed. And I think that was a combination of one, our regional cooperation between the 6 county governments, departments of health, the county executive, the medical directors, the chief officers, and the governors themselves. So that by itself was a big lesson that we learned, that we need to cooperate. And you all know that the borders of the region, starting from Taita Taveta at one end, Tana River and Lamu on the other end, and then also the open seas, we were the most vulnerable. You mix that with the port and the whole corridor from the Mombasa port to DRC, we remained, I think, what we defined to be the pandemic node of East Africa at that time. 2 people were really involved in this process. One, Dr. Asma, who is now our lead at the Africa Center for Global Health Security. At that time, she was working for the World Health Organization in Somalia. She is from Mombasa, came down, mixed with Dr. Anissa, who was the CC of Health in Kilifi, and we managed, in partnership with Pwani University and Cambridge, for us to conduct training for the 6 counties, for them to be able to think together, to think in uniform, and also to basically simply share and manage this pandemic. So through that, we were able to actually move still together until today. There is more collaboration with the county executive, my good friend Peter Mwarogo, and all the other county executives who are there for us to be working together as one region with the same shared problems of health security and vulnerabilities on that matter. So through this experience, the good news out of this conversation was for us to also bring to you now that we have managed to form the Africa Center for Global Health Security as progression from there, which is to be a collaborative catalyst of governments, industry, and academia towards health security in Africa. And through that, then, we have followed the triple helix model, which we have been applying at the Vision 2030 with success. And even the Jumuiya County Zapwani itself, where through Africa CDC, Eastern region, with 14 member countries, that's representative of government, and then the industry, which we know, Kilifi yourself, you have the like of Revital, which is, we're very proud of them as a local manufacturing facility that we have locally, and international station from there. And I know they're part of this conversation, as well as now the other pharmaceuticals which are in the coastal region, the hospitals which we have, which are big spaces for medical tourism, the like of Aga Khan, Mombasa Hospital, and the facilities that we have in the region. And then academia, Pwani University, we've worked quite a bit for them to be fully involved, especially now with their thinking of a medical school. Of course, then the Coast General Hospital with its medical training center, and then all the other, some other universities, as Dr. Chima has mentioned. So what does this all mean to us? As one Kilifi County, the region, and also then all the 47 counties in the country, if I may wear my Vision 2030 hat, it means that Kenya at this point, we are all very much aligned and prepared to be Africa's global health security hub, leading global health security hub, because we have everything that we need for us to put us at that level. We have the Africa CDC, we have the World Health Organization stationed in Nairobi, the operations that they're running. We also have the United Nations, and that's a whole huge system, especially when we talk about One Health. We have some of the leading universities, but more important and very uniquely placed is what Dr. Chima has been rightly bragging about, AMREF, the AMREF Africa institution, which has a global footprint and has been leading health security, primary health care in Africa. And now the new arm that they have in the academia of AMREF International University. So we have an opportunity for our region, for us to be a pilot, especially in this bootcamp. A question was asked how much it costs for that bootcamp for those 10 days. My understanding, Dr. Chima, is 1,850, I believe, for each bootcamp participant. And the idea around that is for it to probably work with the county governments to probably pay for partly of it, and then we also look for some scholarship wherever available, especially at the summit. So the call around that is one, for Kilifi itself to have a few, and I call on this conference, especially my good friend Charles, who is there. Maybe you could offer some scholarships for these, at least a number of your people. A good 6-10 of them would be good. For them to be the first line in terms of participating. And then also we'll have similar conversations with the county governors to get some from the 6 counties. But I'm very particular that my own regional economic bloc becomes the first in line for us to create this global health security champions who can think globally, but also then be able to implement locally at the county level. Now, especially that health is a devolved function. I think, from there, we also would want, as part of this program in the bootcamp, the first actually lesson will be at the summit itself. So the idea is for you to be able to participate at the summit as a delegate, as a special delegate for that matter, on the 27th, 28th, 29th in Nairobi. So Charles and team there, we want some very good representation from the county government of Kilifi, and more so, all of you who are there, it would be good for you to be able to participate.
Thank you very much.
I think I do not want to go, I don't want to go further probably than that. I hear a voice which may be stopping me, but I thank you so much and I yield to you. Thank you so much.
Thank you very much, Dr. Nzai. This is Charles stopping you. A big hand to the Eastern African Global Health Security team. And we are having quite a number of conversations. Like rightly said, we'll be looking inwardly and outwardly to try and sponsor a few of you who are in this room to attend the summit itself and eventually the boot camp. And we will be communicating that through the departments. Allow me to now ask you to stand up and stretch. I know you've been seated after a very nice meal. Just briefly stretch. Yeah, it's good and therapeutic. Have a seat. Now have a seat. That marks the interlude between the end of the presentations and the start of the closing ceremony of the symposium. A big hand to all of you who have presented today and yesterday, tafadhali. And I want us to give Nancy, Dr. Nancy Mongome, a big hand because she's done a wonderful job in helping us keep time and ringing the bell. And before I invite some few people who are going to make a few reflections on behalf of both governments, both national and county government, allow me to invite my good friend, Professor Shauri, to make a few reflections. We started off with reflections from the research side, which is KEMRI, and want to conclude with some few reflections from Pwani University, from Professor Shauri. Karibu sana.
Thank you very much, Charles. Good afternoon. Mko sawa? Mko chonjo? Mumesoma? Mko tayari kutekeleza mliosoma? Thank you very much. It gives me a humble pleasure to make brief remarks in terms of how we want the world to go. The world now is talking about data, and data is research. And out of research, we are not even satisfied at that particular point. We want to talk about R2C, research to commercialization. We've been doing a lot of research and publishing, but we are asking ourselves that some of the things we are publishing, actually we are giving away fodder in terms of innovations to other people. So the new mantra now is to do your research, protect, and publish. You must protect your IP in your research, and you must find the reason why you did that research, because there is a problem and you want to come up with a solution to that particular problem. So the solution must also give you money in the pocket. So you must not think of just research and publishing and doing research in Kilifi, for example, and going to present in Rwanda to people who even don't understand Ganze or Mwarakaya, so that you can be able to say, yes, I've made an impact. The critical question now that we ask for all types of research, including health research, we ask impact to who? Impact in an international journal? How many people will read that particular insightful research? Impact to the donor, because they have given you money and they want you to publish in Lancet or in Nature. And people are asking, why pay 700,000 Kenya shillings or $1 million to publish in Nature? And then you leave the people where you did the research, where you collected data, the same way you found them. So we need to ask ourselves this difficult question as Africa, not only as Kilifi, as Kenya, when we are doing research to solve our problems in healthcare, in all other fields, we must be able to know that the research must be able first to benefit ourselves so that we can be able now to sell the benefits to other people. I want to appreciate very much Kilifi County Government, the Department of Health, for organizing all this, for assembling all these, professionals, practitioners, intellectuals, to come and be able to share with us what they have shared with us. It's a lot of information. It is just yesterday, but when you look at the program, it's information that probably is equivalent to a postdoc. If you have been able to listen and understood all the presentation, we need to ask Charles to be able to give you a postdoc certification. Because it's too much information. But it is good because the world now is led by information. If you don't know, then there's nothing that you can be able to push forward. And that's the reason why probably we have AI. There's too much information for us to use and push forward. And I love the architecture of this symposium because the architecture of this symposium has been inclusive and has embraced the nascent conversation in terms of transdisciplinarity of the way we do research, the way we do things, involving everyone, including those ones who are coming from the community, be able to co-create, be able to talk about innovation, be able to borrow about best practices from other places so that we can be able to make our lives better. As I said yesterday, for me, my passionate conversation would be, I don't want to be sick. In as much as we are saying sustaining, universal health coverage, I don't want to reach there. I want always to be up and running. I don't want to be sick. And therefore, there are some of the critical things that we normally forget. Especially when we talk about health promotion, we take it not very seriously because we think it is just information that is taught in a classroom for you to pass an exam. When they say balanced diet, it really means balanced diet. There is no way you can eat ugali a half a kilogram and porridge and say you have taken a balanced diet. You must be able to know that that balanced diet you read in school, in high school, in the university, it is really balanced diet and you have to practice. When they say you have to exercise, it is really means you have to exercise. If they really say you have to eat nutritionally, rich food, you have to do that so that you don't go to hospital. Why should you go to hospital? Why should you swallow drugs? If you are swallowing already because you have not following your basic education of promotion and prevention, then it becomes critical. Sometimes I even say, I want to brag like Chima. Where is Chima? I want to brag like Chima. I say, I'm a sociologist, and I always say, sociology is the only discipline, the others are tools. Yeah, we are the one who understand society. We understand human behavior. We understand what the human problems are. You guys come and fix the human problems. You're just tools. Mnakuja kutusaidia communication, mnakuja kutusaidia medical science because I don't want to, feel bad. I want to be happy and enjoy. People enjoy all the time when they eat, when they sleep. I don't want to feel bad. So the others are tools to fix. Physics is a tool. Chemistry is a tool. Mathematics is a tool for me to be able to count my money. Veterinary for me to be able to take care of my animals. Those animals belong to people, including money in the bank belongs to people. The money in the bank that you always go there and do your ATM belongs to people. So it is important for us all to address the needs of the population. And one thing that I have to finish with is that it is possible to fix some of these problems without even struggling with one component of health financing. We can reduce the health financing if we embrace promotion and prevention. We normally are very reductionist, Plasmodium and malaria. Cambridge has done a lot of research on that. Plasmodium and malaria, that is a very small reality. We need to go back and see what brings plasmodium, the mosquito. So what do we deal with this mosquito so that it doesn't bring plasmodium? They are not interested in that. They're interested in the mosquito biting you, giving you plasmodium, malaria. A lot of research, a lot of millions of money. Why can't you make the mosquito not to bite me so that I can be sick? Why are you happy to make me sick so that you can be able to say now you are running vehicles, Cambry, welcome to us. We must be able to handle the causal agent. And this is a societal issue. If you are rich, you are contributing to malaria because you are eating blue band and you are throwing the blue band cans and they collect water, mosquito breed. So stop doing that. If you are poor, you cannot be able to have mosquito nets. County government, please give people mosquito nets so that they are not bitten by mosquitoes. By the way, as we have artificial intelligence, even the mosquitoes are becoming very intelligent. Because they know Cambridge is providing treated mosquito nets. They bite you before you go into the net. Very intelligent. Probably they also have access to AI. So it is important that we invest in those things that actually promote health and involve in those things that actually prevent ill health. For example, one of the critical problems that can cut almost 70% of the diseases in Kilifi and elsewhere is water. If you don't have water, recipe to problems. Because you use the toilet, you have your pathogens, and you start eating your apple. You shake my hand. Sometimes I refuse. I look at you and say, you want to shake my hand? What was your hand doing? So if we can be able to provide clean water to the population, already we cut almost 60-70% of the disease problems that we have. If we reduce that, you don't need to start struggling with the coverage because the fewer people will be coming there. You don't have to struggle with putting a lot of state-of-the-art equipment. It will go down. By the way, health is big business for companies because they want you to get sick. They don't want to invest in prevention and promotion so that you can buy their drugs and their equipment. So the more you are sick, they are happy. When they present the data here, they say data, data. When they say some people have cholera, they are happy. They say several people have cancer, they are happy because they will sell their innovations. So we must wake up and invest in the very small things that can be able to improve our health. We must provide our people with water. With water then, they can even start doing agriculture. With agriculture then, they can feed themselves. With agriculture then, they can produce more because they can irrigate, they can sell, they have money in the pocket. So what is the priority? When we were learning, we were told, basic needs. Say food, water, shelter. Some of you here dressed very well, the clothing, you hide. You hide and you're hungry. This is one of the big spenders here at the Coast region. You see a wedding, some ladies are dressing a dress of 30,000, 50,000. But you look back, tomorrow they are sick, they are opening an M-Pesa, you contribute. Because there is missed priority in terms of what comes first and what comes after that. So colleagues, I urge you to embrace the new definition of health, and it is very clear, the new definition of health as a multifaceted of components. It is about the physical health, so you must exercise. It is about spiritual health. You must go to church and pray, or to the forest. If you don't believe in Jesus, you can go to the forest and pray there. You must be able to have emotional health. You must see someone and also, close one of your eye and say, hey, I feel nice inside here. Chima, you must feel inside. If you don't feel nice inside here, you have a problem. You are sick. You are sick, and sometimes there are no machines to correct that emotional part of you. Mental health, you must be able to engage in something that can be able to do something with your mental health, whether you are going to dance, you're going to sing, you are going to do mental whatever, but you need to also engage your mental aspects. At the end of the day, your well-being, very important. So health is not only going to the hospital. The hospital is a garage. Someone, Dr. Tofa said yesterday, it is a garage. Where do you want to go to a garage? And all of you are happy going to a garage. And you queue waiting for the mechanics to fix your brakes. Hello? the responsibility is with ourselves. We take responsibility. We also pass this information to others so that they can be able to do something and be able to change things in a very slow way and in a very progressive way. With those many remarks, I think I challenged the CEC Health yesterday. Next symposium, number 4, should be on how we should not get sick. Why should we discuss sickness? Why do you want me in the ward? Why do you want me, inject me with those things, painful things? You prick me with things. So next time we come here and discuss how do we remain healthy or how do we not visit a hospital. I'll be very happy to join and to present a paper. Thank you very much, Charles.
Thank you very much. A better hand to Professor Ali Mushauri, Deputy Vice Chancellor of Research and Extension at Pwani University. Now in the morning you saw someone who used to do my assignment. He's the one who used to give me the assignment at Pwani. That's full circle now. I am being told that at our very peak we had almost 350 people roaming around these grounds. I think that is one of our highest after the first and the second. A big hand to all of you. Over the years, congratulations to the Secretariat. It has become bigger and better. Right now, allow me to pass some apologies on behalf of the Executive Office of the Governor. The Governor is currently giving the State of the County address at the County Assembly, and the Deputy Governor is in State House for the National County Coordinating Summit. And I want to invite Dr. Hassan Lely, the Director of Health Services, to make a few remarks on behalf of the department, and later on invite the Ministry of Health, who have been with us over the next 2 days, and officially close the symposium. Dr. Hassan.
Good evening, everybody. Quite a big hat to wear, but I just speak on behalf of the department. As a department, we are very, first of all, extend our sincerest appreciation for planning with us, joining us, and as we sit here closing this particular event. I will not say it's an event, but science is a continuous journey. It has, over the years, created significant impact. And as a county government, we really take pride, not only being participating, hosting, but also implementing. There are quite a number of innovations that have been implemented in Kilifi County, and we will continue to welcome and create habitable environment to do health research and also translate it into impactful interventions that improve the lives of our people in this great Kilifi County. Again, appreciation to the planning committee. I don't know if you're here, just stand, just to appreciate you. Charles, Rogers, Kazungu, Nancy. Please, thank you, thank you, thank you. We've been doing it's been quite a journey. Dr. Marianne, Professor Malin, a lot of people to mention, but it's been a journey, and I'm glad that it's been quite a successful one. I've seen people seated, towards the end of an event you see people, the crowd's thin, but people have been sitting and listening. So I'm more confident that it's been a quite impactful one. Also, just special appreciation to our former CEC, Dr. Karisa Dadu. Dr. Dadu joined the department. He was an architect in planning, but the impact of health, I think, is here today. It shows the impact that once you join this ecosystem, it's quite exciting, and you want to be here and make an impact. So as a department, I think I say again, it's been a very good journey, and we affirm our commitment to also improve the capacity of our health workers. And I'm glad our health workers have been making presentations outside in posters and oral presentations. So I'll be crossing my fingers, and I'll be more happy to hear if one of us wins an award in the evening. Sorry, I'm being biased, but that is just a show of the growing capacity, and also the involvement of us to really also play a part. The good work that we do also translate into impactful research. So as a department, we are really appreciative, and we look forward now to the fourth, as Professor Shauri has said, why we should talk about preventing getting sickness, and that is the truth. Preventive and promotive health is the key. And this comes with evidence, and the evidence is showing, the research is showing that once you put more resources into preventive and promotive healthcare, the outcome of population is improved. So even us as a department, that is the song that we sing. Of course, we must balance as for us in terms of provision of care and in terms of curative and rehabilitative. So it's a tussle, but our commitment still stands as a department and as a county government in terms of the well-being of our people. So research is a vital tool, and for us, we are using it quite effectively. And of course, over time, it should be improving the lives of our people. So us as a department, again, thank you everybody joining here physically, and for those who are also joining virtually via the link that we've been sharing. Appreciation so much from the leadership of the county government, and we are looking forward to the next symposium, and I'm hoping the numbers are going to even be bigger. So for us to say thank you, and of course the Ministry of Health, the participation by Dr. Kandie, he'll be making remarks, is a very, very, very good partner in terms of delivery of services to the country, to the county and the country. So again, I say thank you and be blessed as you live here. And of course, we're looking forward to host you for the gala dinner, where we'll be now giving awards, appreciation the county health facilities, workers, and of course, the presenters who have been here with us. So thank you again, and be blessed. So allow me to invite Dr. Kandie, who will be making the closing remarks on behalf of the Ministry of Health, on behalf of the PS, Dr. Oluga. So karibu sana daktari, and a pleasure to be here. Thank you so much for the support.
Okay, thank you very much. A round of applause for the county official. Okay. All protocol, I want to ride on the protocol already established. Fellow delegates, ladies and gentlemen, hamjambo. Habari za jioni. When I come to Coast, I normally worry that have I made the greetings appropriate? Because there's one time we used to come to this area, so as we go out and sometimes you get lost, and then you come and come back and tell those people, hii njia yaenda wapi? And then they wanakuangalia na kusema hii njia haiendi. Salamu hauna. Ukienda ungekutusalamia kwanza, ndio ukirudi tunakwambia basi umepotea, nenda njia lile lingine. So I'm very grateful. So ndio nimesema mpo. Okay, asante sana. So I'm very grateful. Let me take this opportunity to thank the county government of Kilifi for doing this 2-day workshop or symposium, so that we can reflect and do what we call soul searching for the sector. Where are we doing well? What do we need to do? And not only looking at health sector alone, but looking at other sectors. Like I can see professor from the academia. We can see, we had something around rivers, although I know you have been in the health sector. When I looked at your credentials, Dadu, you actually are an architect. And I said that health sector needs to embrace. If you look at other industries, like the banking, they take our best doctors to be bankers. Why don't you also borrow other sectors so that they can remove this inbreeding? We have inbred in the sector so much that we need to have other people give us ideas on how we can improve. And that's why it resonates with today's theme on how do we do research, innovate, and then we look at the best practices. So this 2-day event has been very useful, and I believe from the Ministry of Health, we will support how we move on. We will see how do we, what do we do. So I've been sitting in and the rich ideas that have come in, the beautiful papers you guys have presented, we need to applaud everybody here. So sijui tutafanya na njia gani. So a rouse of applause to all those who have been presenting the Okay, asante sana. So, and I like to thank the people who have been who have been presenting. Wale walikuwa wanaonyesha torch hizi mbili. Thank you very much. You've really done perfect. It was seamless. So the reflections of today has been ably done, and I don't need to repeat that. So what I want to say is, what is our takeaway, especially on issues around research? Health sector, tunangojea mpaka we are very reactive. What can we do to be proactive? We need to start anticipating things. Let's look at this research agenda. And I want to ask academia, hizi research mnefanya, hizi students wanafanya, kwa nini can we have a database so that we can pick and see what we can begin improving? Not tomorrow, but right away, so that we can. So I'm giving our colleagues, let's see how we can be interacting. So research needs to meet. We meet at the theater of action when we are doing that. The second one is on issues around best practices. We need now to spread. Yesterday we were talking, one of our the openings, the speaker who talked about pilotitis. We are not talking about pilotitis, but we can say we have got 47 counties in Kenya, and each county, I look at it as a laboratory for experiment or doing something. So let's start, and then we spread. Whoever comes with the best practice, other counties can borrow. So that is another area we can look for. So let's so I'd like to, we need to start working. So from Monday, are we going to do something? Hizi presentations ambazo tumezifanya leo, tunataka kuona action. Action si mwaka ujao. Action ni kutoka from now on. So let's see how we can work on that. I don't know how, we need to radicalize you to start reflecting on what we can do best for this country, especially when it comes to health matters. So arising from that, because I don't know whether I was representing the PS medical services, but on his behalf, he may not have been able to come, but I would like to give his thanks for the invitation. And whatever innovations that you are coming up with, we shall come up with a national mechanism so that we can roll it to other counties and come up with a piece of either legislation or come up with guidelines so that we standardize it so that it becomes the way to do when we are when we are doing in this sector. So with those few remarks, I would like to, it's my pleasure now to close this meeting on sustaining universal health coverage, innovation, research, and best practices, and the biannual health scientific symposium close. Thank you very much.
A better hand to the ministry. Indeed, you are representing the peers who would have liked to be here, but has competing engagements at State House as well. Allow me to invite Kazungu to do a vote of thanks to everyone, after which I will then call some few people on the stage to take some photos.
Thank you so much, Charles. Can we all stand up, please? You'll help me do this. Sawa sawa. So, I won't talk a lot, but we will do a lot, isn't it? So, this is a vote of thanks to everyone. So, on behalf of the organizing committee, we take this opportunity to express our sincere gratitude to everyone who has contributed to the success of this third Kilifi Scientific Symposium. So, there are so many players. So you'll agree with me. What do you call this? Inaitwaje hii? Hamunioni, I'm very tall. I'm tempted to stand here. Tunaitaje hii? What do you call this? Do you know ina kazi yake? Okay, so we will do a jig, eh? Asante sa, you will repeat with me, okay? So this one is on behalf of our governor, okay? For gracing this symposium. So it will go like this to him. He's not with us today, but he was here in person yesterday, isn't it? So we will do to him like this. Asante sana kwa kazi nzuri uliyofanya. Asante. Remember, it is for the governor. Eh? He's not here. Mimi naona ako hapa. Say he sat here. So let's go together, everyone to sing and dance. Especially to the ladies. I'll be watching. So let's go for the governor. Asante sana kwa kazi nzuri uliyofanya. Asante. Okay, atakayofanya. He has done and he will do. Sindio? So let's go. Asante sana kwa kazi nzuri utakayofanya. Asante. That is for the governor. Let's go to our keynote speakers and presenters. They have really shared their knowledge to us, isn't it? So let's go. Waliofanya na utakayofanya. To who? Our keynote speakers and presenters. Okay. So they are plural, ni wengi, si ndio? Haya, twende. Asante sana kwa kazi nzuri mliofanya. Asante. Okay, watakayofanya, Okay, let's go. Asante sana kwa kazi nzuri mtakayofanya. Asante. Msichoke. To our partners and sponsors and stakeholders. Do you agree with me that they are very important? Okay, let's go. Sana kwa kazi nzuri mliofanya. Asante. Future, we want more money, eh? We don't want to be to be Trumpinized. Whatever the case. Okay, let's go. Asante sana kwa kazi nzuri mtakayofanya. Asante. The ladies are not doing the... Okay, let's go to for the organizing committee and secretariat. Kwa kazi nzuri mliofanya. Asante. We still have a fourth one, okay? This was third scientific symposium. For the fourth, asante sana kwa kazi nzuri mtakayofanya. Asante. So to all participants. Now, turn to your neighbor. Turn to your neighbor. So instead of you doing this, you do like this, okay? Instead of you doing this, you do like this. Okay, let's go. Hello. Hii ni yetu sote sasa. Huh? We do it louder. Okay, let's go. Asante sana kwa kazi nzuri uliyofanya. Asante. Let's go again. Asante sana kwa kazi nzuri tutakayofanya. Asante. Very good. Hiyo imetosha. The ladies, I didn't see the ladies dance. Na yangu je? By the way, kuna mtu, someone said, there is a very learned fellow amongst us who said he doesn't want to die. Mlimsikia? Mosquito bites. What else? Diarrhea. Shindwe kabisa, si ndio? Okay, thank you so much.
So as we conclude, we are confident that the knowledge shared here will translate into action, innovation, and improved practice. Thank you very much for participating. We love you. Sawa, asanteni sana. So, back to you, sir. Hey, nimesahau huyu mdosi. No dancing, okay. Thank you very much. Can I ask the organizing committee to please come here for a group photo, joined by Professor Shauri from Pwani, Dr. Sophie from Kemri. Please do join us. Dr. Kandie, Professor Chima. We have to remove this. All the entire secretariat for the 3rd County Biennial Health Scientific Symposium. So we'll stand here so that we include the rest. Down there. Then you face front. Then he will take and include you, Owen. So you can include the rest. Thank you very much. The stage is now open for anyone else who wants to take a photo. And tea is served, tea and coffee is served. Tafadhali, tea and coffee is served.
Na safari hii ma MC na waombea dua, nikiwa hit kwa industry nikimanuva kama mvua na nyesha mahewa, nikileta wako wengi lakini sovya sambeta. Brother kamata, sister kata, kiuno kwa mdundo na huu ndio mtindo. Pole pole, twazienda, haraka haraka haina baraka.
Hello. Hello, hello. Dinner is by voucher, kindly. Dinner is for the invited.
Rasta Kiwelu, thank you for the tip. Thank you so much.
Hebu tathmini kisha nipe jibu. Hivi kwa nini hutaki kunijibu? Mitihani yote nimeshinda.